Hello everyone, good evening to all of you. Very happy to see you all join today and we've been sprinting, right? हम लोग एक sprint कर रहे हैं, एक दौड़ लगा रहे हैं and we've been doing a lot of things regarding many subjects. हम लोग जल्दी बहुत सारी चीजें खत्म कर रहे हैं and today also I know you guys must be tired by now. You've already sprinted up and finished a lot of things in forensics. You've finished about dermatology and my segment is the last segment for today. I'll complete the whole of ENT today with you. तो हम लोग क्या करेंगे? We'll finish ear, we'll finish nose, we'll finish oral cavity pharynx, we'll finish the larynx. तो अब पूरी की पूरी sprint इसीलिए बनाई गई है so that you don't have any question out of what I do today, out of what I'm doing with you. It will be a discussion. I've already given you a workbook which has everything. उस workbook में सब कुछ लिखा हुआ है line by line, but we are going to make sure कि हम साथ में वो points cover करें. We take out all the important points, we discuss them, and at the same point of time, I want you all to be very active so that it turns out to be a very fruitful session to all of you. Okay, so welcome you all. Thank you for joining, and we will straight away start into what exactly is this marathon all about, ENT. बिल्कुल ठीक हूँ हर्षित. Hello everyone. कैसे हैं आप सब? So I hope you guys are ready. I hope you guys are charged up and ready for NEET PG as well. इसको we will crack it down in today's time itself. चलो. So let's begin. So start कहाँ से करेंगे? In ENT, everything starts from ear. We will start from ear, right? The most important question that is asked to you in ear or otology every year, coming year, is embryology. तो सबसे पहले embryology देख लेते हैं, right? So where does the pinna develop from? Pinna develops from, you can remember the rule of 6. Pinna एक 6 की तरह लगता है, तो you can actually tell that it is a rule of 6. That means our pinna is developed from 6 tubercles of his at 6 weeks of gestation. 6 weeks of gestation पे 6 tubercles of his fuse करते हैं in order to form the whole of pinna. So you can see these are the 6 tubercles of his which have joined together to form the whole of the pinna. Now very important point is the first tubercle forms our tragus and the rest, second to 6 tubercles form the rest of the pinna. So first tubercle से tragus बनता है, rest all the tubercles form the rest of the pinna. If there is failure of fusion between the first and second tubercle, अगर ये first और second tubercle fuse नहीं करा, then there will be a defect in front of the auricle and we call that defect as preauricular sinus. So what is preauricular sinus? It is a sinus opening which is present because of a failure of fusion between the first as well as the second tubercle of his, or we can also say the first and the second pharyngeal arch. ठीक है? Fine? चलो. This finishes about what is the rule of 6 and how does the pinna develop. अब straightforward आते हैं. How does the external auditory canal develop? How does the eustachian tube develop? What is the formation of the ossicles and the tympanic cavity? So all our ear is formed from first and second pharyngeal arch. First pharyngeal arch बना लेते हैं. Then we form the second pharyngeal arch. Now we know that each pharyngeal arch has got an ectodermal side and endodermal side. So this is ectodermal side, this is endodermal side, and in the center there is mesoderm. The ectodermal side is basically the one which forms cleft. So ये हो गया pharyngeal cleft, and the endodermal side forms something called as pharyngeal pouch, which is between the first and the second arch, right? Now, if I ask you what is the external auditory canal developed from? External auditory canal is developed from first pharyngeal cleft. First pharyngeal cleft forms external auditory canal. First pharyngeal pouch will form eustachian tube and tympanic cavity. The eustachian tube and tympanic cavity are formed from first pharyngeal pouch. First pharyngeal cleft gives rise to external auditory canal. Okay? अब इसके बीच में क्या है? What is there inside it? You've got ossicles, right? So you have got 3 ossicles which are malleus, incus and stapes. बहुत important question आता है. Malleus कहाँ से develop होती है? Stapes कहाँ से develop होती है? Incus कहाँ से develop होती है? So how we can understand is that the malleus and the incus both are derivatives of first pharyngeal arch. ये दोनों ossicles first pharyngeal arch से derive होती हैं. Stapes की ऊपर का part, the suprastructure of the stapes is derived from second pharyngeal arch. But the foot plate of stapes is derived from otic capsule. So many of the times they will ask you foot plate of the stapes is derived from, you have to tell about otic capsule. ऊपर का part of stapes is developed from, it is from second pharyngeal arch. Rest malleus is incus, it is from first pharyngeal arch. Okay, fine. What is the joint between the incus and malleus called as? इस जॉइंट को बोलते हैं इंक्यूडोमैलियल जॉइंट. इंक्यूडोमैलियल जॉइंट इज अ टाइप ऑफ सैडल वैरायटी ऑफ साइनोवियल जॉइंट. वेरी इंपॉर्टेंट क्वेश्चन. इंक्यूडोमैलियल जॉइंट कौन सी वैरायटी होता है? इट इज सैडल वैरायटी. What is this joint? This is incudostapedial joint. What variety of joint is incudostapedial joint? It is ball and socket joint. This is ball and socket joint. Okay, fine. This finishes about in general things about what you need to know as far as embryology is concerned, right? Okay. Now we move to the nerve supply of pinna. अब इसमें important क्या question आते हैं? You have already seen that this is the nerve supply of the lateral surface of pinna. This is for the medial surface of the pinna. एक पीछे की है, एक आगे की है, right? The greater part of the pinna is supplied by the greater auricular nerve. Greater auricular nerve किसकी branch होती है? It is a branch of C2 and C3 cervical plexus. C2 and C3 cervical plexus से आती है greater auricular nerve. That is why if the patient has got any kind of cervical issues like cervical spondylitis, cervical spondylosis, then in those cases there will be greater auricular nerve refertotalgia. कोई भी चीज होगी that will irritate the cervical plexus and it will cause refertotalgia. Okay. Now we come to what is the front part of the pinna being supplied by? It is supplied by the auriculotemporal nerve, which is a branch of V3 division of trigeminal nerve. अब एक चीज हमेशा याद रखनी है, if they tell you that there is a person who has got a mandible swelling or if there is tongue ulcer and there is refertotalgia to the ear, always remember mandible, tongue, ये सारा oral cavity का pain is carried by the trigeminal nerve. So always remember that refertotalgia which they are talking about because of any oral lesion, that will be basically carried by the auriculotemporal nerve as refertotalgia. Okay. Now in the center you can see two things, facial and vagus. What is the branch of the vagus nerve which supplies the auricle? The auricular branch of vagus nerve is given the name as Arnold's nerve. Arnold's nerve. Okay, fine. उसी तरीके से the back part of your pinna is supplied by on top the lesser occipital nerve, which is a branch of C2 division of the cervical plexus. ये एक बार पूछा गया है. Okay, fine. चलो, so this finishes about the major part of what you require. Two questions important इसमें आते हैं. What is the auricular branch of vagus called as? It is called as Arnold's nerve. What is the auricular branch of glossopharyngeal nerve called as? It is called as Jacobson's nerve. Auricular branch of glossopharyngeal nerve is called as Jacobson's nerve. Okay, fine. चलो आगे बढ़ते हैं. Now we move into external auditory canal. External auditory canal, we know that it is S-shaped. सीधी नहीं होती, it is S-shaped. That means our external auditory canal is directed forward, downward and medially. Forward, downward, medially. This is the direction, that is why it forms like an S. Okay. Now inside this external auditory canal, what they have asked as question, which is the narrowest part of the external auditory canal? It is a junction between the bone and the cartilage and that is given the name as isthmus. Isthmus is the narrowest area of the external auditory canal. Which is the most common area for foreign body lodgement in the external auditory canal? It is also the isthmus because it is the narrowest area. Okay. There are two deficiencies which are present in external auditory canal. एक deficiency अगर वो बोलेंगे that there is a deficiency in the anterior inferior part of cartilaginous canal, they are called as fissures of Santorini. Cartilaginous canal में deficiency को fissures of Santorini कहते हैं. Bony canal में deficiency को foramen of Hashki कहते हैं. This is something that you should remember. And these are the potential sites for cross infections between the mastoid, parotid gland and the temporomandibular joint. Okay, fine. This is all what you know, what you should know as far as external auditory canal is concerned. अब आगे बढ़ते हैं. Whenever I tell you how to identify the tympanic membrane, always remember a very simple logic. अपना हाथ लो and tilt it towards the right. If your tympanic membrane is tilted towards the right, that means it is a right-sided tympanic membrane. अगर आपका tympanic membrane left की तरफ tilted है, that means it is left-sided tympanic membrane. यानी कि the side towards which the tympanic membrane is tilted, that side will be the side of the tympanic membrane. ये हो गई right side की because it is tilted towards the right. Now, the area towards which it is tilted, मतलब ये इस तरफ tilted है, मतलब ये side will be anterior side, opposite side will be posterior side. This is one way of identifying the canal about the tympanic membrane. एक और important point है, always look at the cone of light. Cone of light will always be in which quadrant? Cone of light will always be in the antero-inferior quadrant. So this is another way to identify कि कौन सा anterior है, कौन सा posterior है. Now one very important question that comes in your tympanic membrane is that inside the tympanic membrane, which is the most unsafe quadrant? The most unsafe quadrant of the pars tensa is the posterior-superior quadrant. क्यों? क्योंकि यहां पे होता है incudostapedial joint. That's why this is the most unsafe quadrant of the pars tensa. Okay, fine. This is about what you should know at least right? What the direction of the tympanic membrane is. The point of attachment of the malleus to the pars tensa is called as umbo. इसे हम कहते हैं umbo. If we draw an imaginary line, one along the handle of malleus and another important line perpendicular to it, then it will divide it into 4 quadrants: antero-superior, antero-inferior, postero-inferior, and postero-superior. Okay, fine. This is how we divide it. Okay, so tympanic membrane has got 2 parts: pars tensa, pars flaccida. Tympanic membrane has got 4 quadrants: antero-superior, posterior-superior, antero-inferior, postero-inferior, and tympanic membrane has got 3 layers: epithelial layer, fibrous layer, and mucosal layer. ये तीनों चीजें इतने नंबर की होती हैं. Okay, now if we see the external auditory canal nerve supply, तो वो इस तरीके की होगी. Now you see this is tilted towards the right. तो ये वाली कौन सी tympanic membrane हुई? This is the right side tympanic membrane. So if it is tilted towards the right, ये right side की tympanic membrane है. जिस तरफ tilted है, ये side anterior है, opposite side posterior है. So external auditory canal is supplied by what nerves? Posterior-superior is supplied by the facial nerve. Posterior-inferior is supplied by the auricular branch of vagus nerve, which is called as Arnold's nerve. And anterior, A for anterior, A for auriculotemporal. So this is the nerve supply of the external auditory canal. अब एक ट्यूमर होता है vestibulocochlear nerve पे, which is called as vestibular schwannoma. If there is a vestibular schwannoma in any person, then in those cases, because of the compression of the sensory fibers of facial nerve, there will be hypoesthesia in the posterior-superior canal wall. And if there is hypoesthesia of posterior-superior canal wall, यहाँ पे feel नहीं होगा कुछ भी, if you touch. What is that sign called as in vestibular schwannoma? That sign is called as Hitzelberger sign. That sign is called as Hitzelberger sign. Very, very important question, which is a sign for vestibular schwannoma. Okay, fine, good, great. चलो, अब आगे बढ़ते हैं. Now, very important question that comes inside the middle ear compartment is from Prusac space. Prusac space क्या होती है? अब see, this is your Prusac space, what I've shown you here. Prusac space is a tiny space in the middle ear, which is basically bounded by the pars flaccida in front. So in front there is pars flaccida. Behind there is the neck of malleus. Okay. Above, let me just make it a little more of a different color. So see this space here, this is your Prusac space. So in front the Prusac space is bounded by the pars flaccida. Behind it is bounded by the neck of malleus. Inferiorly it is bounded by the lateral process of malleus, and you can see there is a ligament above. This ligament is called as lateral malleal ligament. This is the boundary for Prusac space. Above it is lateral malleal ligament, below it is the lateral process of malleus, anteriorly pars flaccida, posteriorly neck of malleus. What is the role of Prusac space? Prusac space is the most common site for primary acquired cholesttoma. Most common site for primary acquired cholesttoma is Prusac space. Very, very important question, right? So this is what I have written over here. Remember the retraction pockets that happen. सबसे common pars flaccida retraction इसी में होगा. That is why the keratin debris accumulate, and that is the reason Prusac space is so dangerous. Okay, fine. चलो आगे बढ़ते हैं. Now let me come to certain important tuning folk test. Okay, so this is fork. This is a tuning folk test. Okay. Now what are the tuning folk test और इनकी interpretation क्या होती है? अगर कोई भी आपको question आता है and you have to see for tuning folk test, सबसे पहले see for the Rennes test. Okay, see for the Rennes test. Now whenever I say Rennes test is always positive when air conduction is more than bone conduction. That means Rennes is positive. We say Rennes is positive when air conduction is more than bone conduction, and the only point where air conduction and bone conduction is more than bone conduction is in normal people or if people have sensorineural hearing loss. क्योंकि हमें पता है sensorineural hearing loss में always bone conduction गिर जाता है. So if the air conduction is more than the bone conduction, then either two things could be there, normal or it is sensorineural hearing loss. Okay. Only one question that has come again and again in your exams is false negative Rennes किसमें दिखता है? False negative Rennes is seen in severe unilateral sensorineural hearing loss, and that occurs due to the transcranial vibrations from the opposite cochlea. This is a very, very important question. False negative Rennes कहाँ दिखता है? Okay. Now, when we talk about Weber's test, right? Weber's test is always lateralized to the worst side in conductive hearing loss and always lateralized to the better side in sensorineural hearing loss. So, whenever we have Weber's, in normal people it is equally perceived in both the ears, but if it is a conductive hearing loss, it will go to the worst side. If it is sensorineural hearing loss, it will go to the better ear. Okay. Now let's come to what exactly you have in absolute bone conduction test. In absolute bone conduction test, tragus को बंद कर देते हैं. अगर tragus को बंद कर देंगे, so we are testing only the bone conduction of the person in respect to the examiner. तो अगर किसी के bone conduction dip होगा, यानी sensory neural hearing loss होगा, the patient will have a poorer bone conduction in comparison to the examiner. So what will happen in sensory neural hearing loss? The bone conduction will be shortened in respect to the examiner in absolute bone conduction test. इसमें कोई भी काम नहीं होता about conductive hearing loss. अगर हमने ट्रेगस बंद नहीं किया, then we call it as Shawback test. Shawback test में ट्रेगस खुला रहता है. The patient is tested for bone conduction, फिर examiner अपने रखता है. Now, two things are there in Shawback's test. If it is shortened, if the bone conduction of the patient is shorter than the examiner, we call it sensory neural. If it is lengthened, ये important है, Shawback's अगर lengthened है, then always remember they are asking about conductive hearing loss. Okay, fine. This finishes all in all about what you require in tuning fork test and what are the different interpretations of tuning forks. ठीक है, चलो. Now we come to the next point. Now comes important audiograms that you need to interpret in your exams. अब ये as it is simple है. Okay, if you see air conduction, bone conduction दोनों गिर रहे हैं, साथ साथ गिर रहे हैं, साथ साथ मतलब दोनों लाइनें साथ साथ है, मतलब एयर कंडक्शन की लाइन, बोन कंडक्शन की लाइन साथ साथ है, साथ साथ S फॉर सेंसोरी न्यूरल. अगर एयर कंडक्शन बोन कंडक्शन एक साथ है और दोनों गिर रहे हैं, इट इज सेंसोरी न्यूरल हियरिंग लॉस. सिंपल. नाउ इफ यू सी देयर आर फॉलिंग एट अ डिप ऑफ 4000 हर्ट्ज, अगर ये एयर कंडक्शन बोन कंडक्शन दोनों गिरा एट 4000 हर्ट्ज, वी कॉल दिस एज अकूस्टिक डिप एंड दिस इज अ क्लासिकल साइन फॉर नॉइज इंड्यूस्ड हियरिंग लॉस. This classical is noise-induced hearing loss. This particular curve is called as Boiler's notch या boiler maker notch. हम साथ साथ है, correct? ठीक है, तो ये हो गई Boiler's notch. Boiler's notch is seen in 4000 hertz और acoustic dip seen in noise-induced hearing loss. Simple. Okay? Now let me come to the second PTA. If by any chance you see that the bone conduction is dipping at 2000 hertz, I'm talking about bone conduction. Always remember, otosclerosis में bone conduction is lost. Bone cannot move, stapes is fixed. So if the bone cannot move, stapes is fixed, the ossicular resonance frequency of the stapes usually is at 2000 hertz. So क्या होगा? The bone conduction will dip at 2000 hertz. If there is a 2000 hertz dip in bone conduction, we call this as Carotenoids Notch, which is a classical thing that is seen in cases of otosclerosis. Okay, fine? चलो. Now we come to another important point. अब आता है Meniere's disease. If they tell you that there is a person who has entered in your OPD and that patient has got symptoms of VDTA, मतलब vertigo, deafness, tinnitus and oral fullness. Vertigo, deafness, tinnitus, oral fullness. इसी लाइन में, then the answer is Meniere's disease. Now, if it is Meniere's disease, if they do a Pyoton audiogram, what will you see? You will see a rising curve. ये देखो, साथ साथ हैं. The bone conduction and the air conduction are साथ साथ. That means it is a sensory neural type of hearing loss. But this sensory neural type of hearing loss is at lower frequencies. You can see it is at lower frequencies. And at higher frequencies, this curve has started to rise. So this is a classical rising audiogram which is seen in cases of Meniere's disease. It produces a rising curve. And why does that rising curve happen? It happens because of the phenomena of recruitment. Recruitment का क्या मतलब होता है? Recruitment का मतलब होता है, let's say हमारे hair cells हैं, right? और hair cells बहुत सारे हैं, but in Meniere's disease these hair cells start to die. अब ऐसा सोचो कि 10 hair cell हैं और 10 में से 5 are dead. So what will happen? The remaining 5 will start acting double in order to compensate the function of the lost hair cells. वो ज़्यादा काम करेंगे. And अगर वो ज़्यादा काम करेंगे, they will become very sensitive. And if they become very sensitive, then to any particular sound, you will appreciate कि ये curve rise करिए, क्योंकि अब वो इतने sensitive हो जाएंगे that they couldn't even hear 1 decibel change in sound. And that is why you see a rising curve in the earlier stages of Meniere's. अब धीरे धीरे करके क्या होगा? These hair cells जो बचे कुचे हैं, ये भी मर जाएंगे. They will also die. And if they will die, then in about middle stages of Meniere's disease, as it progresses, they will form a plateau curve. ये plateau हो जाएगी, straight हो जाएगी, as the hair cells keep dying. और एक पॉइंट के में सारे के सारे hair cells खत्म हो चुके होंगे, and in late stages of Meniere's, you will see a sloping curve. So all three curves are seen in Meniere's disease. Initially, it is rising because of recruitment. In the middle stages, it is plateau, and then after that, it will be sloping. Okay, fine. So this is something that you should understand about what exactly you need in Meniere's disease audiogram. Chalo. Now we come to sloping audiogram. Agar aapko kabhi bhi in your paper you see that there is something sloping given. Sloping का मतलब you will always see sensory neural hearing loss. क्यों? क्योंकि air conduction गिर रहा है, bone conduction गिर रहा है, साथ साथ गिर रहे हैं, and you see that it is forming a slope. The differential diagnosis of a sloping audiogram is either it could be presbyacusis. Presbyacusis मतलब age related hearing loss. अगर आपसे उन्होंने पूछा कि the patient is 60 or 65 or 70-year-old bilateral hearing loss and this is the curve, then obviously it is the answer is presbyacusis क्योंकि वो age related है. If they tell you this patient has been put on tuberculosis की medicines या amikacin या streptomycin, in those cases the answer would be ototoxicity, which also produces this kind of an audiogram. Now one more important thing that they ask you is vestibular schwannoma. Vestibular schwannoma में भी sloping audiogram दिखता है, but this is usually unilateral, not bilateral. Okay, and finally I already told you in the late stages of Meniere's disease you will have this kind of an audiogram. Okay, so sloping audiogram में ये चार important differentials याद रखनी है: presbyacusis, ototoxicity, vestibular schwannoma and late stages of Meniere's disease. Okay, fine. चलो, let's go. Now we come to important impedance audiometry. Right? Impedance का मतलब होता है resistance. Right? So अब हम लोग करते हैं what is impedance audiometry. Impedance audiometry means that you test for two things: pressure and compliance of the tympanic membrane. Pressure के बदले compliance. Compliance का मतलब how much mobile the tympanic membrane is. In and out कितना कर रही है. At what pressure it is doing. So let's say this is a neutral pressure 0. This is plus 200. ये plus के side पे. This is minus 200. And this is the compliance or the mobility of the tympanic membrane. If the patient is having normal pressure and normal compliance, मतलब 0 पे normal pressure and it is compliant, ये move कर रही है, अच्छी move कर रही है, we call this curve as A curve. ये A की तरह दिख रही है, so it is called as A curve. A curve is normal curve on impedance. Okay. Now let's suppose that this particular patient developed stapes fixation. Stapes के ऊपर कुछ fix हो गया. That is otosclerosis. तो क्या होगा? Now if the stapes is fixed, you cannot move the tympanic membrane so well. Compliance reduce हो जाएगी because अब वो इतनी अंदर नहीं जाएगी. And that is why you will get a reduced compliance at the same pressure. So what is the other curve? The other curve is called as AS curve, S for sclerosis. So question आता है, where do you see AS curve? AS curve is seen in all sclerosis. Sclerosis का मतलब otosclerosis और tympanosclerosis. सारी की सारी sclerosis में compliance reduce हो जाएगी, but the pressure will remain normal. So S for sclerosis, tympano या auto. Now we come to another type of curve. Another curve is कि अब कंप्लायंस बहुत ज्यादा बढ़ गई, इतनी कंप्लायंस बढ़ गई दैट यू कैन नॉट क्लोज द कर्व. ये हमेशा ओपन रहती है. देयर इज नथिंग रॉन्ग विद द मिडिल ईयर प्रेशर, बट द कंप्लायंस हैज गॉन वे अबव. राइट, इट इज ओपन. अब ये किस में होगा? अगर इन केस मैलियस इंकस स्टेपीज लूज देयर कनेक्शन, विच इज कॉल्ड एज ऑसिक्युलर डिसकंटिन्यूटी. किसी को चोट लग गई, देयर ऑसिकल्स आर डिसकंटिन्यूड, तो ऑब्वियसली जब भी साउंड लगेगा there will be hypermobility of the tympanic membrane. Tympanic membrane बहुत अंदर जाएगी. Why? Because the ossicles are not attached to each other, and that is called as hypermobile tympanic membrane. तभी इतना compliance हो गया है, इतनी mobility हो गई है. So this is called as a D curve. D means discontinuity. Discontinuity of ossicles. When do you see this kind of AD curves? You see discontinued ossicles. Okay. Now we come to another point. Now we come to C type of curve. C का मतलब क्या हुआ? C का मतलब हुआ इट इज रिलेटेड टू द प्रेशर. राइट, अब C को ऐसे याद रखो, C E की तरह दिखती है. तो C curve is seen in eustachian tube dysfunction. When the eustachian tube will get blocked, the curve will turn towards the negative side. इसमें compliance में कोई प्रॉब्लम नहीं है, but there is a problem with the pressure. It has become more negative. So negative pressure, you will get a question of adenoid hypertrophy. They will ask you what type of curve will you see? You will see a C curve. Why? Because there is a eustachian tube blockage. Okay, and finally you will have a flat curve. Flat का मतलब हो गया B curve. Flat curve. Flat दो चीजों में दिखती है, either F for fluid, F for flat, या F for फटा हुआ eardrum and F for flat. फटा मतलब perforation. तो दो F, fluid यानी otitis media with effusion, or if there is a फटा हुआ eardrum, that means a perforation. The compliance of the tympanic membrane will be lost, and that will produce a B curve or a flat curve. This finishes all in all about what you require in impedance audiograms. Okay, fine. Chalo. Right. Now we come to Bera. बहुत important question. Brainstem evoked response audiometry, also called as auditory brainstem response. Okay, so thank you Harshit, thank you again for the appreciations. So keep going guys, Bera or ABR. Okay, up I told you, when I teach, whenever I tell you that what is the mnemonic for the auditory pathway? Mnemonic for auditory pathway is ecolema. Ecolema. That is the mnemonic for auditory pathway. मतलब 8th cranial nerve, cochlear nucleus, olivary complex, lateral lemniscus, inferior colliculus, medial geniculate body, and auditory cortex. This is your whole order of how sound goes into your brain. अब हम लोग क्या करते हैं? When we need to take Bera, we usually do this as a screening tool in children. So what do? We seat the child and we put certain electrodes over the vertex. We put electrodes, different electrodes, and we put a sound inside the ear. When that sound will go through all the ranges of the auditory pathway, कुछ potentials create होंगे, and those potentials are picked up by these electrodes and they create a graph. और उस graph को we call it as Bera. Okay, but these waves of Bera are totally 7 in number. Total देखेंगे तो these waves are 7 in number. Now, how to identify what wave is corresponding to what side? So this is important. So इसके लिए mnemonic याद रखना है E coli. इसमें इकोलीमा नहीं है, इसमें ई कोलाई है. This is something which is not very well given in your textbooks. I'm correcting you here. इसमें इकोलीमा नहीं है. This is many textbooks are wrong. So what is the formation from wave 1 from? The wave 1 is formed from the distal part of the cochlear nerve. Distal part मतलब when it comes out of the cochlea. ये distal part है. The wave 2 is formed by the proximal segment of the 8th cranial nerve when it enters inside the brainstem. ये brainstem है, when it enters inside, that is proximal. So this is E coli. 8th cranial nerve, when it comes out of the cochlea, it will form wave 1. As it reaches the brainstem, proximal part will form wave 2. अब C से क्या हो गया? Cochlear nucleus. Then the same thing. Wave 3. Wave 4 by olivary complex. Wave 5 by lateral lemniscus. And wave 6 and 7 by inferior colliculus. The medial geniculate body and the auditory cortex do not directly participate in Bera formation. This is a very important point. अब एक और चीज आपसे आती है पूछने में, that which among the following is the most standard wave for Bera? सबसे अच्छी वेव कौन सी है? The most standard wave of Bera is wave 5. If you want to see anything, see wave 5. Okay, fine. Now I'll show you exactly what questions of Bera have come. ठीक है? And I'll give you a kind of a line. ऐसे सीधे questions आए हैं. Which audiometric test is done to assess neonatal hearing screening? It is Bera. Which audiometric test is the best to rule out malingerer, जो झूठ बोलते हैं? Now, always remember, malingerers को we also call it non-organic hearing loss because there is no cause for it. ये झूठ बोल रहे हैं. So how can you rule them out? It is by Bera. Best audiometric test. Third important thing, best audiometric test for ruling out a retrocochlear pathology. Retrocochlear मतलब cochlea के बाहर, like vestibular schwannoma, right? So that is also Bera. Okay. Best audiometric test for differentiating between a cochlear pathology with a retrocochlear pathology. What is that? It is also Bera. 4 MCQs, 4 lines, you need to remember all of them. It is Bera. Okay, fine. Now, straightforward otoacoustic emission में एक question आता है. Otoacoustic emission is what? Otoacoustic emission is basically these are potentials which are generated from the outer hair cells. हमारे outer hair cells move करते रहते हैं. Even when we are resting, our outer hair cells are moving. And if you put a kind of an electrode inside the ear, these outer hair cells are going to create certain potentials, you have certain emissions, and जब ये emissions बाहर आएंगे, we can catch them and we can see. So if these emissions are present, we call them as otoacoustic emissions, जो normally हमारे होने चाहिए. If they are not present, that means there is some kind of a pathology. So important question क्या आता है? Otoacoustic emissions are generated from outer hair cells. Very important question. What is the use of otoacoustic emissions? Otoacoustic emissions are very important for neonatal hearing screening assessment. Neonatal hearing screening assessment में दोनों important tools हैं, Bera as well as OE. Okay, fine. चलो. So this finishes about what you require as far as audiometry is concerned. अब आते हैं important diseases में. अब एक करके हम लोग सारी diseases खत्म करते जाते हैं. Now let's talk about external ear disorders and let's finish them off. Okay. Now, first is hematoma pinna. Hematoma को pinna के क्या बोलते हैं? We call it as boxer's ear or wrestler's ear. That means if somebody boxes a ear, it forms a swelling. This is called as boxer's ear या wrestler's ear. Okay. Now the treatment of hematoma oris is always incision and drainage or aspiration of blood. If we don't treat hematoma, if we don't drain it out, it will form cauliflower ear. Cauliflower का क्या मतलब होता है? Cauliflower का मतलब होता है that now the blood that has been collected will not go away. It will get resorbed and it will basically cause necrosis of the chondrocytes. जब chondrocytes यहाँ के necrose हो जाएंगे, so they will heal with fibrosis. और जब heal होगा fibrosis से, तो पूरा पिन्ना उबड़ खाबड़ हो जाएगा. It will crumple. It looks like a cauliflower. So healing of the pinna which occurs due to fibrosis creates a cauliflower ear. Okay, fine. That is why we should drain the pinna. We should drain any hematoma oris. Perichondritis. Straightforward. What is perichondritis? Perichondritis is something. Perichondrium is the layer which is lining our pinna cartilage. Right? Pinna ki cartilage kya hoti hai? It is elastic cartilage. If there is inflammation of the perichondrium, we call it as perichondritis. दो इंपॉर्टेंट क्वेश्चन आते हैं. व्हाट इज द मोस्ट कॉमन कॉज, व्हाट इज द मोस्ट कॉमन ऑर्गेनिज्म. मोस्ट कॉमन कॉज ऑफ पेरिकॉन्ड्राइटिस क्या है? जब आप जाते हैं किसी भी गंदी जगह से, आप ट्रॉमा, यू पुट पियर्सिंग. इट इज वेरी वेरी कॉमन, राइट? आप जाते हो गोवा और यहाँ पे पियर्सिंग करा लेते हो. दैट इज व्हाट, दैट इज अ पोटेंशियल साइट फॉर इन्फेक्शन. मोस्ट कॉमन कॉज ऑफ ट्रॉमा या ईयर पियर्सिंग. Which is the most common organism which causes perichondritis? One organism which loves the ear, Pseudomonas. सबसे ज्यादा Pseudomonas प्यार करता है ईयर को. Now, whenever you see Pseudomonas, the drug of choice automatically becomes ciprofloxacin, which is a fluoroquinolone. Remember, ciprofloxacin, that is why half of India uses Ciplox ear drops. Right? So, ciprofloxacin is a drug of choice for Pseudomonas. Okay? Now, let me come to the third one. Furuncle क्या होता है? Furuncle means a boil. If there is any boil in the cartilaginous part, this is not occurring in the bony part. The cartilaginous part of our external auditory canal contains hair. If there is any infection of the cartilaginous part of external auditory canal, it will produce a boil or a furuncle. What is the most common cause of furuncle? It is Staphylococcus aureus. It is also called as localized rotitis externa. Okay. Now, one important question. What is one sign which is positive in otitis externa? क्या एक साइन है? अगर मैं आपसे बोलूं तो कहीं पे भी अगर आपने देखा कि ट्रेगल टेंडरनेस प्रेजेंट है, थिंक अबाउट ओटाइटिस एक्सटर्ना. ट्रेगल टेंडरनेस इज अ डायरेक्ट साइन ऑफ एक्सटर्नल ईयर ओटाइटिस एक्सटर्ना. ओके, फाइन. व्हाट इज डिफ्यूज ओटाइटिस एक्सटर्ना? डिफ्यूज मतलब पूरी कैनाल हैज बिकम्ड इन्फ्लेम्ड. पूरी कैनाल इज इन्फ्लेम्ड. दिस यूजुअली हैपेंस व्हेन अ पर्सन यूजेस अ लॉट ऑफ टेलीफोन, or if a person is living in a very hot and humid tropical climate, okay, or the patient has got a history of swimming. So there will be whole enlargement, or diffusely the external auditory canal will get enlarged. That is why it is also called as tropical ear. It is also called as telephonist ear, or it is also called as swimmer's ear. It occurs usually in the hot and humid climate. इसमें भी the organism of choice is Pseudomonas. Most common organism, Pseudomonas. Okay. Now let me come to otomycosis. Otomycosis का मतलब fungus inside the ear. Fungus inside the ear, most common organism, Aspergillus niger. Aspergillus niger is the most common fungus that happens in the ear. It causes black filamentous colony. Kali kali color ki bhai, because niger means black. So there will be black filamentous colonies. If you see anything white, that means it is candida. It produces white curdy colonies. So curdy white means candida, black filamentous colonies means aspergillus. So अगर ये black and white मिल जाएगा, so you will get something like a newspaper. So the question comes, wet newspaper appearance is seen in, it is seen in otomycosis. Okay, wet newspaper, black and white, right? Okay. अब आते हैं next पे. Ramsey Hunt syndrome क्या होता है? Ramsey Hunt syndrome एक अभी बहुत important celebrity को भी हुआ था, Justin Bieber, right? And this is a triad which is caused due to the infection of herpes zoster virus. तभी the other name for Ramsey Hunt syndrome is also called as herpes zoster oticus. What is the triad for Ramsey Hunt syndrome? इसमें बहुत सारे blisters होंगे, इसमें बहुत intense ear pain होगा या otalgia होगा, and there will be lower motor neuron facial palsy. So facial palsy, blister together with increased otalgia, that is Ramsey Hunt syndrome. Correct. भाई Justin Bieber baby वाला, same guy. Okay. Now we come to the next one. Very important. ये hit question है external ear का. Malignant otitis externa. अब जितने मैंने point लिखे हैं, ये सारे important points हैं malignant otitis externa के questions. Okay. First of all, whenever they ask malignant otitis externa, they will give you that this is about a patient in his 60s, diabetes uncontrolled, comes to the hospital with severe otalgia and purulent ear discharge. When you see inside through an otoscope, you see granulations in the external auditory canal. What is the likable diagnosis? The diagnosis would be malignant otitis externa. So otalgia, purulent ear discharge, diabetes, most common cause pseudomonas, and granulations inside the external auditory canal. Answer is malignant otitis externa. Always remember, in malignant otitis externa cases, they will tell you TM is normal. So if the TM is normal, it has to be external ear, correct? So malignant otitis externa always happens in immunocompromised hosts. That is why diabetes history will be there. Okay. Now, it is also called as skull-base osteomyelitis. It is also called as necrotizing otitis externa or necrotizing osteomyelitis. ये सारे इसके synonymous names हैं. ठीक है? Necrotizing otitis externa, necrotizing osteomyelitis, skull-base osteomyelitis. So it is a very common disorder to see in diabetics. Most common organism for malignant otitis externa, close your eyes, it is Pseudomonas. It can happen because of Aspergillus also, but most common is Pseudomonas. Right? Okay. So I told you what? I told you the man will come with severe otalgia, purulent ear discharge, as well as there could be even facial palsy. Because this is osteomyelitis. ये फैलेगा. It will run like cancer. So ये जब फैलता है, that is why it is called as malignant. It is not cancer, but it spreads like cancer. So it is very common to see cranial nerve palsy. Question आता है, what is the most common cranial nerve to get paralyzed during malignant otitis externa episodes? Facial nerve. Because it is very next to our ear. So that is why facial nerve is the most common nerve to get paralyzed in such cases. What is the hallmark sign? I told you when you put an otoscope, you will see granulations at the bony cartilaginous junction. Granulations. Whenever you see granulations, the answer is malignant otitis externa. Okay. Now, what is important? What is the investigation of choice? कभी भी bone involvement होती है, तो bone को देखने के लिए we need bone scan. What is the bone scan we require in osteomyelitis? The bone scan is technetium-99 bone scan. Now, technetium-99 is a very good bone scan to tell us about where the disease is. क्या stage है disease की? That is something very, very important. But when we follow up the patient, जब हम follow up करेंगे patients को, तब कौन सा scan करेंगे? When we follow up the patient to see whether the patient is improving with our treatment or not, the question will be that what will you do? You will do a gallium-67 citrate scan. So investigation of choice to see bone involvement is technetium-99, but on follow-ups to see for treatment response, it is gallium-67. Very, very important question. What are the biological markers to show whether the patient is improving on treatment or not? There will be ESR and CRP levels. ESR or CRP are acute phase reactants. They will drop down if the patient is becoming better. Okay? What is the treatment of choice? If I told you Pseudomonas, answer is ciprofloxacin. So drug of choice here also would be ciprofloxacin. Okay, fine. Chalo. Now we come to the next one, bullous syringitis. Bullous matlab bulla. Bulla matlab vesicle. If there is a formation of a blister or a bulla over the tympanic membrane, we call it as bullous syringitis. Syringa matlab eardrum, itis means inflammation. Right? Question सीधा सीधा आया है. Most common organism for bullous syringitis is, it is Streptococcus pneumoniae. Okay, so they usually present with a very high amount of ear pain or otalgia as well as some kind of a serous discharge. So जब ये बुल्ला फूट जाता है, then it causes some kind of a serous discharge. Okay, fine. चलो, let's move further. अब आते हैं into middle ear, external ear over. Now we come to middle ear. Middle ear में first and foremost acute otitis media. Always remember one thing, whenever they give you acute otitis media ka question, the question will be that this is about a 5 to 6 year old child, school going child, who is entered to the emergency or the OPD with severe ear pain, fever. They may say that the patient is having a toxic look, and they will give a history of an upper respiratory tract infection 3 to 4 days back. So that means कोई upper respiratory tract infection है, उसका organism has gone inside into the ear and it has inflamed it. When it gets inflamed, then it causes this kind of an infection to happen, and that is called as acute otitis media. Okay, that is why the most common route of infection into the middle ear in acute otitis media is what? This is a direct question. It has to be eustachian tube. सबसे important point. Okay. Now comes most common organism of ASOM is, it is Streptococcus pneumoniae. Second important point. This is the most common organism. Okay. Third, what are the stages of ASOM? So there are practically 5 stages of ASOM. एक stage mention नहीं करी है, but there are 5 stages. But we'll talk about important 4, because 5th stage I'm going to talk about in general, specifically उसकी हम बातें करेंगे. What are the 4 stages importantly for ASOM? The first stage is when the tube will get blocked. सबसे पहले eustachian tube block हो जाएगा. That is called as stage of tubal occlusion. During the stage of tubal occlusion, अगर हमारा tube block हो गया, there will be negative pressure in the middle ear and that will retract the tympanic membrane. So question आता है, what tympanic membrane finding will you see in tubal occlusion? The tympanic membrane will get retracted. Why? Because उसके अंदर pressure कम हो गया. Okay? Second stage is called as stage of congestion. Congestion का मतलब the tympanic membrane will become red and fiery. The whole of the tympanic membrane will become red and fiery. बहुत सारी red vessels दिखती हैं. So this question is called as, what do you see in this stage? This particular appearance is called as cartwheel appearance. Cartwheel appearance is seen in which stage? Cartwheel appearance is seen in the stage of congestion, also called as stage of pre-suppuration. This is a direct question. Okay, fine. Now we come to stage of suppuration. Pre-suppuration में this vessels became dilated, but अब pus जमा होना शुरू होगा. There will be formation of pus inside the middle ear. If there is formation of pus inside the middle ear, this is called as stage of suppuration. This is called as stage of suppuration. अब इसी point of time पे अगर tympanic membrane में गलती से perforation हो गया, then all the pus will come out in the form of a pulsatile manner. वो ऐसे आएगा जाएगा, आएगा जाएगा, आएगा जाएगा. So it will come out as a leash and it will keep coming out. This is called as pulsatile otorrhea. And question comes as, what is this sign called as? This sign is called as lighthouse sign. So lighthouse sign is seen in which stage? It is seen when the stage of suppuration has become so large that it creates a perforation and it produces pulsatile otorrhea. That is called as lighthouse sign. And if all the symptoms resolve, then it goes into the stage of resolution. जब सारी resolution हो जाती है, that means everything has become fine, सारा tympanic membrane सब ठीक हो गया, that is called as stage of resolution. ठीक है, अब इन्हीं stages के बीच में the patient can go into stage of complications. That means now the pus has gone beyond the confines of the middle ear and it has gone into some other place. What is the most common complication of ASOM? The most common complication of ASOM is mastoiditis. What is the most common intracranial complication of ASOM? The most common intracranial complication of ASOM is meningitis. Two important points. Okay, fine. Chalo. अब आते हैं ये. Now what do you see over here? This is about, let's say, a 5-year-old boy who has come to you with dull aching pain inside the middle ear, and you see there are certain important bubbles or air fluid levels which are seen behind a normal pars tensa. What are these? These are air fluid levels which are seen behind a normal pars tensa. What is the diagnosis? If you see air bubbles, the answer is otitis media with effusion. Also called as serous otitis media. Also called as non-suppurative otitis media. Also called as glue ear. Also called as otitis media with effusion. All of these names mean the same thing. Okay? अब किसी ने पूछा है कि bullous meningitis, I'll send you the image of bullous meningitis. Okay, once it finishes, I'll send you the image of bullous meningitis. कैसा होता है? But it is a bulla. इस तरीके का नहीं होता. See, this is something which has a normal tympanic membrane. उसके पीछे there are bubbles. Okay? Bullous meningitis में एक बुल्ला इस तरीके से निकला हुआ बाहर मिलेगा. There is nothing wrong with there is nothing wrong in the middle ear. But bullous meningitis में there will be a vesicle or a bulla which is protruding out. That is what is bullous meningitis. But here you see multiple bubbles behind a normal tympanic membrane. The answer is otitis media with effusion. Okay? So if there is collection of sterile fluid in the middle ear, we call this as otitis media with effusion. एक question आता है, what is the most common cause of hearing loss in children? The most common cause of hearing loss in children is otitis media with effusion. Okay? What is the most common cause of otitis media with effusion in children? The most common cause of otitis media in children is because of adenoid hypertrophy. Very important cause. Very, very important cause. ये याद रखना. Whenever they are telling you children, the answer is adenoid hypertrophy. What is the most common cause of unilateral otitis media with effusion in adults? Adults में क्यों होगा? Adenoids is something which stays till 12 to 14 years of age. Adenoid hypertrophy होती है, but it stays till 12 to 14 years of age. After 14 years of age, adenoids atrophy. So what could be the possible reason of unilateral otitis media with effusion in adults? There has to be some pathology in nasopharynx. That is nasopharyngeal carcinoma. Nasopharyngeal carcinoma, unilateral otitis media with effusion in adults. Children में most common cause adenoid hypertrophy. Please don't forget this. This is very, very important. Okay, fine. चलो आगे बढ़ते हैं. Now, let's come to more important stuff. That is chronic otitis media. Chronic otitis media में the most common questions that come are from unsafe ear, या फिर हम इसको कहते हैं atticoantral disease, right? We also call this as atticoantral disease, or we are talking about the cholesttoma, right? Now, what is a cholesttoma and what are the theories of cholesttoma is something that I'm going to quickly show you what happens in this. So, the presence of keratinizing stratified squamous epithelium inside the middle ear is given the name as skin in the wrong place, and skin in the wrong place का मतलब होता है that this is basically called as cholesttoma. Okay, so usually our middle ear does not have keratinizing stratified squamous epithelium. अगर वहां पे वो है, then we call it as a cholesttoma. Okay. Now, cholesttoma contains certain enzymes. ये कुछ enzymes release करता है. What are the enzymes? Such as acid phosphatase, collagenase, and this is why cholesttoma has got bone eroding properties. और जब ये erode करता है bone को, we call that particular thing as osteitis. That is why cholesttoma is dangerous. Why? Because it produces osteitis because of the release of these enzymes. Okay. अब एक चीज पूछ रहे हैं, there are some things in the workbook which are given as it is, वो याद रखनी है. I'm not discussing those things which are very well understood in the workbook. Somebody is asking about acute necrotizing otitis media. चलो फटाफट बता देता हूँ. Acute necrotizing otitis media का मतलब है, let's say if this is your tympanic membrane, अगर किसी इंफेक्शन की वजह से ये पूरी tympanic membrane डिस्ट्रक्ट हो गई, that means pars tensa, pars flaccida, all the ossicles, annulus सब destroy हो गया, यानी अब कुछ बचा ही नहीं है. This all is destroyed. There is a hole. अब एक hole बन गया है. We call this as acute necrotizing otitis media, क्योंकि अब necrosis हो गई है complete tympanic membrane की. And question comes is ये किस वजह से होता है? It occurs because of beta hemolytic streptococci infection. It occurs most commonly because of beta hemolytic streptococci infection, which usually causes something called as scarlet fever. Scarlet fever में there is a rash that happens, there is fever, and there is acute necrotizing otitis media chances also. Now another important question is, अगर पूरी तरीके से tympanic membrane destroy हो गई, तो क्या होगा? Then all the epithelium of the external auditory canal will start entering inside into the middle ear and start forming a cholesttoma. That is why the question that is asked is, what is acute necrotizing otitis media got to do as a sequelae? इसके आगे क्या होगा? There will be secondary acquired cholesttoma. Secondary acquired cholesttoma means that the epithelium of the external auditory canal has migrated within the middle ear. Why? Because there is nothing to hold it now. अब सब middle ear के अंदर grow करेगा. That is why acute necrotizing otitis media has got a very high chance of developing secondary cholesttoma or secondary acquired cholesttoma. Okay, fine. अब चलो, अब ये सारी theories हैं. These are all the theories of cholesttoma. आपसे जो question आता है that which among the following is not a theory of cholesttoma पूछा जाता है. अब हम लोग बहुत simple तरीके से देखते हैं, right? We'll first start with the first type of cholesttoma, that is congenital cholesttoma. Congenital cholesttoma means the baby is born with a cholesttoma. And the most important theory that is basically responsible for congenital cholesttoma is because of congenital cell rest. Congenital cell rest का मतलब there are certain epithelial cells which are present inside the middle ear. जब वो पैदा हुआ है, then they are there and they keep growing. So when a baby is born with congenital cholesttoma, you will see this kind of a picture. You will see a normal pars flaccida. You will see a normal pars tensa. अब ये देखो, ये कौन से साइड के tympanic membrane है? It is tilted towards the right, so obviously it is a right-sided tympanic membrane. As simple as that. Okay. Now what do you see here? You see there is a whitish mass. There is a pearly white mass which is present behind a normal pars tensa and pars flaccida. If there is a pearly white mass which is present behind a normal pars tensa and pars flaccida, we will call this as congenital cholesttoma. Okay, now there is a criteria for congenital cholesttoma and it is called as Levenson's criteria. What does Levenson's criteria say? Levenson's criteria कहता है that if there is any child who has got a normal pars tensa, normal pars flaccida, if there is a pearly white mass which is present in the middle ear, and if the child is having history of otitis media with effusion which does not form the grounds of exclusion, which does not form the ground of exclusion. That means what? That means अगर otitis media with effusion पहले हुआ है, that doesn't matter. but there will be a normal whitish mass that is present inside behind the normal tympanic membrane. Second question is, which is the most common site of formation of this particular mass? The most common site of congenital cholesteatoma, see which quadrant is this? If this is antero-inferior, क्योंकि ये cone of light है, this is antero-superior quadrant. So the most common site where congenital cholesteatoma is seen, it is antero-superior quadrant. Okay, this finishes about what exactly you need to know in congenital cholesteatoma, and the criteria is called as Levinson's criteria. Okay, अब आते हैं second पे. Now there is something called as primary acquired cholesteatoma and there is something called as secondary acquired cholesteatoma. पहले तो इसकी डिफरेंस समझो. Primary acquired cholesteatoma का ये मतलब है that there is no history of perforation or discharge. That means whenever the patient history will be given, there will be no history of prior perforation, no history of discharge, and still there is a cholesteatoma. That is called as primary acquired cholesteatoma. अगर किसी के दिया हुआ है that there is a history, previous history of discharge, and there is a history of prior perforation, then that means they are asking about secondary acquired cholesteatoma. जैसे मैंने बताया कि acute necrotizing otitis media में पूरी tympanic membrane destroy हो जाती है. That means perforation बहुत बड़ा है. And if there is a perforation, उसके through कोई cholesteatoma हुआ, that is secondary acquired cholesteatoma. But in primary acquired, it is not about the perforation, neither about the discharge. There are three theories for primary acquired cholesteatoma. As it is, हमें याद रखनी है. First and foremost is called as Witt-Max theory. अब इसको कैसे समझो? इसको यहाँ पे ऐसे समझो. Let's say ये external artery canal है. Let's say this is your external artery canal and this is your middle ear. Okay. Now I told you that there is something called as pars flaccida and there is something called as pars tensa. Pars flaccida ऊपर, pars tensa नीचे, right? And there is something called as a malleus which is attached to our pars tensa. Malleus attached it to the pars tensa, right? Okay. अब in case अगर let's say this patient had got a eustachian tube blockage, इसके eustachian tube block हो गया, तो क्या होगा? The most likable area to get retracted is the pars flaccida, क्योंकि वो flaccid होती है, तो क्या होगा? ये एक retraction pocket बन जाएगी in the pars flaccida, and inside this retraction pocket there will be accumulation of keratin debris. इसके अंदर there will be formation of keratin debris. So if there is formation of retraction pocket inside which keratinous debris are getting formed, we will call that as Witt-Max theory. Witt-Max का मतलब retraction pocket theory, which happens because of the invagination of pars flaccida. Okay. Second theory आ गई SAIDS theory. SAIDS मतलब metaplasia. मतलब क्या हो रहा है? That means through the eustachian tube again and again there is constant middle ear infection that is happening. यानी let's say ASOM बहुत बार हुआ. अब कोई भी infection या inflammation बहुत बार होता है, what happens? It will cause metaplasia. So if there is constant inflammation of the middle ear because of constant infections, then they will cause metaplasia in this area. And if there is metaplasia in this area, that means there is a wrong epithelium, a squamous epithelium, instead it shouldn't be there. That is called as SAIDS metaplasia theory. It occurs because of repeated middle ear infections. Okay, that undergoes metaplasia. Third theory is Ruody's theory. Ruody's theory means basal cell hyperplasia theory. What do you mean by basal cell hyperplasia? So that means this, if this is your pars flaccida, let's say this is your pars flaccida has got these cells on the outside, and outside I told you there are three layers of the tympanic membrane. The three layers of tympanic membrane are outer epithelial, middle fibrous and inner mucosal. So hota kya hai? In Ruody's theory, this epithelial layer which contains squamous cells, it starts to undergo hyperplasia. Hyperplasia मतलब ये बहुत सारे cells बनने लगेंगे. Many cells will start forming and they will start moving towards the middle ear compartment. So if it starts moving towards the middle ear compartment, it is called as basal cell hyperplasia theory, right? And this is called as Ruody's theory. Fine. अब ऐसे सोचो secondary क्या है? This is something जिसमें कहीं भी मैंने नहीं बताया that there is perforation. I didn't tell you any history of discharge, right? Now let me come to, there is one guy who has got a perforation. इसके perforation है. Now, if there is a perforation, what will happen? Then this will cause secondary acquired cholesteatoma. Means now there is a perforation through which the epithelium of the external artery canal has grown inwards. So that means there is epithelial migration inside into the middle ear. If there is epithelial migration inside into the middle ear, that is called as Haberman's theory. Okay, fine. So this is about what are the different theories that are present in primary acquired, secondary acquired, and congenital cholesttoma. अब खुद देखो, see this. This is the pars tensa, this is pars flaccida, and see the retraction pocket must have formed, and retraction pocket अब एक hole बन चुका है. There is a hole here. Why? Because now the retraction pocket has contained cholesttoma for a very long time, और अब वो erode हो चुका है. So this is called as an attic perforation. Attic मतलब the area behind the pars flaccida is called as attic. Okay, fine. So this is something which is about primary acquired cholesttoma. चलो अब आगे बढ़ते हैं. अगर आपके पास क्वेश्चन आता है कि अगर आपके पास एक पेशेंट है एंड उस पेशेंट के ट्यूबरक्यूलर ओटाइटिस मीडिया है, तो ट्यूबरक्यूलर ओटाइटिस मीडिया को रूल आउट कैसे करते हैं? ट्यूबरक्यूलर ओटाइटिस मीडिया का जितना भी डिस्चार्ज है इज ऑलवेज नंबर 1 पेनलेस, नंबर 2 इट इज हैविंग मल्टीपल परफोरेशंस. परफोरेशंस का मतलब एक परफोरेशन नहीं. इन टीबी देयर आर मल्टीपल परफोरेशंस. In TB there will be multiple perforations. There will be painless otorrhea, first P. There will be multiple perforations, 2P. There will be pale granulation tissues inside the middle ear, third P. Okay. Now comes the fourth P. The patient will have persistent discharge even if you give any antibiotic. Why? Because this is tuberculosis. This will only subside after ATT. So now if the patient is told कि आप बहुत टाइम से डिस्चार्ज हो रहा है, your antibiotics are not working, it is painless, it is having multiple perforations, what is the thing that is ringing inside your ear? The patient might be having TB. Okay, now the patient might have palsy. The patient might also have palsy. Okay, and in this particular case there is even component of sensorineural hearing loss. मतलब in tuberculosis it is not only conductive hearing loss that you will get, the toxins of tuberculosis will also go into the inner ear and cause damage. That is why there will be mixed hearing loss in tuberculosis. These are the mnemonic for the 6P, okay, that you will see in cases of tubercular otitis media. Okay, fine, ठीक है. चलो आगे बढ़ते हैं. ये सारे क्वेश्चंस आएंगे, ठीक है. ये ओटोरिया अभी खत्म नहीं होगा, दिस विल कीप कमिंग. अभी बहुत सारे आएंगे कॉजेज ऑफ ओटोरिया. Now let me come to the complications of CSOM. Complications of CSOM में most common complication of CSOM is mastoiditis. Very important. Mastoiditis means inflammation of the mastoid air cell system. Okay. Most common cause or organism for mastoiditis is Streptococcus pneumoniae. Okay. Now these are the signs for mastoiditis. ये बड़ा important question है कि which among the following is not seen in mastoiditis? सबसे पहले अगर mastoid enlarge हो गया या inflame हो गया, so all this area will become red and hot. जैसे एक iron होती है ना, red and hot. This is called as ironed out appearance of mastoid. That means red erythematous mastoid, बिल्कुल लाल हो जाएगा, right? Second important is lighthouse sign, which I've already discussed with you. Lighthouse sign का मतलब होता है pulsatile otorrhea. The otorrhea will keep coming out like a lighthouse. जैसे lighthouse चलता है ना, वैसे ही in pulsatile manner the discharge will come out. Third important sign is reservoir sign. Reservoir sign का क्या मतलब है? Reservoir sign का मतलब है that there is discharge which has collected inside in the mastoid. So if we suction out the middle ear, the discharge will again fill up. So that means mastoid is acting like a reservoir of pus. जो हम अगर suction करते हैं, it again starts to fill up. That is called as reservoir sign. Now, if there is inflammation of the mastoid air cell system, the pinna will be displaced forward. Pinna बिल्कुल forward हो जाएगा. And this sulcus, the retroauricular groove or the posterior auricular sulcus will become obliterated. ये बिल्कुल आगे चला जाएगा and all the sulcus will become obliterated. So this is called as obliteration of the retroauricular groove or posterior auricular sulcus. Okay? And this mastoid is near which part of our external auditory canal? कौन सी external auditory canal का part is next to the mastoid? It is our posterior canal. So if this will keep pushing up, then it will cause periosteoitis of the posterior canal wall, which will lead to sagging. Sagging का मतलब ये है कि let's say this is your mastoid. ये हमारा mastoid है. This is our external auditory canal. So it will keep pushing the external auditory canal and it will sag. ये आगे की तरफ push हो जाएगी. That is called as sagging of posterior canal wall. All these features are features of mastoiditis. Please remember that. Okay, fine. चलो आगे बढ़ते हैं. Very important question from intratemporal complications of CSOM is about Gradinego syndrome. Gradinego syndrome occurs due to the inflammation of the petrous apex or the petrous part of temporal bone, which is also called as petrositis. Now, what is the mnemonic for Gradinego syndrome? Gradinego syndrome में 3 D दिखते हैं. There are 3 Ds. One is the patient will have discharge. The patient will have double vision या diplopia. That is because of the involvement of sixth cranial nerve, which is abducent nerve, which supplies your lateral rectus. And finally, there will be deep-seated retroorbital pain. मतलब आँख के पीछे. Now, आँख के पीछे कौन सा ganglion है? There is trigeminal ganglion. There is trigeminal ganglion behind the eye. So that is why that will also get irritated, and that is why there will be deep-seated retroorbital pain. So deep-seated retroorbital pain, discharge, diplopia, close your eyes, Gradinego syndrome or petrositis. Okay, fine. Most common intracranial complication of CSOM, it is meningitis, without a doubt. Okay. Now let me come to lateral sinus thrombosis. Lateral sinus thrombosis का क्या मतलब है? Let's say this is your again your mastoid. This is again your mastoid. Inside the mastoid there is your sigmoid sinus. Now let's say your mastoid is filled with pus. बहुत सारा pus है that is filled inside mastoid. So after some point of time it will enter inside the sigmoid sinus and it will cause a thrombus formation inside the sigmoid sinus. This is called as sigmoid sinus thrombosis या फिर lateral sinus thrombosis. Okay. Now, what will be the classical feature for sigmoid sinus thrombosis? It will be hectic picket fence fever. Hectic picket fence fever का क्या मतलब है? जैसे हमारे picket fence होती है ना, it will rise, it will fall, it will rise, it will fall. जैसे हमारी garden की fence होती है ना, rising and falling, rising and falling. And why does that happen? Because ये एक septic thrombus है, इसमें बहुत सारे organisms हैं. When this thrombus breaks, these organisms will come into the blood and they will cause a fever spike. फिर हमारी body इसको मार देगी. Then फिर एक thrombus release करेगा, it will form a septic emboli, again our fever will come, again body हमें मार देगी. तो इसी तरीके से the fever will keep coming in spikes, and that is why it is called as hectic picket fence fever. Okay. Most important sign which is seen in cases of lateral sinus thrombosis is Grissinger sign. Grissinger sign का क्या मतलब होता है? Grissinger sign का मतलब होता है edema over the mastoid area. If there is edema over the mastoid area, it is called as Grissinger sign. Now always remember, इसमें confusion battle sign से होता है. Battle sign is seen when there is ecchymosis. Ecchymosis मतलब यहाँ पे blue color का patch है. That is seen in basilar skull fractures. But if you see edema over the mastoid, that is Grissinger sign. And why does that happen? Grissinger sign happens because of the blockage of mastoid emissary vein. Emissary vein एक vein होती है which drains the scalp. अब अगर ये sigmoid sinus thrombosis है, then this will block even this emissary vein. So the scalp drainage becomes poor, and that is why there is edema over on the postoral area. So this is a sign seen in lateral sinus thrombosis. Okay. Now two important tests are prominent for this particular lateral sinus thrombosis. एक होता है Toby-Ayer test and एक होता है Crowe-Beck sign, which are positive for lateral sinus thrombosis. What do you understand by Crowe-Beck sign? Crowe-Beck sign का क्या मतलब है? That let's say one side is thrombosed, one side is normal. Okay. So now what will happen is, if you press the normal side, मतलब एक side तो नहीं काम कर रही, it is thrombosed. If you press the normal side internal jugular vein, there will be retinal congestion. Because now the veins are not, they are not able to drain, so there will be retinal congestion on compressing the normal jugular vein, not the diseased. This is called as Crowe-Beck sign to be positive. And finally comes Toby-Ayer test. Toby-Ayer test का क्या मतलब है? Normally अगर हम अपनी IJV को प्रेस करते हैं तो हमारा CSF rise करता है और quickly fall करता है. But अगर किसी के thrombus बन चुका है in the sigmoid sinus, then if we press the IJV, there will be very slow rise and slow fall in our CSF. This is called as Toby-Ayer sign or Toby-Ayer test to be positive. ये हमारी classical test है to differentiate whether the patient has lateral sinus thrombosis or not. Okay, fine. चलो. So quickly we are keeping going. बहुत सारी चीजें हैं, बहुत सारी चीजें हमें डिस्कस भी करनी है. So I am just going on little quickly. So what is extratemporal complications of CS1? अब let's say ये mastoid है, right? इससे attach क्या होती है? इससे attached होती है sternocleidomastoid, and there is also attachment of posterior belly of digastric. If this mastoid tip breaks because the pus has accumulated so much that this mastoid pus comes down into the sheath of sternocleidomastoid and forms an abscess, then that abscess is called as Wizold abscess. Wizold abscess is an abscess present over the sternocleidomastoid. Agar ye abscess goes and trickles along the posterior belly of digastric, then we call this as Cityli's abscess. Then we call it as Cityli's abscess. Okay. If this abscess breaks open through the posterior canal wall and forms an intrameatal abscess, we call this as Lux abscess. Okay, fine. And finally, this can also extend up till the zygoma and will form zygomatic abscess. These are the extracranial, extratemporal complications of CS1. जहाँ पे neck के बाहर, mastoid के बाहर, temporal bone के बाहर, there are various types of abscess formation. ओके फाइन, चलो नाउ वी मूव ऑन टू फेशियल नर्व. अब ये बड़ा इंपॉर्टेंट क्वेश्चन है. फेशियल नर्व हैज गॉट 3 पार्ट्स, इंट्राक्रेनियल पार्ट, इंट्राटेम्पोरल पार्ट, एक्स्ट्राक्रेनियल पार्ट. इंट्राटेम्पोरल पार्ट का क्या मतलब है? इंट्राटेम्पोरल पार्ट का मतलब है टेम्पोरल बोन के अंदर, राइट? दैट मीन्स द फेशियल नर्व कम्स आउट ऑफ द ब्रेन स्टेम, it enters inside into the internal acoustic meatus, then it comes into the middle ear box, अभी let's say ये हमारा middle ear है, okay? This is the posterior wall of middle ear, this is anterior wall of middle ear, this is the center which is the promontory, which is the medial wall of middle ear, right? Now in the medial wall of middle ear मैंने आपको एक बड़ी इंपॉर्टेंट चीज आपको बार बार पढ़ाई है, that posterior wall के superiorly यहाँ पे there is oval window and इसके नीचे होती है round window, okay? Right? So once the facial nerve comes inside the internal acoustic meatus, this part is called as meatal segment. Okay? उसके बाद ये meatus से निकल जाती है and it goes to the roof of the middle ear where it forms a ganglion जिसे हम कहते हैं geniculate ganglion. So question आता है geniculate ganglion is formed from which part of it, in which of the cranial nerves? It is a part which is formed in facial nerve, right? Now this nerve takes a turn. At the roof of the middle ear, it takes a turn, and this turn is called as first genu. Genu matlab bend. Then this nerve takes another turn, and this turn happens between two structures. One is the oval window, and one is lateral semicircular canal. इसके बीच में ये turn करती है. So where is the second genu? The second genu or the second turn of facial nerve is present between the lateral semicircular canal and the oval window. And this turn is called as second genu, and now the facial nerve comes towards the posterior wall of the middle ear. Now इस posterior wall of middle ear पे एक important structure होता है और उसे हम कहते हैं pyramid. Okay? So now very important question. जब facial nerve was inside the internal acoustic meatus, उसे हमने बोला meatal segment. The segment of the facial nerve from the internal acoustic meatus till the geniculate ganglion, this segment is called as labyrinthine segment. This is the shortest segment of facial nerve, which is only around roughly 4 millimeters. It is also the narrowest segment of facial nerve, roughly around 0.64 to 0.68 millimeters. ये shortest और narrowest segment है. So in any particular disorder such as Ramsey Hunt syndrome, such as Bell's palsy, which is the commonest segment to get affected in cases of facial nerve, the most common question is which segment will get affected? It is the narrowest segment which will get affected. Which is the narrowest segment? It is the labyrinthine segment. तभी मैंने यहाँ पे लिखा है that the labyrinthine segment is only 4 millimeters, which is the narrowest segment most commonly affected in Bell's palsy or Ramsey Hunt syndrome. Okay, this is the segment between the meatus up till the geniculate ganglion. From the geniculate ganglion up till the pyramid, ये पूरा रास्ता, this is called as tympanic part or horizontal part, क्योंकि ये horizontal है. This is called as tympanic part या horizontal segment. Very important question is ये कितना बड़ा होता है? It is around 11 millimeters. Okay, so मैं ऐसे याद रखता हूं that horizontal ऐसा दिखता है तो दो डंडी मतलब 11, so it is around 11 millimeters. Okay, now this is the most common area to get affected because of congenital dehiscence. Congenital dehiscence का क्या मतलब होता है? Congenital dehiscence का मतलब है that this whole of the facial nerve is covered by a bone. ये ऐसे नहीं होती, it is covered by a bone. The bone that covers the facial nerve is called as fallopian canal. Fallopian canal is the canal inside which the whole of the facial nerve is present. अगर ये fallopian canal absent होगी, then it will become dehiscent. Dehiscence का मतलब वो खुली हुई है, and that is called as congenital dehiscence. So most common area for congenital dehiscence is tympanic part, or it is also called as horizontal part. Okay. Now, अब ये कहाँ तक गई? Till the pyramid. From the pyramid up till the stylomastoid foramen. This part is called as vertical part of facial nerve, which is also 13 millimeters. Okay. Now, दो क्वेश्चन इंपॉर्टेंट आते हैं. अगर मैं आपसे पूछूं iatrogenic इंजरी सबसे कॉमन, मतलब mastoidectomy अगर मैं कर रहा हूं, mastoidectomy मतलब this is your middle ear, so behind the middle ear your mastoid is there. This is the posterior side. So if I'm doing a mastoidectomy, which is the likely area which will get injured in facial nerve? The most common area to get injured in facial nerve during mastoidectomy is the second genu, जहाँ पे ये turn कर रही है, between the lateral canal and the oval window. The second most common area to get injured is the vertical segment of the facial nerve. So first most common area, it is the second genu, the turn. Most common second area is the vertical segment of the facial nerve. Okay, these are the set questions that come from facial nerve. इसके अलावा कुछ नहीं आता है. This is what you need to understand. Okay, now labyrinthine artery is the one which gives branch to internal acoustic meatus branch, as well as it gives the labyrinthine nerve the branch, as well as superior petrosal artery gives its supply to the horizontal segment, and the stylomastoid foramen is supplied by stylomastoid branch. So the vertical segment is also supplied by stylomastoid artery. These are the arterial supplies for facial nerve in its whole course. खत्म. ओके फाइन, चलो अब आगे बढ़ते हैं. अब फेशियल नर्व से एसोसिएटेड वन लाइनर कौन सी पैल्सीज के क्वेश्चन आए हैं. दिस इज अ स्ट्रेट फॉरवर्ड क्वेश्चन फॉर यू. मोस्ट कॉमन कॉज ऑफ फेशियल पैल्सी इज बेल्स पैल्सी. सिंपल. ओके, आई हैव ऑलरेडी टोल्ड यू अबाउट रैमसे हंट सिंड्रोम. नाउ देयर इज अनदर सिंड्रोम व्हिच इज कॉल्ड एज मिलर्ड-गुबलर सिंड्रोम. मिलर्ड-गुबलर सिंड्रोम इज also very important for medicine point of view. If you get a patient with brainstem lesion with facial palsy with ipsilateral lateral rectus palsy and contralateral hemiplegia, मतलब किसी पेशेंट के ब्रेनस्टेम में कोई लीजन है, contralateral hemiplegia है, ipsilateral facial palsy है, together this particular patient has got ipsilateral lateral rectus palsy, we call this as Millard-Gubler syndrome. Okay, then there is a question that was once came in INICET about what is Melkersson-Rosenthal syndrome. Melkersson-Rosenthal syndrome has got three things inside it. If the patient comes with recurrent facial palsy, this was the catch. अगर बार बार facial paralysis हो रही है, the patient has got edema of the lips, lips बिल्कुल swollen है, and the patient has got fissured tongue. tongue के ऊपर बहुत सारे fissures हैं. That is called as Melkersson-Rosenthal syndrome or MRS. So recurrent facial palsy, edema of the lips, and fissured tongue. What is Hereford syndrome? Hereford syndrome is seen in cases of sarcoidosis. It is characterized by bilateral parotid enlargement together with facial palsy and uveitis. That is called as Hereford syndrome. Okay, and finally comes Fraze syndrome, which is a very common question in NEET PG. That is, what is Fraze syndrome? Fraze syndrome means gustatory sweating. मतलब जब भी patient खाना खाएगा, there will be sweating from the parotid area. This is the most common complication which happens in parotidectomy. Okay, that's called as gustatory sweating. Okay, so this is something that you should understand about. Yes, जितने basic चीजें about what are the basic syndromes that are associated with facial palsy. ठीक है, चलो अब आगे बढ़ते हैं. Otosclerosis, one of the most important hit questions that comes ear में is from otosclerosis. Oto means ear, sclerosis means bone remodeling. That means this is a primary disorder which causes bone remodeling. Bone remodeling means that now the bony labyrinth, instead of forming a hard, dense bone, forms a woven, spongy bone. So there is bone remodeling. एक type की spongy bone बन जाती है in cases of otosclerosis. Which is the layer of the bony labyrinth which gets affected in cases of otosclerosis? It is the enchondral layer of the bony labyrinth. Bony labyrinth की तीन layer होती है. When I say bony labyrinth, what do you understand by bony labyrinth? Bony labyrinth constitutes cochlea, vestibule, and semicircular canals. These are the parts of our bony labyrinth, right? अब when I say कि bony labyrinth की कितनी layer होती हैं? Bony labyrinth की तीन layer होती हैं. Outer periosteal layer, middle enchondral layer, and innermost endosteal layer. If there is any problem or if there is any remodeling that happens in this enchondral layer, it will form some kind of an abnormal bone or it will form some kind of a spongy bone, and we call that bone as otosclerotic bone. So it is the formation of the enchondral layer. It is the problem with the enchondral layer of the bony labyrinth, which is the central layer in the bony labyrinth. Okay. Now, most common site for otosclerosis is fissula antifenestrum. What do you understand by fissula antifenestrum? इसका मतलब ये होता है कि let's say this is your stapes. Stapes has got a foot plate. Stapes has got an anterior crura, posterior crura, neck, right? Now, anterior crus is also called as fissula antifenestrum. ये important part है. So, if there is any kind of otosclerotic foci which form over the anterior crus, we also call it as anterior focus. We also call it as fissula antifenestrum. Now, the question of otosclerosis क्या होगा? Always remember, otosclerosis is a bilateral progressive disease which usually occurs in females of reproductive age group. तो कभी भी आपको कोई भी क्वेश्चन ओटोस्क्लेरोसिस का आएगा, दे विल टेल यू tympanic membrane is normal, the patient is a female which is either in puberty or in the reproductive age group or after menopause, and during that time the patient has got bilateral progressive hearing loss. Always think of the answer is otosclerosis. Okay, second important thing that they will be given in otosclerosis, this is genetically predisposed. That means it has got a hereditary predisposition because it is an autosomal dominant disorder. It is an autosomal dominant disorder. Okay, this is also very, very important, right? Now, one syndrome is attached with otosclerosis, जिसे हम बोलते हैं Van der Hoof syndrome. And Van der Hoof syndrome has got three things inside it. If a patient comes with osteogenesis imperfecta, otosclerosis, as well as blue sclera. तो दो O है Van der Hoof में. Van der Hoof में दो O आते हैं ना, दो O. So otosclerosis and osteogenesis imperfecta together with blue sclera, इसे हम कहते हैं Van der Hoof syndrome. What are the types of otosclerosis? Otosclerosis can be divided in two types. Number one, on the basis of site of involvement, it could be stapedial or it could be cochlear. Stapedial otosclerosis का क्या मतलब है? Either the sclerotic foci is present towards the anterior side, यानी fistula antifenestrum, we call it anterior focus. अगर ये posterior crus पे है, we call it posterior focus. अगर ये all around the stapes है, all around the stapes, but not involving the foot plate, ये बिल्कुल it is around the stapes, then we call it as circumferential. If it is involving the central part of the stapes foot plate, we call this as biscuit type. And अगर इसने सब कुछ involve कर लिया, that is the worst. This is called as obliterative type. These are the types of stapedial otosclerosis. If there is cochlear involvement, we call it as cochlear otosclerosis. तो आपसे दो क्वेश्चन मैंने आपको बताए. What is the most common area to get affected in otosclerosis? Answer is fistula antifenestrum या anterior focus. What is the second most common area to get affected in otosclerosis? Second most common area is round window. Second most common area in otosclerosis to get affected is round window. Okay, fine. Chalo. Ab let's say that otosclerosis is starting, right? So in the earlier stages of otosclerosis, you see something called as Schwartz sign. The other name for Schwartz sign is flamingo pink sign. ये बहुत important question है. Where do you see flamingo pink sign? Which disease? Answer is otosclerosis. Other name for flamingo pink sign or Schwartz sign is Schwartz sign. What is Schwartz sign? Now I told you ये कौन से side की tympanic membrane है? ये right की तरफ tilted है. This is anteroinferior quadrant. So this has to be the right side tympanic membrane. I already told you, right? Now in the posterior-superior part, do you see something pinkish here? So if there is a pinkish hue, in posterior-superior part of the pars tensa, then we will call it as Schwartz sign positive, or we will also call it as flamingo sign to be positive. Now this is usually in the stages of active otosclerosis. Active otosclerosis matlab in the stages when the bone is getting spongy, that time it is hypervascular. उसमें बहुत सारी vascularity होती है, and that is why it shines pink, and it is always in the posterior-superior quadrant. So in cases if the Schwartz sign is positive, then what is the management of choice for otosclerosis? It will be sodium fluoride. If they tell you that if a patient has got Schwartz sign positive, what is the next thing that you will do in this patient? You can start sodium fluoride in this patient. If this Schwartz sign is absent, that means dense sclerotic bone has already formed. That means if the patient is having inactive Schwartz sign, or that means the Schwartz sign is not positive and still the patient has gone into an inactive disease, then the treatment of choice is stapedotomy. That means we need to remove the stapes, we need to perforate the foot plate and put a piston there. That is called as stapedotomy. Okay, fine. Chalo. So now we have understood about that in inactive cases, we choose sodium fluoride, right? In cases of inactive cases, we do something called as stapedotomy. अब ये question आया था in INICET once that they had shown you and they had asked you कि ये कौन सा procedure है. So this procedure is stapedotomy. And what they are putting inside this is called as a Teflon piston. This is called as Teflon piston. What they are putting inside. Instead of the stapes, अब stapes हटा दिए and they are putting this piston inside so that it could work. Okay, fine. Chalo. Now let's move. Now let's move into the next important part, which is Meniere's disease. Okay. Now what is Meniere's disease? Meniere's disease is also called as endolymphatic hydrops. मतलब endolymph बहुत ज्यादा बन गया है inside in the scala media, more than the usual endolymph has collected. If there is no cause for Meniere's disease, अगर हमें पता नहीं चला Meniere's disease क्यों हो रही है, then we call it as Meniere's disease. If it is associated with a secondary cause, then we call it as Meniere's syndrome. That means idiopathic Meniere's disease को Meniere's disease बोलते हैं without a cause, and if it is happening because of something, we call it as Meniere's syndrome. Okay, so in this particular case, in Meniere's disease, there is excessive endolymph production, और या फिर there is decreased endolymph absorption. So production has increased, absorption has decreased, and that is why the endolymph has started to accumulate in the scala media, and we call it as endolymphatic hydrops. That is why if I show you the organ of Corti, you see this is a normal organ of Corti, right? This is your scala media, this is your scala vestibuli, this is your scala tympani. This is the whole cross section of the cochlea. You're looking inside the cochlea. Now I told you that inside your scala media, you have a fluid called as endolymph. Inside the scala vestibuli and tympani, you have got a fluid which is called as perilymph. Scala vestibuli and scala tympani mein perilymph is rich in sodium. Perilymph is rich in sodium, endolymph is rich in potassium. Always remember that. Okay. Now what will happen? Because of either excessive production of endolymph or या फिर ये endolymph absorb नहीं हो पा रहा है, there is excessive accumulation of endolymph inside the scala media. If there will be excessive accumulation of endolymph inside the scala media, what will it do? After one point of time, it will rupture the Reisner's membrane. The Reisner's membrane bulge hogi and it will rupture. And suddenly, if this Reisner's membrane ruptures, then all the perilymph will start getting inside, and this perilymph will mix with the endolymph. That means all the sodium-rich fluid has mixed with the potassium-rich fluid. Now, hair cells do not like sodium. They are only relied on potassium. So, अगर sodium potassium के साथ मिल गया, then this is called as a toxic fluid, and this toxic fluid will start bathing over these hair cells. ये hair cells को मारने लगेगा. So what will happen as a feature in Meniere's disease? As soon as this Reisner's membrane will burst, the first feature of Meniere's disease will be vertigo. Then all this fluid will start getting collected inside. Ye sodium-rich fluid will come inside and it will start bathing these hair cells. They don't like these hairs. These hair cells don't like sodium. So what will happen? There will be sensorineural hearing loss. I told you VDTA, deafness. And at the same time, अब ये रोने लगेंगे. These hair cells will start crying. They don't like sodium, so they will start creating noise, which is called as tinnitus. And because now the fluid has been filled inside, there is hydrops. The patient will develop oral fullness. So VDTA, these are the tetrad of Meniere's disease. ये हमें Meniere's disease में दिखता है. Okay. Now let me go further. So I told you VDTA are the symptoms of Meniere's disease, but there are certain very important variants of Meniere's disease which have been asked as questions. In case agar Meniere's ulti ho gayi, that means reverse Meniere's. That means now this is not VDTA. The hearing loss has come before the vertigo. We call that as reverse Meniere's, or we also call it as Lermoy's syndrome. Very important question. What is Lermoy's syndrome? Lermoy's syndrome means reverse Meniere's. Ulti ho gayi. That means now deafness is before vertigo. What is drop crisis? Drop crisis का मतलब क्या हुआ? Now the disease has gone from the cochlea, but it has involved even the utricle and saccule. Utricle and saccule are called as otolithic organs, क्योंकि इसके अंदर there is an otolithic membrane. So if the utricle and saccule will get involved in cases of Meniere's disease, there will be a sudden disruption of their membrane. And if there is sudden disruption of the otolithic membrane of utricle and saccule, suddenly अगर मैं चल रहा हूँ, suddenly I will fall down to the earth. मैं नीचे गिरूंगा सीधा. That means the gravity will pull me down. I'll get that impulse. That is called as a drop attack. So drop attack means it is also called as Tumarkin's crisis, which occurs due to the disruption of the otolithic membrane which is present in the utricle and saccule. Okay. Now there is also another thing which is called as Tullio's phenomena. What do you understand by Tullio phenomena? Vertigo perceived with loud sounds. Vertigo perceived with loud sounds is called as Tullio's phenomena. Very important question. That is also a signature for Meniere's disease. What is the investigation of choice to confirm Meniere's disease? It is electrocochleography. Electrocochleography एक तरीका होता है जिसमें we take two potentials. एक potential cochlea के endolymph से निकलता है which is called as summation potential, और एक potential होता है जो vestibulocochlear nerve का होता है which is called as action potential. उन दोनों का ratio normally less than 30% होता है. You just need to remember कि SP by AP ratio is normally less than 30%. But in cases of Meniere's disease, because of increased endolymph production, this ratio becomes, the SP by AP ratio becomes more than 30%, which is classically seen as a sign for Meniere's disease. So electrocochleography is the investigation of choice. What is one test you do for Meniere's disease? One test we do for Meniere's disease is called as glycerol test. What do you understand by glycerol test? Glycerol is a dehydrating agent. Dehydrating का मतलब क्या है? We will give the patient 1.5 mg per kg glycerol dissolved in certain lime water. तो हम lime water में we will dissolve this 1 mg per kg के हिसाब से this glycerol and we will make the patient drink. Now what will happen? We will compare the pre-audiometry and the post-audiometry after drinking glycerol. अब glycerol dehydrating agent है, so it will take away all the endolymph. जब endolymph वो सारा खींच लेगा, it will dehydrate, then the hearing will become better. So now what will happen? The patient's pure tone audiometry will become 10% better. And even the speech audiometry will become 10% better. So if there is a 10% improvement after glycerol, that is a positive glycerol test because it has dehydrated all that was collected inside, and that is a classical thing that we do, which is called as glycerol test. Finally, treatment क्या होता है Meniere's disease का? Treatment of Meniere's disease is 10D. सबसे पहले डिस्कस करो, रीअश्योर करो, इट इज समथिंग विच कॉजेज एंजाइटी इन अ पेशेंट, राइट? सेकंड, डाइट. टेल द पेशेंट टू हैव लेस वाटर, लेस सॉल्ट, अदरवाइज बाय ऑस्मोसिस देयर विल बी मोर कलेक्शन ऑफ एंडोलिम्फ. थर्ड, डिप्रेसेंट. डिप्रेसेंट मतलब डिक्रीज द वेस्टिबुलर फंक्शन. इफ द वेस्टिबुलर फंक्शन विल बी डिक्रीज्ड, देन देयर विल बी डिक्रीज्ड वर्टिगो. So what are the vestibular sedatives? You give cynarizine, dimenhydrinate, promethazine, prochlorperazine. ये सारे के सारे drugs are for acute depression of the vestibule, ताकि vertigo गिरे. There shouldn't be any vertigo. Next is dilator. Dilator का मतलब we don't want ischemia of the endolymphatic sac. We want the sac to get opened up so that more and more endolymph gets absorbed. So we will give a vasodilator. Vasodilator, drug of choice, beta histine. Next D, do not smoke. Why? Because smoking causes vasoconstriction. If there is vasoconstriction, there will be more collection of endolymph. There will be more ischemia. The endolymph will not be able to drain. Then comes dexamethasone. Dexamethasone is a steroid which is given intratympanic. Inside the middle ear, we directly put an injection of dexamethasone. This will decrease the edema. This will decrease the inflammation of the inner ear. Then comes diuretics. Diuretics obviously आपने पता है कि सारा का सारा पानी हमारे बॉडी से diuretics निकालते हैं. So even the drug of choice is furosemide, which is given in late stages of Meniere's disease. Then comes certain thing called as device. Device का मतलब होता है Meniere device. So Meniere's disease में हम देते हैं Meniere device. Meniere device also is called as pulsed pressure therapy. Pulsed pressure therapy. What do you understand by pulsed pressure therapy? That means ये device हम लगा लेते हैं and धीरे धीरे इससे pulsed pressure निकलता रहता है. There is pressure that will keep coming out. Will keep coming out. And what will happen? This pressure will create, or it will push the endolymph out from the inner ear into the endolymphatic sac. So the patient is asked to put this device intermittently so that the endolymph gets pushed. Finally, if nothing works out, we do a surgery called as endolymphatic sac decompression. Okay? And last, if nothing works out, even if the sac is not working, if after decompression, then we destroy the labyrinth. Destruction of the labyrinth को हम क्या कहते हैं? We call it as total labyrinthectomy. Or we also use a chemical that is called as gentamicin, which can cause disruption of the inner ear. And that is called as, if you put gentamicin injection directly inside the inner ear, this is called as chemical labyrinthectomy. So what is the agent that you utilize for chemical labyrinthectomy? Answer is gentamicin or gentamicin injections. Okay, fine. Chalo. Now, okay, fine. Now we move into the next point. Next point is about ototoxicity. ठीक है, अब इसमें क्वेश्चंस क्या आते हैं? ओटोटॉक्सिसिटी ड्रग्स कौन से होते हैं? व्हाट आर द ड्रग्स दैट कॉज ओटोटॉक्सिसिटी डायरेक्टली, राइट? सो हियर आई विल टेल यू अ वेरी 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 सिंपल निमोनिक, राइट? एंड यू कैन रिमेंबर एज A cube, C and D. Okay, A cube, C and D. Now what is this A cube? A means the most common is aminoglycosides, right? What is aminoglycoside? Aminoglycoside जितने माइसिन होते हैं ये सारे हमारे aminoglycosides हैं. There are two types of aminoglycosides. Either it is cochleotoxic drugs or vestibulotoxic drugs. कॉक्लियोटॉक्सिक ड्रग्स को याद करने का निमोनिक है कान, कान हम लोग पढ़ रहे हैं तो कान, राइट? कान इज फॉर कानामाइसिन, amikacin and neomycin. So if you were given anywhere कान से related options, that are cochleotoxic drugs. Now comes what are vestibulotoxic drugs or vestibulotoxic aminoglycosides? Answer is no GST. हमें GST पे नहीं करना है, right? No GST. So no GST means nettlemycin, gentamicin, streptomycin, tobramycin. So this is no GST, which are the vestibulotoxic drugs. Cochleotoxic, कान. Okay? Now comes A cube का दूसरा A, that is analgesic. Most common analgesic which causes hearing loss, it is aspirin. Now comes the third A. Third is anti-malarial. Most common anti-malarial to cause hearing loss, it is quinine. Even chloroquine or hydroxychloroquine causes ototoxicity. Okay? Then comes C. C मतलब दो है, दो C हैं, that is cytotoxic drugs and chelating agents. Cytotoxic drug में आता है सारे के सारे chemotherapy drugs, that is cisplatin, carboplatin. Finally comes chelating agents. Chelating मतलब whenever there is iron overload, we give an iron chelator. Answer is desferrioxamine. Desferrioxamine is an iron chelator. It also causes sensorineural hearing loss. And finally, D for diuretic. Most common diuretic to cause sensorineural hearing loss, it is furosemide. This is a simple way how you can understand, but always remember aminoglycoside is the foremost forerunner of ototoxicity. सबसे ज़्यादा questions इसी से आते हैं. Which among the following is not cochleotoxic? Which among the following is not vestibulotoxic? This is how they will frame the questions. Okay? So remember these mnemonics that I gave you. चलो. Now let's move further. अगर आपके पास एक patient की history आती है, which was very recently asked in INICET also, that the patient has got sudden episodes of vertigo, and this usually happens when he gets up or turns towards the right or turns towards the left, and the episodes last for only 2 to 3 seconds. तो ऑलवेज याद रखना, ब्रीफ एपिसोड्स ऑफ वर्टिगो, छोटे छोटे एपिसोड्स ऑफ वर्टिगो हैं, 2 से 3 सेकंड में हो रहे हैं एंड सडन हो रहे हैं, पोजिशनल चेंज पे हो रहे हैं. आंसर इज बिनाइन पैरोक्सिस्मल पोजिशनल वर्टिगो. ओके, नाउ ऑलवेज इन केसेस ऑफ बिनाइन पैरोक्सिस्मल पोजिशनल वर्टिगो या बीपीपीवी, द मोस्ट कॉमन सेमीसर्कुलर कैनाल विच यूजुअली गेट्स इन्वॉल्व्ड, इट इज द पोस्टीरियर सेमीसर्कुलर कैनाल. दैट इज द मोस्ट कॉमन कैनाल विच गेट्स इफेक्टिव इन बीपीपीवी. ओके, राइट? नाउ What is the maneuver which you will do to confirm BPPV? हम क्या करते हैं confirm करने के लिए? We do a maneuver called as Dix-Hallpike maneuver. Dix-Hallpike maneuver मतलब we will keep the patient's head below the bed at certain angles in order to check for vertigo and nystagmus. That is called as Dix-Hallpike maneuver. But if we want to actually treat the patient, so in order to treat the patient, we do something called as canal repositioning maneuvers. CRP, canal repositioning maneuver, which is given the name as Epley's maneuver. So Epley is the treatment of BPPV. Dix-Hallpike is the diagnostic technique how we confirm BPPV. ये दो important questions याद रखना है. Okay? चलो आगे बढ़ते हैं. Sudden sensory neural hearing loss. If you get a patient's history that the patient's tympanic membrane is normal and the patient has developed sudden loss of hearing that has happened within 72 hours. So how to remember sudden sensory neural hearing loss? You have to remember the rule of 3. Rule of 3 क्या कहता है? Rule of 3 ये कहता है that if a patient has come to you with at least 30 decibels of hearing loss at 3 contiguous मतलब continuous frequencies. Continuous frequency का मतलब 500, 1000, 2000, 1000, 2000, 4000 और 2000, 4000, 6000. 3 contiguous या continuous frequencies में at least 30 decibel loss है and happened within 3 days. So rule of 3 ये कहता है, and that is what is given the name as sudden sensory neural hearing loss. Now what is the cause of sudden sensory neural hearing loss? You can remember IT3. Okay, most common. बहुत सारे होते हैं, but this is the most common ones. I means the most common among them is still idiopathic. हमें नहीं पता है. So they always ask you what is the most common cause of sudden sensory neural hearing loss. You don't know. It is idiopathic. Most common cause. But it is this idiopathic cause also is believed to be because of a recent viral infection. So they will always say that the patient came post fever or post upper respiratory tract infection. So it could be because of HSV, mumps, cytomegalovirus, influenza virus infection, but usually they will give a history of viral infection or fever. Now comes T3, it can happen because of trauma, tumor or toxin. Trauma मतलब temporal bone fracture हो गया, tumor मतलब vestibular schwannoma हो गया, and toxin मतलब ototoxicity हो गई. So any of these T3s can produce sudden sensory neural hearing loss. What will be the management of sudden sensory neural hearing loss? Always remember, in order to save the nerve, the drug of choice is steroid. जहां पे भी nerve बचानी हो, facial palsy हो, recurrent laryngeal nerve palsy हो, sensory neural hearing loss or suddenly vestibulocochlear nerve palsy ho, everywhere the drug of choice to save nerves is steroids. So here steroids becomes a mainstay of management. Either we can give oral steroids, we can give IV steroids, or we can even give intratympanic injections. That means directly we put an injection into the middle ear. Now there is also something which is called as hyperbaric oxygen therapy, which has been recently believed to be very useful for sudden sensory neural hearing loss. हाइपरबारिक ऑक्सीजन थेरेपी का क्या मतलब है? दैट वी सीट द पेशेंट इनसाइड अ चेंबर. हम एक चेंबर के अंदर, लेट्स से एक चेंबर है जिसके अंदर मैं हूं एंड आई एम लाइंग डाउन. इसके अंदर क्या करेंगे? दे विल पुश 100% ऑक्सीजन इनसाइड मी फॉर 90 मिनट्स एट 2.0 to 2.4 एटमॉस्फेरिक प्रेशर. तो अंदर बहुत सारे प्रेशर के दे विल लेट मी इनहेल 100% ऑक्सीजन. तो उससे क्या होगा? द इश्मीया अराउंड द वेस्टिबुलोकॉक्लियर नर्व विल स्टार्ट रिवर्सिंग, एंड दिस इज वेरी गुड, विच इज कॉल्ड एज हाइपरबारिक ऑक्सीजन थेरेपी. Now this is usually helpful in those cases if the patient has come with more than 40 decibel hearing loss within 14 days. If the patient is coming within 14 days with more than 40 decibel loss, you can provide the patient with hyperbaric oxygen therapy. Other than this, we will also give antivirals such as acyclovir, valacyclovir. Why? Because one of the causes is viral infections. And we can also give the patient carbogen therapy. कार्बोजेन का क्या मतलब होता है? कार्बोजेन इज अ मिक्सचर ऑफ कार्बन डाइऑक्साइड एंड ऑक्सीजन. कार्बोजेन. तो क्या होता है? व्हेन वी गिव ऑक्सीजन प्लस कार्बन डाइऑक्साइड टू इनहेल टू द पेशेंट, ऑक्सीजन रिलीव्स हाइपोक्सिया. ये हाइपोक्सिया को रिलीव करेगा, एंड कार्बन डाइऑक्साइड एक्ट्स एज एन ओटिक वेजोडाइलेटर. दिस एक्ट्स एज अ ओटिक वेजोडाइलेटर. ओके, फाइन. चलो, सो नाउ वी विल मूव फर्दर फ्रॉम सडन सेंसोरी न्यूरल हियरिंग लॉस. अब हमने इसको ठीक कर दिया है. नाउ वी गो इनटू वेरी इंपॉर्टेंट, व्हाट इज सुपीरियर सेमीसर्कुलर कैनाल सिंड्रोम और व्हाट इज सुपीरियर सेमीसर्कुलर कैनाल डेहिसेंस. ओके, नाउ व्हाट इज द सुपीरियर सेमीसर्कुलर कैनाल डेहिसेंस? तीन चीजें याद रखना. ऑफन यू गेट कंफ्यूज्ड. सुपीरियर सेमीसर्कुलर कैनाल डेहिसेंस मतलब बोन गायब हो गई है. तो इफ यू सी दिस इज योर सुपीरियर सेमीसर्कुलर कैनाल एंड यू डू नॉट सी अ बोन अबव इट, राइट? सो नाउ व्हाट विल हैपन इज, नाउ हियर देयर विल बी समथिंग कॉल्ड एज अ थर्ड विंडो फिनोमेना. मतलब एक विंडो एक्स्ट्रा बन गई है. So now whenever the sound will come inside into the cochlea, it will get shuttled from this third window. It will disappear. So that is why there will be three features. अगर आपको superior semicircular canal syndrome के तीन तरीके के features आएंगे. What will be that? The patient will have hearing loss, which will be usually conductive type. The patient will have episodic vertigo because all there is a sudden release of pressure, and the patient will always hear their own voice more, which is called as autophony. Autophony catch करना. Whenever they tell you autophony, answer is superior semicircular canal syndrome. Okay, so conductive hearing loss, autophony together with vertigo, SCCD is the answer. Okay, fine. Chalo. Now we come to more important stuff. Vestibular schwannoma. Vestibular schwannoma का मतलब होता है, it is the 8th cranial nerve tumor, which is the most common benign tumor of the 8th cranial nerve. It is vestibular schwannoma. It occurs in an area which is between the cerebellum and pons, which is called as cerebellopontine angle. That is why the most common cause of cerebellopontine angle tumor is also vestibular schwannoma. Most common cerebellopontine angle tumor is also vestibular schwannoma. Now, let me make you understand this particular logic. Let's say this is your brainstem, this is pons, and this is medulla. Inside the pons there is vestibulocochlear nerve nucleus. यहाँ से इसका nucleus है. And this is your internal acoustic meatus. Now your vestibulocochlear nerve comes out of the brainstem and it goes into the internal acoustic meatus, right? During the time it is intracranial. अब ये पूरा जितना time ये intracranial है, it is covered by a sheath which is called as central myelin. इसके around Schwann cells है. That is called as central myelin. It is covered by central myelin till the time it is entering inside into the internal acoustic meatus. As soon as it enters inside the internal acoustic meatus, this central myelin changes into peripheral myelin. ये change हो जाता है into peripheral myelin क्योंकि अब ये enter कर गई है into the temporal bone. The point of change where the central myelin is changing into peripheral myelin, this zone is the maximum area where the vestibular schwannoma develops. That means where the central myelin is changing into peripheral myelin, this is the zone which is called as Obersteiner-Redlich zone. This is called as Obersteiner-Redlich zone. This is the maximum activity zone for Schwann cells. सबसे ज़्यादा Schwann cells यहीं पे active होते हैं, और क्योंकि Schwann cells सबसे ज़्यादा active यहीं पे होते हैं, they can because of certain factors develop a tumor in this area, और उसे हम कहेंगे vestibular schwannoma. So what is the most common site of formation of vestibular schwannoma? It is the Obersteiner-Redlich zone, which is the transition zone where the central myelin changes into peripheral myelin as soon as it enters inside the internal acoustic canal. Okay, fine. Which is the most common nerve to get involved? The most common nerve to get involved is the inferior vestibular nerve. So vestibulocochlear nerve के दो part होते हैं, cochlear part and vestibular part. Vestibular part भी, there is superior vestibular nerve, inferior vestibular nerve. The inferior vestibular division has got the maximum predisposition to develop a vestibular schwannoma. Okay, fine. Chalo. Now let me show you. This is a diagram of internal acoustic canal जो मैंने आपको दिखाया. Very very important question. तो अगर हम internal acoustic canal का cross section देखते हैं, it is divided into 4 quadrants by 2 important bony projections. The 2 bony projections inside the internal acoustic canal are, one is a vertical one. Vertical is called as Bill's bar. ये question बहुत बार आया है. What is Bill's bar? Bill's bar is a vertical bony projection which divides the internal acoustic canal incompletely. देखो ये नीचे तक नहीं है, it is incomplete. Then there is another important bony projection which is horizontal. Horizontal bony projection को we call it as falciform crest. This we call it as falciform crest. We also call it as a horizontal crest. This divides the whole internal acoustic canal into 4 parts. Anterior, posterior. Now anterior में क्या होगा? You know there is a cold drink जो 7-up आती है, 7-up. So 7-up will always be up. मतलब 7 यानी facial nerve is always found in the anterosuperior part of the internal acoustic meatus. Right? अब कोका कोला आती है, तो कोका कोला मीन्स cochlear division of the vestibulocochlear nerve. तो cochlear division of the vestibulocochlear nerve, coke down. Coke हमेशा down, 7 हमेशा up. Right? That is an anterosuperior, anteroinferior. Now comes posterosuperior, posteroinferior. Posterosuperior में होती है superior vestibular division. Posteroinferior में होती है inferior vestibular division. Right? Now, if this inferior vestibular nerve will start getting bigger and bigger and bigger with the tumor, क्योंकि tumor सबसे common इसी में है, so which is the first thing which it will compress? It will first compress the cochlear division. That is why the first complaint that the patient will have will be sensory neural hearing loss. सबसे पहली complaint जो vestibular schwannoma की होगी will be sensory neural hearing loss. Okay? Now, if this inferior vestibular nerve goes and compresses the 7th cranial nerve या फिर facial nerve, then what will happen? Facial nerve में remember that there are 2 types of fibers in facial nerve, sensory fibers, motor fibers. But the motor fibers of facial nerve are very resilient, बहुत resistant होते हैं, इतनी जल्दी नहीं उनको दबा सकते हैं. That is the reason you don't get facial palsy so easily in vestibular schwannoma. But you will get a sensory loss of facial nerve wherever it is supplying it. Where does the facial nerve supply? I told you, it is supplying the posterior part of our external auditory canal. So there will be loss of sensation or hypoesthesia of the posterior part of our external auditory canal, which is called as Hitzel-Berger sign. Which is called as Hitzel-Berger sign, which is classically seen in the involvement whenever there is classically an involvement of the facial nerve. Okay, fine. This is called as Hitzel-Berger sign that we have already discussed. Chalo. अब आते हैं, what is the audiometric finding? So audiometric finding I already told you that on a pure tone audiogram you will see a sloping type of sensory neural hearing loss. And एक चीज याद रखना, I told you E. coli in Bera. अब अगर 8th nerve पे ट्यूमर आ गया है तो 5th wave जो बनेगी, that is because of lateral lemniscus, it will appear late. क्योंकि अब तो इतनी जल्दी ट्रांसफर हो नहीं पाएगी एक्शन पोटेंशियल्स, it will form late. That is why there is increase in the latency of the wave 5. It will form, but it will form very late because it will get that kind of stimulation a little later. That is why wave 5 is formed later. The latency is increased in cases of vestibular schwannoma. ये याद रखना आप लोग that wave 5 latency is increased in vestibular schwannoma. Okay? What is the investigation of choice to confirm vestibular schwannoma? You will always say MRI with a contrast. MRI with gadolinium contrast is something which we will do in order to confirm. And you see this is like an ice cream. See, this is growing from the internal acoustic canal towards the cerebellum. This is your cerebellum and it actually looks like an ice cream. So this is called as ice cream cone appearance. So where do you see ice cream cone appearance? You see it in vestibular schwannoma. If you do a histological examination, then you see a pathological finding which is called as Antony A and Antony B cells. I hope this has already been taken in your pathology, right? So Antony A and Antony B is a pathological finding which you see in cases of vestibular schwannoma. How will you treat a vestibular schwannoma? It is always surgical. So if it is small, we do a translabyrinthine approach. Translabyrinthine matlab mastoid drill karke, labyrinth drill karke, we straight away go inside into the brain. That is called as translabyrinthine approach. But if it is a big schwannoma, then we have to do a craniotomy and we have to go inside through the middle cranial fossa. That is why it is called as middle cranial fossa approach as well as translabyrinthine approach. These are the main two approaches that you should remember. Okay, fine. Chalo, आगे बढ़ते हैं. अब आते हैं questions from cochlear implant. This is also very, very important, very, very common questions that come in your exams. Ear is long. That's why we are taking some time. तो कॉकलियर इम्प्लांट में किसने सबसे पहले कॉकलियर इम्प्लांट बनाया? कॉकलियर इम्प्लांट वाज मेड बाय विलियम हाउस. ही इज आल्सो द फादर ऑफ न्यूरो ओटोलॉजी, राइट? ही वाज द फर्स्ट वन हु गेव दिस. नाउ if there is an implant which replaces the cochlea, which replaces the organ of cottae, we call that as cochlear implant, right? Now what are the indications of cochlear implant is very important question that has been asked. Recent INICET में question आया था, which among the following is not an indication for cochlear implant? So if you have got any patient who has got bilateral severe or profound sensory neural hearing loss, right? Either it could be before the language development, जिसे हम कहते हैं prelingual, or या फिर even after the language has developed, that is called as postlingual. They are good candidates for undergoing a cochlear implant surgery. Now comes what is temporal bone fracture. अगर temporal bone टूट गई, that could lead to cochlear damage. That also is a possible candidate for doing a cochlear implant. Third is if they are not benefiting from the hearing aid काम ही नहीं कर रही because it is severe to profound hearing loss. Fourth is if the damage to the cochlea has happened because of an ototoxic drug, or I already told you that if the otosclerosis goes and involves the cochlea, we call it as far advanced otosclerosis क्योंकि अब वो cochlear involvement कर चुकी है. In those cases cochlea is damaged, we can do a cochlear implant. और या फिर there is a condition where the hair cells and the nerves do not function properly. That is called as auditory neuropathy. In all these cases, we can do a cochlear implant. That means अगर ये चीज देखो इन सब में cochlea is the problem. Cochlea is the issue. But the only requisite for doing a cochlear implant is हमारे पास एक working vestibulocochlear nerve होनी चाहिए. We should have a working eighth cranial nerve because cochlea से सारे sensations vestibulocochlear nerve को लेके brain में जाने हैं. So there should be a working vestibulocochlear nerve. That is the only thing that we require. That is why the contraindications are related to the nerve. या तो contraindication हो गया कि cochlea ही नहीं है तो हम electrode कहाँ लगाएंगे हमें नहीं पता. So that is obviously not there. Second is cochlear nerve की aplasia है. The cochlear nerve is not formed. So you can't do because nothing will take the sensations from the electrode to the brain. Third is if there is a transected nerve, you cannot do anything. Or if the central nervous system is not functioning properly, there is a central disorder. In these four cases, there is problem with the auditory pathway. You cannot do a cochlear implant. Okay? चलो अब आगे आते हैं. Now these are the components of cochlear implant. जो ये देख रहे हो सारे components हैं. Cochlear implant के दो component होते हैं. एक होता है external component, एक होता है internal component. Now what is the external component? External component बिल्कुल hearing aid की तरह होता है. That is just like a hearing aid. It is three parts. One is called as a microphone, one is called as a speech processor, and the other is called as an external transmitter. तो देखो कान के पीछे से पहना इस तरीके से. So one is called as a microphone. Behind one इसके पीछे एक processor है which is called as speech processor, which has gone up to the external transmitter. ठीक है? Now अंदर क्या है? What is there inside? Internal component मतलब अगर हमने incision दिया, so once we raise the skin, we drill a hole in the skull, and inside the skull we place the internal component. और internal component क्या होता है? We call it as a receiver. हम इस receiver को skull के अंदर drill करके लगा देते हैं. This is inside, मतलब skin के अंदर है ये. Outside the skin are these three. Inside the skin is this receiver. And receiver is connected to a very important electrode which goes into the cochlea. Okay? अब कैसे काम करेगा? The moment the sound will come, sound is a form of mechanical energy, उसको सबसे पहले microphone catch करेगा. Microphone will send this sound energy to speech processor. Speech processor इसको बनाएगा into a digital signal. It will convert it into a digital signal. Now this digital signal will be carried to the external transmitter. अब ये external transmitter को ये digital signal मिल गया. अब ये क्या करेगा? This external transmitter will transfer all the sound in the form of radio frequency waves to the receiver. इसमें सारा का सारा जितना भी वो सिग्नल था, it transferred it as in the form of radio frequency waves to the internal receiver. Now receiver ने इसको देखा. अब receiver हमेशा क्या करेगा? Our cochlea will only understand potentials, only understand electrical signals. So now the receiver will convert this radio frequency wave into electrical signals, and these electrical signals will be transferred to the cochlea or the electrode, and they will fire the whole sound into the auditory pathway. This is how the whole cochlear assembly is working. अब 3 important questions आपको याद रखने हैं. How do we approach the cochlear implant? Approach क्या होती है, कैसे करते हैं? The approach name is called as facial recess approach, or it is also called as posterior tympanotomy. This is the name of the operation that we do for cochlear implant surgery. Okay. Now 2 important questions you need to be very careful. Electrode is passed through what? And electrode is placed inside what? So electrode is passed through the round window. Electrode is placed inside the scala tympani. Round window के अंदर होती है scala tympani. तो through जाता है electrode round window से, and किस में रखा जाता है? It is kept in the scala tympani of the cochlea. Okay, that's what I have written everything here. Cochlear implant is approached by facial recess or posterior tympanotomy through the round window placed in the scala tympani. ठीक है, ये चीज हमें याद रखनी है. चलिए आगे बढ़ते हैं. अब आते हैं ग्लोमस ट्यूमर पे. ये बड़ा इंपॉर्टेंट क्वेश्चन है. ये भी इसमें बहुत सारे साइंस आते हैं. बड़ा इंपॉर्टेंट क्वेश्चन आता है. नाउ रिमेंबर, मोस्ट कॉमन बिनाइन ट्यूमर ऑफ द मिडिल ईयर अगर आपसे पूछा जाए, ये मिडिल ईयर है. इनर ईयर, व्हेन आई वाज टॉकिंग अबाउट वेस्टिबुलर कॉक्लियर नर्व, इट वाज वेस्टिबुलर schwannoma. बट मोस्ट कॉमन ट्यूमर ऑफ द मिडिल ईयर कंपार्टमेंट इज व्हाट? इट इज ग्लोमस ट्यूमर. राइट. ग्लोमस क्या है? ग्लोमस मतलब होता है पैरागैंग्लियोनिक सेल्स. Paraganglionic cells are basically certain cells which are present around vessels, right? So these are the cells which form something called this benign tumor, also called as a glomus tumor. Now there are 2 parts, or there are 2 places where this glomus tumor can form. One is over the promontory, जहाँ पे tympanic plexus होता है. So if the glomus tumor is formed over the promontory or the tympanic plexus, we call it as glomus tympanicum. It is formed over the tympanic plexus. Tympanic plexus is a plexus which forms over the promontory. If this glomus tumor arises at the level of the jugular foramen मतलब जहां पे jugular vein का superior part is called as jugular bulb. अगर ये वहां पे होता है, we call it as glomus jugulare. Okay. Now important to note here is what? Whenever they give you glomus questions, they will give you the patient has got hearing loss, pulsatile tinnitus, which is synchronous with the heartbeat. क्योंकि ये सारे के सारे tumors are supplied by the carotid artery. If you have a question where there is synchronization with the heartbeat, pulsatile tap 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 sound आ रहा है, conductive hearing loss है, the answer is glomus tumor. पर एक चीज हमेशा याद रखनी है कि हम कैसे डिफाइन करेंगे कि ये tympanicum पूछ रहे हैं कि jugular पूछ रहे हैं. If there is pulsatile tinnitus and conductive hearing loss alone, answer is glomus tympanicum. If they tell you कि ये pulsatile tinnitus भी है, conductive hearing loss भी है, and together with that there are cranial nerve neuropathies, answer is glomus jugulare. क्योंकि jugular foramen is the area through which 9th, 10th and 11th cranial nerves pass. और अगर उसके through pass होता है, so glomus jugulare has a high potential of causing 9th, 10th and 11th cranial nerve palsy, which is not a classical feature of tympanicum. Okay, this is how we differentiate. अब इससे important signs क्या है? बहुत important signs है. If we take an otoscope and put inside the ear and we will see a red mass behind a normal tympanic membrane, which is also called as rising sun sign. That is the first sign of glomus. Okay. Second important sign of glomus is brown sign. B for brown, B for blanching. अगर हमने seagull speculum लिया and we pressurize the tympanic membrane, so this mass will get pressurized and it will turn whitish. Whitish का मतलब it will blanch. So if it blanches on seagullization or on pressure, it is called as brown sign. Next is aquinose sign. Aquinose sign में भी blanching होती है, but this blanching occurs by the compression of the carotid artery, because glomus is supplied by branches of carotid artery. So if we compress the carotid artery, the tumor will blanch, it will become सफेद. That is called as aquinose sign. And finally there is the fourth sign which is called as Phelps sign. Phelps sign दिखता है glomus jugulare में. So I already told you jugular मतलब jugular foramen का area. So whenever glomus jugulare happens, it erodes the keratojugular spine. Carotid artery और jugular foramen के बीच की bone को ये तोड़ देता है because it is jugular. And that is why this erosion of the keratojugular spine is called as Phelps sign, which is classically seen in glomus jugulare. Okay, fine. Now, if we do an MRI में glomus tumor में हमें कुछ चीजें दिखेंगी, हमें कुछ चीजें सफेद दिखेंगी और कुछ चीजें काली काली दिखेंगी. We'll see something white and we'll see something black. White is the hemorrhage, black is the void. Void मतलब जहां blood नहीं जा रहा. तो black color की चीजें दिखेंगी जहां पे blood नहीं जा रहा. That is called as flow void. That means the flow is not happening. White means hemorrhage. So black and white means salt and pepper. So on an MRI you will see a salt and pepper appearance. Okay. Now what is the treatment? Treatment is always surgical approach, right? So either we do a transmastoid approach, either we go through the mastoid and approach it, or either we do something called as fish approach. But that is something which is not important for you as of now. Just remember हम इसको कैसे approach करेंगे, वैसे surgical excision करेंगे. Okay, signs are very important. ठीक है, चलो आगे बढ़ते हैं. Done. So we finish ear, right? सारा ईयर खत्म. This is what you should know about all the important diseases, all the important questions. अब straight away fast forward rapid करते हैं, nose खत्म करते हैं, right? Let's finish off what is important in the nose. Now in the nose, the first question is what are the important congenital anomalies of the nose, right? Okay. Now the congenital anomalies of the nose में सबसे पहला आएगा what is choanal atresia. Choana मतलब दो होते हैं. There is anterior choana and there is posterior choana. Posterior choana, if they are closed, we call that as atresia. That is called as choanal atresia. Now usually the cause of choanal atresia is what? The cause of choanal atresia is because of the persistence of a membrane which fails to recanalize, and that is called as persistence of bucconasal membrane. Bucconasal matlab between the oral cavity, between the oropharynx as well as the nasal cavity, there is a membrane which persists, and that is called as bucconasal membrane, and this persists, and that is why this is called as choanal atresia. It is a failure of recanalization. One syndrome which is associated with choanal atresia is charge syndrome. What do you understand by charge? C is for coloboma of the iris, H is for heart defects, A is for atresia, जो हम लोग देख रहे हैं, R is retarded growth, G is genitourinary anomalies, and E means ear anomalies. All these are associated with Charge syndrome. Okay. Now, one drug which is associated with choanal atresia, one drug is high dose of methimazole, which is taken during pregnancy. That is also associated with the formation of choanal atresia. Okay. चलो. अब ये टाइप का आपको दो पिक्चर्स याद रखनी है. एक में हमें दिख रहा है that there is, see one side there is open and the other side it is completely closed. So this is unilateral choanal atresia. So choanal atresia, either it could be unilateral or bilateral, and this particular choanal atresia could be either because of a membrane, or it could be a bone, or it could be both, bone plus membrane. Most commonly this is a membrane. So most commonly it is only the bucconasal membrane which is persisting and it is membranous, but it could be also mixed. Okay. What are the clinical features? अब always ये एक चीज याद रखनी है हमें कि unilateral choanal atresia is not something which is a problem in children, because एक nose is एक part of nasal cavity is still working. Remember, infants are obligate nasal breathers. जब बच्चे पैदा होते हैं ना, their larynx is very high placed. They cannot open their mouth and breathe. That is why you never see a child open their mouth and breathe. They are obligate nasal breathers. तो अगर एक side का nasal cavity is working, they will breathe okay. They will be breathing fine. But if both the cavities are closed, then that becomes a surgical emergency, and that will lead to cyclical cyanosis and stridor. Remember this line. Cyclical cyanosis का क्या मतलब है? बच्चा रोता है, बच्चा सोता है. बच्चा रोता है मतलब they will get cyanosed, then they will cry, then they will sleep. क्योंकि cyanosis will get reversed when they cry. Then again they will get up, they will cyanose again, they will cry, again वो सो जाएगा. बच्चा रोता है, बच्चा सोता है, again this will keep happening. This is called as cyclical cyanosis. And the patient will be in stridor. How will you do an investigation for it? The best investigation of choice is doing a CT scan or seeing it. But what is the clinical method in which you can assess? Clinical method इसमें सबसे आसान ये होता है, you take an infant feeding tube, जिससे infant को हम feed करते हैं, and you keep it inside the nose. So you will always find obstruction while you pass the infant feeding tube. वो नीचे नहीं जाएगा. So if there is obstruction in passing the infant feeding tube, that is a characteristic कि choanal atresia present है. Second important way is you can do a cold spatula test. Cold spatula test matlab you can take a cold tongue depressor, you can keep it below the nose and you can see that there is no fogging that will happen because the nasal cavities are blocked from behind. This is something which is called as cold spatula test, which is a confirmatory for finding out corneal atresia. What is the treatment? अब treatment में सबसे पहले हमें बच्चे का मुंह खोलना है before we do a surgery. और बच्चे का मुंह खोलने के लिए what do we do? If the बच्चा is taking, this is a nipple, right? So this is a nipple. So we cut open the nipple at one end, we keep it inside the mouth and we tie it around the occiput. देखो हमने बच्चे के मुंह के अंदर ये nipple रखी and we tie it around the occiput so that the mouth of the baby remains open because they don't know how to open the mouth for breathing. So this is called as McGovern's nipple. Okay, this is called as McGovern's nipple. Now, what is the ideal modality of treatment? It is laser excision. So we need to excise this particular segment out. But again, remember, once we excise something out, it can recanalize. वो वापस से बंद हो सकती है. So that is why here there is a very important drug we need to apply locally, which is called as mitomycin C, which is an anti-fibroblastic agent, which will not let the membrane form again. It's an anti-fibroblastic drug. Okay, fine. This finishes corneal atresia. अब आ जाओ दो important conditions पे. What do you understand by nasal encephalocele? What do you understand by nasal glioma? अब देखो दोनों midline of nose पे ये दोनों बड़ी बड़ी swelling है, right? One swelling occurs because of the intracranial tissues which have herniated out because there is a defect here in the frontal bone. There's a defect here. So now all the intracranial tissues have come out as a swelling in the midline. On the other hand, एक swelling थोड़ी सी localized लग रही है, इतनी बड़ी नहीं है. And these are nothing but these are the glial cells which have accumulated in this area and grown into a tumor. But always remember, glioma does not have any intracranial collection. There is a connection in the intracranial compartment only with encephalocele. ये intracranially connected है. This is something which is just a mass over here because there are these glial cells or dysplastic cells which have collected and formed a mass there. This is called as a glioma. So always one thing, how to differentiate between the two. अगर बच्चे के midline में इतनी बड़ी swelling है and it is soft, it is compressible and pulsatile. Pulsatile क्यों? क्योंकि it is connected to the intracranial compartment. Also, this is a transilluminant swelling. You see, it is bluish. It means ये चमकेगी. It is transilluminant, right? And at the same time, also one thing you need to remember: if the child cries, अगर ये बच्चा रोता है, or if the बच्चा coughs, then the swelling will increase in size. If the child cries or coughs and the swelling increases in size, we call that test as Furstenberg's test. What is Furstenberg's test? Furstenberg's test means that if it is an intracranial neoplasm which has come out, or if it is an intracranial swelling which has come out or herniated, because of the increase in intracranial pressure during coughing or crying, there will be an increase in the size of the swelling, which is positive in cases of encephalocele. तो ये सॉफ्ट होती है, कंप्रेसिबल होती है, ट्रांसइल्यूमिनेंट होती है, पल्सिटाइल होती है, फुर्स्टेनबर्ग्स टेस्ट पॉजिटिव होता है. ये सारी चीजें नेगेटिव होती हैं व्हेन इट इज अ ग्लायोमा. ये बस होता है. ऑलवेज रिमेंबर दिस इज द क्लासिकल डिफरेंस. ये सब होगा एंसेफेलोसील में, ये सब एब्सेंट होगा ग्लायोमा में. दोनों के केसेस में वी डू एक्सिजन. ओके, दिस इज व्हाट यू नीड टू अंडरस्टैंड अमंग दीज टू. चलो अब सेप्टम पे आते हैं. सेप्टम इज वेरी वेरी इजी, सो आई डोंट नीड टू डू अ लॉट ऑफ थिंग्स इनसाइड इट. आई विल टेल यू द मोस्ट कॉमन क्वेश्चंस दैट आर आस्क्ड इन सेप्टम. Most common deformity of the nose is nasal septum, right? Nasal septum deviation. Most common cause of DNS is what? It is birth trauma that usually occurs due to obstructed labor or forceps delivery. This is something which is the one which causes the maximum chances of formation of DNS since birth. Now, what are the types of DNS? It could be anterior dislocation. Anterior dislocation का क्या मतलब है? That the moment you will raise the nasal tip, there will be dislocation of the septum outside. So you see, I raise the tip, the septum is dislocated. ये फोटो हमें याद रखनी है because it has come in your exams. So anterior dislocation is also given the name as caudal dislocation. जैसे ही हम tip elevate करेंगे, because the septum is not resting over the maxillary crest, it comes out. It gets dislocated. Next one is C shape. C मतलब C की तरह होगा, right? It is like a C. Third is S shape. It is like an S. Fourth is spur. Spur का मतलब it is a sharp projection at the bony cartilaginous junction. अब ये sharp projection कैसा होता है? You see this. See this. This is a sharp projection at the bony cartilaginous junction. We also call this as shelf-like projection. देखो ये shelf की तरह निकला हुआ है. We can keep a mug over it. This shelf-like projection. Okay. Finally, there is something called as septal thickening, जिसमें septum दोनों साइड पे thick हो जाता है. Okay. नाउ इंपॉर्टेंट क्वेश्चंस रिलेटेड टू द सेप्टम क्या आते हैं? इंपॉर्टेंट क्वेश्चन रिलेटेड टू द सेप्टम ये आते हैं, आई विल जस्ट राइट इट ओवर हियर. Which is the most common type of septal deformity which causes epistaxis? अब सबसे शार्प कौन सा है? सबसे शार्प होता है स्पर. तो स्पर is the most common DNS to cause epistaxis. Most common cause of Sludder's neuralgia is. अब what is Sludder's neuralgia? ये इंपॉर्टेंट क्वेश्चन है. Sludder's neuralgia का मतलब ये होता है, तो let's say this is your nose, this is your inferior turbinate, this is your middle turbinate. Middle turbinate is supplied by anterior ethmoidal nerve. Anterior ethmoidal nerve supplies middle turbinate. Okay? So if there is a deviation or if there is a spur which is impinging over the middle turbinate and it is irritating the anterior ethmoidal nerve, it will lead to a hemifacial pain. And that hemifacial pain, because of the irritation of anterior ethmoidal nerve, is given the name as Sludder's neuralgia. ये आता है second question. ठीक है? Right? Now let me come to the third question. Third question is paradoxical nasal obstruction क्या होता है? Paradoxical nasal obstruction means कि इस साइड पे DNS है. So what happens? There is a compensatory hypertrophy of the opposite side inferior turbinate. There is compensatory hypertrophy of the opposite side inferior turbinate, and this is why there is bilateral nasal obstruction. दूसरे साइड पे भी nasal obstruction आ जाएगा. This is a paradox. That is why it is called as paradoxical obstruction. These are the most important points that are asked as questions. Okay. Now, what is this test? If you put your two fingers on the nasolabial fold and retract, this is called as Cottel's maneuver, or this is also called as Cottel's test. This is a very important test for confirming whether my surgery will work or not. If the Cottel's test is negative, that means my surgery might not work after even if I do a septoplasty. Okay. Ab. Two important incisions. There are two surgeries that we do for septal correction. One is called as septoplasty, one is called as submucous resection. Right? Submucous resection is more radical. Septoplasty is more conventional. Right? For septoplasty, we give an incision at the caudal border of the septum. Caudal मतलब बिल्कुल आगे का, just where the septum is starting. This is called as Freer's incision. The other name for Freer's incision is hemitransfixation incision. So where do you give Freer's incision? You give it in septoplasty. Other name for Freer's incision, it is hemitransfixation incision. If I do an SMR or submucous resection, then I give an incision 5 millimeters posterior to my caudal border. This incision is called as Killian's incision. So Killian's incision is given in SMR, Freer's incision is given in septoplasty. Very important figure. Okay? चलो आगे बढ़ते हैं. Now, let's say you did a septoplasty. और septoplasty में आपने देखा, septoplasty करने के बाद your patient started having intense nasal pain. Now, when the patient complained of intense nasal pain, you went and you saw the patient, you saw that there are two bulbous swellings which are red in color in bilateral nasal cavity. What is your diagnosis? Diagnosis is septal hematoma. Most common complication of septoplasty is septal hematoma. So now, once what has happened? Now there is collection of blood within the mucoperichondrium. Beneath the perichondrium, there is collection of blood, and that will lead to bilateral bulbous swelling, which is called as septal hematoma. Okay, what exactly will you do? The treatment of choice of septal hematoma is aspiration. हमेशा हमें इसमें needle लगा के इसको aspirate करना है. We need to aspirate out all the blood, or we need to give an incision and we need to drain out the blood. If we don't drain out the blood, if we don't do an aspiration, what will happen? This septal hematoma will keep forming and it will keep compressing over the cartilage. And cartilage के जो chondrocytes होते हैं, they can only live for 72 hours in such conditions. If the cartilage chondrocytes get dead, आपने 72 hours के अंदर drainage नहीं किया, then what will happen? The nose will become saddled. वो permanently damage हो जाएंगे chondrocytes and they will necrose and the nose will become a saddle. Saddle मतलब बिल्कुल जैसे horse के ऊपर बैठते हैं ना, like a saddle. So that is called as a saddle nose deformity. So what is the sequelae that will form after untreated septal hematoma? It is saddle nose deformity. Or it will form an abscess which is called as septal abscess. So that is why this particular area is very, very important, because if septal hematoma does not get treated, it will form into an abscess also. So there is something called as a dangerous triangle of the face. And what is that? If I draw an imaginary line from the dorsum of the nose down to the angle of the lip, इस तरीके से this area is called as dangerous triangle of my face. That means all my facial veins which are present in this area are valveless. उनमें valve नहीं होते. and that is why retrograde infection can travel into the cavernous sinus, causing cavernous sinus thrombosis. So if there is any infection that happens in this area, it's potentially it can lead to cavernous sinus thrombosis. So if there is collection of pus, we need to treat it as soon as possible. That is why septal abscess is dangerous. Okay, fine. Chalo aage badhte hain. Now, another thing that can happen, another thing is septal perforation. So now Shubham is asking, won't it lead to more bleeding? No, bleeding nahi hogi because this is a collection within the mucosa. So now, अब ये mucosa बढ़ता चला जाएगा. ये mucosa के within है, तभी ये पस ये under tension है. If it bleeds, then it won't be under tension, right? So there won't be any bleeding in those cases. You need to put an incision and release that. Okay. Now, if you accidentally take out a lot of cartilage and you injure the septum completely, then it can lead to something called as septal perforation, right? Which is a perforation that is present over the septal mucosa. Okay. Most common cause of septal perforation is, answer is trauma. Second most common cause of septal perforation is, it is granulomatous conditions like tuberculosis, syphilis, which cause intense destruction of the nasal mucosa. Now, what will you treat it by? You either treat it by a flap, तो हम एक local flap उठा के उसको close कर देते हैं, और या फिर एक बटन आता है जो बटन हम उसके अंदर लगा देते हैं. So let's say this is a septal perforation, तो उसके अंदर we seal it with the help of a button. उसके अंदर एक बटन लगा देते हैं, and this is called as a silastic button. जैसे हम septal button भी कहते हैं. Okay, fine. Okay, so now somebody is asking, Aniket is asking, Pillai and Pujari's textbook is an alternative to Dhingra's book. So in Dr. Pillai's and Dr. Pujari sir's book, even I am one of the author. I have written chapters on hypopharyngeal cancer in that textbook. So it is, I would say it is a very, very good book. It's a very standard textbook. It is a little larger than Dhingra, what we have created, but it is also a very good textbook if you can read. It's a beautiful textbook to read. Okay, chalo, usme you will find my name too. Chalo, now let's come. What is foreign body nose? Right. Now, agar aapke paas koi bhi question ye aata hai, that if there is a young boy who has got unilateral nasal obstruction and the patient has got acute history of foul smelling nasal discharge, what will be your answer? The answer is foreign body nose. So it is most common in children, unilateral nasal obstruction and foul smelling nasal discharge. This will be the thing that they will complain with, right? So now, what is the most dangerous foreign body inside any ENT tract? Koi bhi? It is button battery. Button battery contains a lot of potential chemicals which can lead to liquefactive necrosis of the mucosa, and that could lead to a perforation completely. That is why they are called as dangerous foreign bodies. So सबसे dangerous foreign body is button battery. Okay. Now let me come to what is if you find certain maggots or crawling creatures inside. So maggots are something which are the fly larvae. So these fly larvae usually come out and they start crawling inside. That is called as myiasis. If you find maggots inside the nose, it's called as myiasis. What is the management of maggots? Always the maggots are removed by application of turpentine oil. जहाँ पे भी maggots आते हैं, turpentine oil डाल दो. So turpentine oil is something which irritates maggots. They don't like, they get suffocated. So they will start crawling out. If they start crawling out, you can pick them and you can remove them completely. Okay, fine. Chalo. अब आगे आते हैं. What if you don't treat a foreign body? अब let's say वो foreign body पड़ी रही. अगर वो foreign body पड़ी रही, so what will happen? Let's say now this was the nose, right? And this foreign body kept lying there for a long time. It's a missed foreign body. Nobody paid attention. So what will happen as a reflex to it, as a body's response to this missed foreign body, what will it do? Body will start forming granulation tissue around it. Body will start forming granulation tissue around this foreign body. And later there will be deposition of calcium and magnesium salts. There will be deposition of calcium and magnesium salts around this foreign body. तो ये क्या बनाएगा? This will form a stone-like structure. एक stone बना देगा क्योंकि ये सारे salts हैं. So it will form a stone-like structure. देखो ये stone की तरह है. So this is a calcareous stone-like structure which usually occurs in missed foreign bodies as a complication, and this is called as rhinolith. This is called as rhinolith. Rhino matlab nose, lithos means stone. So if you find a stone-like structure inside the nose, it is called as rhinolith. It is because of the deposition of calcium and magnesium salts around the missed foreign body. Okay, how will you treat it? The only way to treat it is removal. So either if it is a small rhinolith, we can remove it in toto, मतलब एक साथ remove कर दिया total में. If it is a very big rhinolith, then we cannot just pull it out because it can abrade, it can cause septal perforation. In that case, we will do a piecemeal removal. Piecemeal मतलब छोटे छोटे टुकड़े करके we will take it out. Okay, fine. This is what is required for you as far as rhinolith is concerned. चलो अब आगे बढ़ते हैं. Now, bleeding from the nasal cavity is called as what? Bleeding from the nasal cavity is called as epistaxis. Okay? Now, very, very common question. Favorite question. कौन सी vessels बनाती हैं Kisselbach's plexus? Kisselbach's plexus is an area which is present on the anterior part of our nasal septum. It is contributed by 4 arteries which are derived from external and internal carotid artery. Okay? Very good. Already answer दे दिया. So 4 artery कौन सी होती हैं? Quickly revise करते हैं. Internal carotid artery gives a branch called as ophthalmic artery. Ophthalmic artery divides into anterior ethmoidal and posterior ethmoidal artery. Anterior ethmoidal artery goes and supplies the anterior end. ये पहली artery है which forms the Kisselbach's plexus. Anterior ethmoidal artery. तो आता यही क्वेश्चन है कि which among the following is not a contributor? तो उसमें आंसर होता है posterior ethmoidal. ऐसे याद रखना, right? तो posterior वाली नहीं involved होती है. So anterior ethmoidal is the first artery. Now let's come to external carotid system. External carotid artery gives a very important branch called as facial artery. Facial artery will give branch which will go from the superior labial part, means from the lip. And when it goes from the lip, it is called as superior labial artery. So superior labial artery gives it septal branch. So what is the second artery which forms Kisselbach's? Superior labial branch. ये lip से चढ़ेगी ऊपर. Second branch which is also given off from external carotid is maxillary artery. मैक्सिलरी आर्टरी की 2 ब्रांचेस होती हैं. एक ब्रांच होती है जो पैलेट से जाती है, एंड पैलेट से जो जाती है तो वो हो गई ग्रेटर पैलेटाइन आर्टरी. सेकेंड आर्टरी इज द लार्जेस्ट ब्रांच विच कॉन्ट्रीब्यूट्स एंड दिस इज कॉल्ड एज स्फीनोपैलेटाइन आर्टरी. अब इंपॉर्टेंट क्या आता है? स्फीनोपैलेटाइन आर्टरी इज ऑल्सो कॉल्ड एज आर्टरी ऑफ एपिस्टैक्सिस. ये बहुत इंपॉर्टेंट क्वेश्चन है. व्हाट इज आर्टरी ऑफ एपिस्टैक्सिस? सबसे लंबी आर्टरी विच कॉन्ट्रीब्यूट्स, इट इज स्फीनोपैलेटाइन आर्टरी. That is why sphenopalatine artery ligation is also the treatment for uncontrolled epistaxis. Okay, fine. This is a branch of maxillary artery, which is a branch of external carotid artery. अब questions क्या आते हैं epistaxis में? I have given you straightforward in 4 points. Most common cause of epistaxis in children क्या है? Trauma. They will keep scratching the nose. Most common cause trauma, right? And trauma to what? Trauma to the Kisselbach's plexus. So most common area which will bleed on epistaxis is Kisselbach's plexus. So Wilhelm Kisselbach ने सबसे पहले ये ढूंढा था. And there was another person whose name was Little. His name was Lawrence Little. And he was the first one who with Kisselbach's together gave this plexus. तभी इसका नाम Little's area भी है, तभी इसका नाम Kisselbach's plexus भी है. One was a surgeon, one was an anatomist, and they both got together and named this area. Right? So that is why it is called. अब एक और वेन होती है जो जस्ट हमारे कॉल्यूमिला. कॉल्यूमिला क्या होता है? ये पार्टीशन जो दिख रहा है ना उसका, दिस इज कॉल्यूमिला. जो कॉल्यूमिला के जस्ट पीछे होती है. एंड दैट ऑल्सो कैन ब्लीड. सो द सेकंड मोस्ट कॉमन एरिया टू ब्लीड इन चिल्ड्रन बिकॉज ऑफ ट्रॉमा अदर देन Kisselbach's plexus इज रेट्रोकॉल्यूमिलर वेन. रेट्रोकॉल्यूमिलर मतलब कॉल्यूमिला के पीछे. ओके. मोस्ट कॉमन कॉज ऑफ एपिस्टैक्सिस इन अडल्ट क्या है? अडल्ट में सबसे कॉमन कॉज होता है हाइपरटेंशन. That is why epistaxis is more posterior in adults, and we also call it Woodruff's plexus. So Woodruff's plexus is a plexus of veins which is present over on the posterior part of our inferior turbinate, and that is the one which bleeds most commonly in adults, mostly during hypertension. Okay, ये 4 points as it is पूछे गए. They are as it is questions in your exams. Okay, as far as epistaxis is concerned. अब कोई भी epistaxis का patient हमारे पास आता है, तो करेक्ट वेन वाली Woodruff, तो उसका ट्रीटमेंट का प्रोटोकॉल ये है. सबसे पहले हम क्या करते हैं? वी ऑलवेज टेल द पेशेंट टू पिंच द नोज एंड बेंड फॉरवर्ड. व्हाई? क्योंकि अगर पीछे बैठ जाएगा वो तो सारा का सारा ब्लड दे विल एस्पिरेट. So when you pinch the nose and you press forward, this is called as Trotter's maneuver. ये बड़ा important question है. What is Trotter's method? Bending forward with the nose pinched is called as Trotter's maneuver. Okay? Now, अब क्या करेंगे हम? We will take an endoscope and we will try to identify कि bleed कहाँ से आ रही है. अगर हमने bleeder ढूंढ लिया, if we have found the bleeder, then we will stop the bleeding from there. Thank you, Sapna. Thank you. तो अगर हमने bleeder ढूंढ लिया, so we will stop the bleeding from there. If we stop the bleeding from there, तो हम कैसे stop करेंगे? We have to do something. either we put a chemical or we put electrical current. अब chemical कौन सा put कर सकते हैं cauterization के लिए? Chemical that we can put is trichloroacetic acid or silver nitrate. So these are the two common chemicals which we can add there and वो chemically वो cauterize कर देगा, वो seal कर देगा blood vessel. Otherwise we can put a direct electrical current जिसे हम कहते हैं electrocautery. Right? Okay. अब आते हैं दूसरे साइड पे. दूसरे साइड पे ये कि ब्लीडर हमें मिला ही नहीं. We don't know where the bleeder is. उसके केस में हमें नोज को पैक करना पड़ेगा so that the bleeding can stop. So either we will do anterior nasal packing, we will do posterior nasal packing, and अगर फिर भी bleed नहीं रुकी, then we will have to ligate the sphenopalatine artery, which is called as TESPAL, transnasal endoscopic sphenopalatine artery ligation. मैंने बताया था artery of epistaxis is TESPAL, तो सबसे बड़ी artery को हमें ligate करना पड़ेगा, which we do it with the help of an endoscope. Right? This is how we manage epistaxis on a flowchart. कि किस तरीके से मैनेजमेंट होता है. TESPAL आपका क्वेश्चन पूछा गया. ओके, आगे बढ़ते हैं. अगर आपसे ये क्वेश्चन आया, ओके, नेजल douching इज इक्वल टू नेजल पैकिंग, नहीं. नेजल douching का मतलब होता है सफाई करना. तो वी टेक अ फ्लूइड एंड वी पुट इनसाइड द नोज, दैट इज डन इन एट्रोफिक राइनाइटिस. में आऊंगा. नेजल पैकिंग मतलब ही पैक, पट्टी रख दी, दैट इज पैकिंग. ठीक है. अब एक क्वेश्चन ये आया, व्हाट इज दिस इंसिजन? तो दिस इंसिजन इज यूजुअली गिवन इन केसेस ऑफ मैक्सिलेक्टमी. हम जब मैक्सिलेक्टमी करते हैं तब देते हैं. And this incision is called as Weber-Ferguson incision. Weber-Ferguson incision, which is done in cases of maxillectomy. जब हम maxilla को निकालते हैं, तो we raise the maxillary flap like this and we take out the maxilla. Okay. अब Ram is asking botroclot कैसे help करती है? Botroclot is basically derived from snake venom. तो bothropus एक snake venom होता है, right? It's a plant toxin, and that is something which locally causes it stabilizes the fibrin clot. जब इसे हम ऐड करते हैं तो जो क्लॉट बनता है उसे स्टेबलाइज करता है. So that is something which will prevent the rebleed to happen. That is why botroclot is very commonly utilized in ENT practice, right? But it is not FDA approved. It is still not FDA approved. अब आते हैं, what is this? This is on-Gren's line. On-Gren line क्या होती है? On-Gren line is usually a line done in cases of maxillary tumors. Maxillary tumors में क्या होता है? That if we draw an imaginary line from the medial canthus up till our angle of mandible. So what we do? We draw a line from the medial canthus up till the angle of mandible. From the medial canthus up till the angle of mandible. अगर कोई भी maxillary tumor is present below this line, then it is called as infrastructure. If there is any tumor which is present above this line, then it is called as suprastructure. Now remember, infrastructure tumor क्योंकि नीचे है line के, they have got good prognosis. Why? Because it is below. If there is a suprastructure tumor, मतलब on-Gren line के ऊपर, then actually it can go into the brain, it can go into the orbit, and that is why it has got poor prognosis. This is the whole meaning for on-Gren's line. How do we divide that into infrastructure and suprastructure tumors? Okay, fine. चलो आगे बढ़ते हैं. Now let's come to nasal fractures. Two important fractures. One is called as jar-Javet fracture. One is called as chevalet fracture. अगर किसी भी इंसान को we beat from the front or from the lateral side, मतलब ऐसे सामने से किसी ने मारा या फिर साइड से मारा, so what will happen? The fracture in the nasal septum will be called as jar-Javet. मतलब away मतलब जाने वाला. That means this fracture line will start from the anterior nasal spine. This projection here is called as anterior nasal spine, the anterior end where the septum is resting. And this line will go parallel to the septum and it will go towards the perpendicular plate of ethmoid. You can see it is going parallelly. ये ऐसे चढ़ रहा है. That is why it is called as jar-Javet, away जाने वाला. Right? Okay? Now, if someone hits you from below, कुछ इस तरीके से किसी ने मारा, तो अगर नीचे से किसी ने इस तरीके से मारा, तो what will happen? Then there will be a perpendicular fracture, क्योंकि अब blow नीचे से है. So if somebody hits you from below, then there will be a vertical fracture of the septal cartilage. If there is a vertical fracture of the septal cartilage, then we call this as chevalet. So chevalet is a vertical fracture. jar-Javet is going in the oblique direction, perpendicular to the septal and vomer junction. This is your vomer, this is septal cartilage. इनके junction से perpendicular जा रहा है, right? Parallel जा रहा है. That is what is called as jar-Javet fracture. So remember, points to remember, jar-Javet सामने से होता है, chevalet नीचे से होता है. शेवलेट परपेंडिकुलर होता है, जर्जवे गोज पैरेलल टू द सेप्टल एज वेल एज द वोमर जंक्शन. ओके, नाउ प्रणव इज आस्किंग दैट कितने क्वेश्चंस ईएनटी में एक्सपेक्टेड होते हैं. इस सब आ जाएगा इसमें से, there's nothing that will come out. ये सारे क्वेश्चंस का amalgamation है, that's why we have created the workbook. इस जितनी वर्कबुक में जितनी चीजें हैं, that's why I have concised the whole workbook into aroundish about 70 to 80 pages. उसमें सारी की सारी ENT के जितनी चीजें हैं सब क्वेश्चंस हैं. You read that much, that's more than enough. उससे ज़्यादा कुछ नहीं है, right? Expected questions are aroundish about 10 to 12 questions, but always remember minor subjects जितने होते हैं, ये जितने भी 10-12 क्वेश्चन वाले सब्जेक्ट्स हैं, they are the rank deciding subjects. They are the ones which decide the rank. So that is why don't get anything wrong इसमें, क्योंकि ये स्ट्रेट फॉरवर्ड क्वेश्चन हैं, ये बहुत इजी आंसर्स हैं. ओके फाइन, चलो नाउ ओके नाउ वी कम टू द नेक्स्ट वन, CSF rhinorrhea. Okay, CSF rhinorrhea is what? CSF leaking out from the nose. That's called as CSF rhinorrhea. CSF rhinorrhea के अपने set signs हैं. Okay, now the first sign of CSF rhinorrhea is what? It is called as halo sign या target sign. अगर किसी आपने इमरजेंसी में देखा that there is a patient who is bleeding from the nose and he has got intracranial injury, maybe he also has CSF leaking out. आप कैसे बताएंगे इसमें CSF है कि नहीं? वो तो आप ब्लड दिखेगा. So what we will do, we will take a blotting paper and we will keep it just below the nose. And that blotting paper पे एक ड्रॉप गिरेगी तो सडनली क्या होगा, जो ब्लड होता है वो हैवी होता है. So the blood will stay in the center and the CSF is light. So the CSF will form a rim around the blood. So that is why this is also called as halo sign, because it creates a halo. Also called as a bullseye sign क्योंकि bullseye की तरह दिखता है. Also called as target sign क्योंकि ऐसे लगता है किसी ने टारगेट लगा दिया है. This is seen in traumatic CSF rhinorrheas. Okay. Second sign is sniff sign. Sniff sign का मतलब nasal discharge भी colorless होता है. Even CSF is colorless. How will we differentiate? We will ask the patient to sniff back. अब जब भी कोई भी nasal discharge आता है आप sniff करते हो ना, कर लेते हो. But CSF you cannot sniff back. That is called as CSF sniff sign. Sign is hanky sign या handkerchief sign. Handkerchief sign का क्या मतलब होता है? CSF does not have mucus. Nasal discharge has mucus. So how to differentiate between the two? आप कहोगे कि hanky लो, take out your nasal discharge. If you have got mucus, that hanky will crumple. बिल्कुल सख्त हो जाएगा hanky. You must have seen, right? But अगर CSF है, that handkerchief will not crumple because it does not have any mucus. This is called as handkerchief sign. Fourth sign is reservoir sign. Reservoir sign का क्या मतलब है? That when the patient is sleeping, supine लेटा हुआ है, what will happen? The CSF will keep collecting inside the sphenoid sinus. वो पीछे होता है, उसमें collect होता रहेगा. The moment the patient will get up, under gravity, all the CSF बड़बड़ will start coming out. That means that sphenoid sinus has acted as a reservoir for all the CSF that has come out. Right? So this is called as reservoir sign. The sphenoid sinus acts as a reservoir. Okay, right? So this is something which is also seen. Now, if you bend the head, the CSF will start dropping like somebody is pouring tea into a pot. That is why it is also called as teapot sign. Teapot sign is something जैसे कोई tea ऐसे गिराता है ना, ऐसे like a tea. So ऐसे tap, the CSF will start coming out. So this is called as teapot sign, which is also a particular sign seen in CSF rhinorrhea. Okay. Now, this confirms clinically. But biochemically क्या हम confirm कर सकते हैं CSF? Yes, there are certain important proteins which are only present in CSF, nothing else. CSF में जो certain proteins हैं, these are released from the choroid plexus, where the CSF is getting formed. And two proteins which are released in CSF are beta-2 transferrin and beta-trace protein. So the most important investigation of choice for biochemically telling this is CSF is either you take beta-2 transferrin levels or you take beta-trace protein levels. अब एक क्वेश्चन इंपॉर्टेंट ये आता है कि अभी तक योर करंट आंसर्स में beta-2 transferrin is the choice, right? But if you are given anything related to beta trace protein, remember beta trace protein is almost 100% sensitive and 100% specific. Beta trace protein is a better answer than beta-2 transferrin if both of them are given. Otherwise they will give beta-2 transferrin only. Okay, so remember that both में से सबसे ज़्यादा sensitive is beta trace protein. What is the radiological investigation of choice? You'll do a CT or an MR cysternography. Okay, to check which site the CSF leak is coming from. Okay, chalo. How do you manage it? अब आपके पास ये क्वेश्चन आएगा कि CSF rhinorrhea किसी को हुआ है, the patient had got trauma, what is the line of management that you will do? The line of management that you will do in such cases will always be conservative first. First is conservative in order to get down the active leak. It is not something we straight away go for surgery. So conservative mein I have given you a mnemonic A cube BCD. First, avoid the patient to strain. Any heavy work, no straining. No straining during micturition, no straining during stool passage. Tell the patient to start taking antibiotics in order to prevent meningitis. Tell the patient to start taking antihistamines. Why? Because you don't want the patient to sneeze. Tell the patient to take complete bed rest and keep the position of the bed a little propped up. क्योंकि हमें पता है जब वो सीधा सोएगा, it will turn into reservoir sign. So elevate the head end a little bit, 45 degrees, so that there is decreased intracranial pressures. Then comes give. For constipation relief, give stool softeners, okay? And then finally give diuretics such as carbonic anhydrase inhibitors. जिसमें क्या आता है? Acetazolamide. What is acetazolamide? It's a carbonic anhydrase inhibitors. It will decrease the production of CSF from the choroid plexus. So obviously, अगर CSF decrease हो गया, then the pressure also will come down. This is a conservative management, what you do in cases of CSF rhinorrhea, okay? And only in cases if the CSF rhinorrhea is uncontrolled, we do something called as endoscopic leak repair, where we need to stack up बहुत सारी चीजें. तभी हम इसे सैंडविच टेक्निक भी कहते हैं, क्योंकि उसमें हम फैट लगाते हैं, we keep cartilage, we keep temporalis fascia, we keep mucosa, बहुत सारी चीजों की we keep stacking up so that the CSF does not flow down. तभी वो सैंडविच की तरह बन जाता है. We call it as a sandwich technique. But just you need to remember what do? We do an endoscopic leak repair. That's all. Okay, fine. चलो. अब आते हैं rhinosporidiosis. Now we come into granulomatous disease of the nose, right? Granulomatous diseases of the nose में दो important diseases you should be knowing in and out. One is rhinosporidiosis, one is rhinoscleroma. That is something very, very important. Okay, rhinosporidiosis. So causative organism, Rhinosporidium seaberi. What is Rhinosporidium seaberi? It is an aquatic protestin. Initially, it was found to be a fungus. But now we have classified as an aquatic protestin. तो क्योंकि ये water bodies में रहता है, and that is belonging to the class Mesomycetozoa. It belongs to the class Mesomycetozoa. Now always remember, whenever this rhinosporidiosis is asked to you, they will always say that there is a patient and usually belongs to the southern part of India, and he has got a peculiar feature of swimming in local ponds, and now the patient has got a lesion in the nose which bleeds on touch. So now this is a classical history. If the patient is from the southern part of India, mostly from areas like Tamil Nadu or Kerala, they have got a lot of water bodies, and a lot of swimming happens into these local ponds. So this is an aquatic protestin which resides in these local ponds, and if it goes straight away inside the nose, it can form these kind of lesions which are called as rhinosporidiosis. Okay, fine. So they will have a swimming in local and dirty water. Okay. Now clinical features are what? You will always find a strawberry-like mass. ये याद रखना है. What is a strawberry-like lesion? Strawberry मतलब red and white, right? So this looks red, and inside there are something which are white, right? Now what are these white spots? These white spots are nothing but sporangia. They are sporangia, which is containing within the rhinosporidiosis, right? So sporangia are nothing but these are the sporangia which contains these basophilic spores of the organism. You can see these are basophilic stains. Spores, which are the infective unit of this rhinosporidium. So these spores are present inside what? They are present inside sporangia, which look white over this mass. This is a classical rhinosporidiosis picture. Now how will it present? Obviously एक तरफ mass है, so it looks red, it is very vascular, it will bleed, and it will cause unilateral nasal obstruction also. How will you treat this? For obvious reasons, how will we treat this? We will treat it by surgery. We will take this mass out, and when we take this mass out, we need to burn the base. Burn the base matlab we will cauterize the base so that this does not come back, because it has got a very high chance of recurrence. Now, in order to prevent recurrence, what is the drug of choice for rhinosporidiosis? It is Dapsone. How much you give? You give 100 mg once a day at least for 3 to 6 months, because it is a chronic granulomatous disease, right? So this is something that it could be Dapsone. It could be bilateral, but very rare, very, very rare. Okay, mostly it is unilateral. Okay, fine. Chalo, ab aage badhte hain. Now we come to the next granulomatous disease of the nose, that is called as rhinoscleroma. Rhinoscleroma kahan se aaya? Klebsiella rhinoscleromatis. The other name for rhinoscleroma or Klebsiella rhinoscleromatis is what? It is Frisch bacillus. It was Frisch who found out, so that's why it's also called as Frisch bacillus. There are 3 stages of rhinoscleroma. 3 stages में ये होता है. First stage is called as atrophic stage. Atrophic stage is just like atrophic rhinitis. मतलब सारा mucosa अंदर का will get atrophied. The mucosa, the bones, they will start getting atrophied and there will be crust formation inside the nose. So there will be crusting and foul smelling nasal discharge that will be present in the earlier stages. Okay? Now in the next stage what will happen is they will start forming nodules. This is very, very important. So if you see a nose of a rhinoscleroma, they will classically form these kind of big nodules. You can see that. And these nodules are firm. They are hard, wood-like hard. We call it as woody hard, right? And they do not ulcerate. Always remember, if they give you any particular question where they have told that nodules are not ulcerating, they are talking about rhinoscleroma. Because generally nodules ulcerate karte hain. These are the nodules which never ulcerate. They break and they heal with fibrosis. So whenever they break, they heal with fibrosis. That is what will be the problem with this, right? But in the granulomatous stage, there will be granulomatous nodules which will form, which will not ulcerate. They will be firm. They will be woody hard. And because itne sare nodule ban jate hain, the whole nose becomes very broad. You can see this nose has become very, very broad. So this actually looks like a cross between a zebra and a horse, जिसे हम लोग कहते हैं हेब्रा. Right? So zebra और horse को अगर cross करते हैं तो उसे कहते हैं हेब्रा. So this is called as a hebra nose deformity. Question यही आता है. Hebra nose deformity is seen in rhinoscleroma. और ये कुछ ऐसी ही दिखती है. Right? Now I told you one more thing that this does not heal with ulceration. This heals with fibrosis. मतलब ये nodules टूट जाते हैं and they shrink and they fibrose. If they fibrose, then what will happen? ये अब नाक बहुत पतली हो जाएगी because now they have fibrosed. तो इसे कहते हैं स्टेज ऑफ सिकेट्राइजेशन, विच इज द थर्ड स्टेज ऑफ राइनोस्क्लेरोमा. सिकेट्राइजेशन का मतलब होता है फाइब्रोसिस, क्योंकि अब नोड्यूल्स फाइब्रोज हो गए. तो इन द ग्रैन्युलोमैटस स्टेज वी सॉ हेब्रा डिफॉर्मिटी. इन द सिकेट्रेशियल स्टेज व्हेन द होल नोज विल बिकम फाइब्रोज्ड, इट विल बिकम वेरी थिन एंड टेपर्ड. अजीब सी. एंड दिस एक्चुअली लुक्स लाइक एन एनिमल्स नोज. और इस एनिमल का नाम है, इसका नाम है टापीर. इट इज अ हर्बीवोर. इसका नाम होता है टापीर. एंड टापीर की एक छोटा सा स्नाउट होता है, तो इसीलिए इसकी नाक एंड दिस नोज एक्चुअली लुक्स लाइक द सेम. तभी इसका नाम होता है टापीर नोज डिफॉर्मिटी. टापीर नोज इज सीन इन विच स्टेज? इट इज सीन इन सिकेट्रेशियल स्टेज. नाउ अनफॉर्चुनेटली वी कांट ऑपरेट ऑन ग्रैन्युलोमैटस स्टेज, क्योंकि यहां पे नोड्यूल्स आर ऑलरेडी फॉर्मिंग. बट व्हेन द टापीर नोज इज फॉर्म्ड, दिस इज द टाइम वी एक्चुअली ऑपरेट ऑन, व्हेन द होल लाइफ साइकिल ऑफ द ऑर्गेनिज्म हैज वॉश्ड अवे, जब पूरी तरीके से द पेशेंट इज नॉट इन्फेक्टिव. So in this case, in tapir nose deformity, we do septorhinoplasty. Septorhinoplasty का मतलब we have to actually make the whole of the septum. We have to reconstruct the whole of the septum again. That's called as septorhinoplasty. We take a rib and we apply it over there. That's called as septorhinoplasty. Okay, fine. Okay. Now, another important point is कि अगर granulomatous stage है तो इसको treat कैसे करेंगे? So the treatment of choice for this is tetracyclines. So tetracyclines are the drugs which are the treatment of choice for rhinoscleroma. Okay, and also we can apply a local solution over it, and that local solution is called as acreflavin. Acreflavin is a local solution जिससे ये nodules जो हैं shrink कर जाते हैं. Right? Okay. So this is something what you should require in cases of rhinoscleroma. Okay. Catarrhal stage, sclerotic stage is same, atrophic. Catarrhal stage मतलब होती है जिसमें कोई सिर्फ जनरल फीचर्स दिखें. तो कैटरल स्टेज इज द वन विच इज द फर्स्ट स्टेज, द एट्रोफिक स्टेज. वो कैटरल स्टेज है. ओके, स्क्लेरोटिक नहीं है. स्क्लेरोटिक नहीं, वी कैन कॉल इट सिकेट्रेशियल स्टेज. दिस इज द वन, दिस इज द थर्ड स्टेज. ओके, फाइन. चलो, अब व्हाट इज द हिस्टोपैथोलॉजिकल फाइंडिंग? ये बड़ा इंपॉर्टेंट क्वेश्चन है. Two important things you see in rhinoscleroma. One is called as Mikulicz cells, one is called as Russell body. What do you understand by Mikulicz cells? When you take a histopathology of rhinoscleroma, you will see foamy macrophages. ये देखो खूब सारे खाली cells दिख रहे हैं. These are called as foam cells. We also call them as foamy macrophages called as Mikulicz cells. And inside that you can see there are certain pink inclusions. You can see certain pink areas, कुछ pink inclusions है. If I actually draw that, तो कुछ इस तरीके का होता है. These are the pink inclusions. और pink inclusions क्या होते हैं कि these are nothing but plasma cells inside which these antibodies or immunoglobulins have clustered. At one end of the plasma cells, these immunoglobulins get clustered and they become eosinophilic. And these plasma cells stain eosinophilic and they are called as Russell bodies. So Russell bodies are characteristically seen in rhinoscleroma. Micelic cells is characteristically seen in rhinoscleroma. Russell bodies are nothing but these plasma cells which have these aggregated immunoglobulins which stain eosinophilic. Okay, fine. Chalo. Okay, now we come to acute sinusitis and its complications. But इसमें एक ही क्वेश्चन इंपॉर्टेंट है जो आपको करना है acute sinusitis से related, and that is what you will find this kind of a gentleman's image. What is this? What is this? This is called as Pott's puffy tumor. What is Pott's puffy tumor? Pott's puffy tumor occurs due to frontal osteomyelitis. Frontal osteomyelitis क्या होती है? That the frontal sinus has got discharge. It has got a lot of pus. So when the frontal bone breaks, it starts to collect certain pus subperiosteal. मतलब subperiosteal collection. Just skin के नीचे subperiosteal there is a collection of pus. It looks like a tumor, but actually it's not. It's called as Pott's puffy tumor. Okay. अब आपको ये कुछ दिख रहा है यहाँ पे. What is this? What is this X-ray image? This is very, very important. This X-ray image is called as what? So this is called as an open mouth modified Waters view, also called as Pier's view. Okay, so this is an open mouth. You can see the mouth is open and patient ऐसे करा हुआ है, right? So this is modified Waters view, या फिर we can also call it as a Pier's view. Now, what is the best view to see maxillary sinus? The maxillary sinus can be seen best on Waters view. Frontal sinus can be best seen in Caldwell view. ये दो चीजें हमें याद रखनी है. तो Caldwell view में सबसे अच्छा frontal sinus दिखता है. Waters view में सबसे अच्छा maxillary sinus दिखता है. Okay. Now what do you see in this image? You see that there is something white below and above there is air जो black है. So this is called as air fluid level. अगर air fluid level दिखा हमें maxillary sinus में, this is a classical feature that is seen in cases of acute sinusitis. Acute sinusitis में क्या होता है? There is air fluid level. नीचे fluid white होगा, ऊपर air black होगी. So this is called as air fluid level. What sinus is seen through the open mouth? ये कौन सी दिख रही है sinus? Through the open mouth we can see the sphenoid sinus. This is the sphenoid sinus which we can see through the open mouth. Okay. Now Pranav is asking, sir कितने questions करने हैं कि वापस ENT ना देखना पड़े? Workbook कर लो, everything will be sorted. That is why I have designed the workbook for you all. That is all. बस यही करना है, right? I've already taken a session of PYQs which you have already seen, right? PYQs अभी है जिन लोगों ने नहीं देखा है. I've discussed all the potential NEET questions उसमें, right? And finally इस workbook में सारे questions जो आ सकते हैं वो भी सब हैं. So it completes all in all जो इतना जितना ENT में चाहिए. इसके अलावा you don't need anything else. Okay, fine. चलो बढ़े आगे. अब let's come to nasal polyp. ठीक है? What is nasal polyp? What do you understand with nasal polyp? Right? So nasal polyp का क्या मतलब है? नेजल पॉलिप ऐसी चीज होती है जो नाक के अंदर कूद के आती है. हॉप, इट हॉप्स इनसाइड द नोज. सो दैट मीन्स अ नेजल पॉलिप हॉप करता है इनसाइड द नोज. दैट मीन्स लेट्स से ये साइनस की बोन है एंड बोन ऑफ साइनस के ऊपर होता है म्यूकोजा. देयर इज म्यूकोजा ऊपर ओवर द बोन ऑफ द पैरानेजल साइनस. अब अगर कभी भी किसी भी पेशेंट के कोई एलर्जी हो गई और लेट्स से इन्फेक्शन हो गया, दिस म्यूकोजा विल बिकम स्टिम्युलेटेड एंड ये क्या करेगा? ये हॉप आउट कर जाएगा. हॉप का क्या मतलब हुआ? हॉप का मतलब हुआ इट विल बिकम हाइपरट्रॉफीड, इट विल बिकम इडीमेटस एंड इट विल बिकम प्रोलैप्स्ड. तो ये नॉर्मल म्यूकोजा ही है, बट अंडर द पॉसिबल इन्फेक्शन एज वेल एज एलर्जी, दिस म्यूकोजा इज हॉपिंग आउट इन द फॉर्म ऑफ अ पॉलिप. दिस इज कॉल्ड एज नेजल पॉलिप. राइट? सो शुभमन इज सेइंग ENT का फॉर्मो चला गया. आई एम वेरी हैप्पी. I'm very, very happy that you guys are enjoying and you are very active. Okay, so just keep holding on. हम पूरी ENT खींच देंगे आज रात. This is what is called as nasal polyp, right? Now there are two types of polyp. अब इनसे क्या question आते हैं? One is called as antroconal, one is called as ethmoidal. अगर कभी भी ऐसा question आए that there is a young boy or a girl who have got unilateral nasal obstruction, there is a gray glistening mass, the answer is antroconal. एंट्रोकोनल पॉलिप हमेशा यूनिलैटरल होता है and it is called antroconal because it arises from the maxillary sinus. Maxillary sinus का दूसरा नाम is antrum of Highmore, तभी इसका नाम एंट्रो है. ये निकलता है वहां से and it goes into the quana. Quana मतलब posterior quana, पीछे जाता है. That's why it is called as antroconal. So that is why if ever you get unilateral nasal obstruction, young person with any mass which is gray and glistening. So young person, gray glistening mass arising from the maxillary sinus, and answer is antroconal polyp. What is the most common cause of antroconal polyp? It is infection. Simple, ठीक है. अब अगर आपको ये क्वेश्चन आए कि पेशेंट 40-50 साल का है, बायलैटरल नेजल ऑब्स्ट्रक्शन है, ग्रेप लाइक मास है, आंसर बिकम्स एथमोइडल, क्योंकि एथमोइडल बायलैटरल होता है, ग्रेप मल्टीपल होते हैं, ग्रेप लाइक होता है, एंड दे आर यूजुअली एसोसिएटेड टू लॉन्ग स्टैंडिंग एलर्जी. So long standing allergy occurring from the ethmoidal sinus, older people, multiple grape like bilateral. This is something related to ethmoidal polyp. I'm going to show you the images also. Okay. Now medical line of management अगर हमें करना हुआ तो medical line of management is not at all going to be any significant in antroconal, क्योंकि antroconal is something which is happening because of infection. हम उसमें क्या medical management करेंगे? We just remove the polyp. Answer is sorted. That is why the treatment of choice for antroconal is FES. Functional endoscopic sinus surgery. But if there is ethmoidal polyp, it is happening due to allergy. Allergy is a type 1 hypersensitivity which occurs in the body. So we need to cut down the allergy. That is why recurrence is very high. Even if we do FES, that is why we need to give a medical line of management first, जिसमें antihistamine देने पड़ेंगे allergy के लिए, steroid देने पड़ेंगे allergy के लिए, and then we need to remove the polyp and do FES. Okay, so both the things are important. इसमें FES बहुत है. Don't need to do anything else, but इसके केस में we need to do something. We need to do a medical line of management so that the recurrence is not common. Okay. Now let me show you the important questions. ये question हाल में आया है in your INICET exam, where they gave you a lot of triads related to ethmoidal polyp, और उनका पूछा था इसमें से कौन सा match the following में correct नहीं है. So let me just tell you what are the causes of ethmoidal polyp, because I told you antroconal का main polyp का cause is infection, but ethmoidal के काफी causes होते हैं, and there are 4C and 4A of ethmoidal. अब 4C का मतलब क्या है? अगर उन्होंने ये बोला that this ethmoidal polyp is present bilaterally in a child and the sweat chloride test is positive, answer is इस बच्चे के cystic fibrosis है, because sweat chloride test is significant for cystic fibrosis. Second is obviously if the patient has chronic sinusitis, तो हो गई polyp, that is the second C. Third syndrome is Churg-Strauss syndrome. Churg-Strauss syndrome is again vasculitis. So what will it lead to? It will lead to rapidly progressive glomerulonephritis. Patient will come as eosinophilia and asthma. So this is the triad present for Churg-Strauss syndrome. अब ये triad बड़े important है. दो syndromes आते हैं. One is called as Carotenoids syndrome. One is called as Young syndrome. Carotenoids syndrome और Young syndrome में बस एक word का difference है. बाकी कोई difference नहीं है. कार्टेगनस सिंड्रोम का मतलब क्या है? सीलिया काम नहीं कर रहे. दैट मींस नाक में सीलिया काम नहीं कर रहे, लंग में सीलिया काम नहीं कर रहे. इफ दे डोंट हैपन, इफ दे डोंट वर्क इन द नोज, इट विल कॉज साइनोसाइटिस. इफ दे डोंट वर्क इन द ब्रोंकाई, इट विल कॉज ब्रोंकिएक्टासिस. राइट? ओके, सो साइनोसाइटिस प्लस ब्रोंकिएक्टासिस. और तीसरा ट्रायड इन कार्टेगनस इज साइटस इनवर्सस. साइटस इनवर्सस मतलब ऑर्गन उल्टे हो गए. नाउ द हार्ट इज नॉट टुवर्ड्स द लेफ्ट, इट्स टुवर्ड्स द राइट. That's organ उल्टा हो गया. Situs inversus. What is the only difference with young? Young लोगों में क्या होगा? Azoospermia that occurs due to obstruction at the epididymis, क्योंकि वहां पे भी सीलिया हैं. So that is what is the only difference. इसमें भी sinusitis है, इसमें भी bronchiectasis है, पर यहां पे लगा दिया azoospermia. तो young में azoospermia, Carotenoids में situs inversus. This is the only two difference that you will see in cases of both these syndromes. बस ये ध्यान रखना, young से azoospermia. Okay? अब आ जाते हैं 4A पे. 4A में एक हो गया एस्थमा, एक हो गया एलर्जिक राइनाइटिस, एक हो गया एलर्जिक फंगल राइनोसाइनोसाइटिस. इसके बारे में हम बात करेंगे. एंड फाइनली देयर इज समथिंग कॉल्ड एज एस्पिरिन इंटॉलरेंस, एस्थमा एज वेल एज पॉलिप्स. तो आम आदमी पार्टी होती है ना, AAP, एस्पिरिन इंटॉलरेंस, एस्थमा एंड पॉलिप्स. दीज टुगेदर फॉर्म व्हाट? दीज टुगेदर फॉर्म सैम्टर्स ट्रायड. इसे हम कहते हैं सैम्टर्स ट्रायड. दिस इज व्हाट यू गाइज नीड टू रिमेंबर. What is Samter's triad? ये बहुत बार पूछे जाने वाला क्वेश्चन है. ओके, चलो अब आगे बढ़ते हैं. अब देखो, अगर किसी के एंट्रोकोनल पॉलिप है, so that polyp, if you do a lateral X-ray, so how will it look? I told you it comes out of the maxillary sinus and when it comes out of the maxillary sinus, it will go towards the quana. देखो ये grey color का polyp है, and it is growing towards backside. It is growing towards the quana. But what are you seeing over here? That in this there is a crescent of air. इसके पीछे there is a shadow of air. देखो air हमेशा black दिखती है. You can see there is air over here, and this air actually looks like a crescent. Crescent की तरह है. That is why this is also called as crescent sign. So crescent sign is a sign which is due to a cuff of air, which is seen in cases of AC polyp. इसे हम लोग डॉट साइन भी कहते हैं. We also call it as dot sign, also called as crescent sign. Okay, there is a cuff of air present behind the AC polyp. Now, how will the ethmoidal polyp look like? I told you ethmoidal polyp multiple होते हैं, grape like होते हैं, बहुत सारे होते हैं. These are gray, glistening, hypertrophied, edematous, prolapsed. Hop. Hypertrophied, edematous, prolapsed mucosa, multiple, grape-like, bilateral. Right? So this what finishes about कि हमें polyp में क्या पता होना है. This all finishes about what is polyp. चलो अब आ जाते हैं इंपॉर्टेंट राइनाइटिस से रिलेटेड क्वेश्चंस पे. क्या क्या राइनाइटिस से रिलेटेड क्वेश्चंस आते हैं, राइट? व्हाट आर द इंपॉर्टेंट रिलेटेड राइनाइटिस क्वेश्चंस? सबसे कॉमन राइनाइटिस नोज की क्या होती है? आपको सबसे कॉमन क्या होता है? कॉमन कोल्ड. कॉमन कोल्ड का दूसरा नाम होता है कोराइजा. इट इज ऑल्सो कॉल्ड एज कोराइजा, विच इज द मोस्ट कॉमन कॉज ऑफ राइनाइटिस इन योर नोज, राइट? नेक्स्ट कम्स राइनाइटिस मेडिकामेंटोसा. अब ये बड़ा इंपॉर्टेंट क्वेश्चन है. If you get a patient's history where they have told you the patient has got obstruction in the nose which has worsened and the patient is a chronic user of oxymetazoline or xylometazoline drops, यानी ऑट्रवेन और इस टाइप की ड्रॉप्स बहुत टाइम से लेता आ रहा है, तो व्हाट हैपेंस? दैट आंसर ऑटोमेटिकली बिकम्स राइनाइटिस मेडिकामेंटोसा. ओके, तो व्हाट इज राइनाइटिस मेडिकामेंटोसा? टर्बिनेट्स होते हैं, टर्बिनेट्स के ऊपर ब्लड वेसल्स होती हैं. If we give any kind of nasal decongestant drug like oxymetazoline or xylometazoline, they will cause shrinkage of these blood vessels. And अगर ये blood vessels shrink हो जाएंगी, then it will lead to shrinkage of the turbinate. If there is shrinkage of the turbinate, सांस अच्छी हो जाएगी because there will be more space. Now always remember what are the receptors which are present over these blood vessels? They are alpha 1 receptors, right? Which are present over these blood vessels. If you keep using Otorhinolaryngology or if you keep using oxymetazoline, xylometazoline, there will be down regulation of these alpha 1 receptors. अब ये काम करना बंद हो जाएंगे. These alpha 1 receptors undergo down regulation. And because of the down regulation that they have undergone now, if you keep adding these drops, it will lead to rebound congestion. अब क्या होगा? Now the turbinates will swell up because of rebound congestion. अब काम ही नहीं कर रहे हैं वो. And this is the reason what is called as rhinitis medicamentosa. Now the obstruction has increased even after using drugs. Now what is the only way to reverse this? Only way to reverse this is using steroids. So the best way of reversing this is utilization of nasal steroids, that is topical steroids, and stop using decongestant drops. तुरंत decongestant drops को बंद कर दो. Okay, fine. हाँ, तो rhinitis medicamentosa could be one of the causes of atrophic rhinitis. Okay, it could be one of the causes. अभी हम आएंगे उस पे. अब तीसरा क्वेश्चन आता है rhinitis सिक्का. सिक्का मतलब ड्राई. ड्राई कहाँ पे होगा? डेजर्ट में ड्राई होगा. ये बेकिंग इंडस्ट्री में जितने लोग काम करते हैं, बेकर्स, उनमें ड्राइनेस होती है. तो इफ देयर इज क्रस्टिंग प्रेजेंट इन द एंटीरियर 1/3 ऑफ द नोज ओनली एंटीरियर 1/3 ऑफ द नोज में बहुत सारी क्रस्ट बन गए हैं, वी विल कॉल दैट पर्टिकुलर एज rhinitis सिक्का. और अगर सिर्फ एंटीरियर 1/3 में क्रस्टिंग हो रही है, बाकी पूरी नोज नॉर्मल है और कुछ प्रॉब्लम नहीं है, दिस इज यूजुअली सीन इन केसेस ऑफ बेकर्स. दैट इज व्हाई इट इज आल्सो कॉल्ड एज बेकर्स नोज. इट इज आल्सो सीन इन केसेस ऑफ आयरन स्मिथ, क्योंकि वो वहां पे बहुत गर्मी होती है. दैट इज व्हाई दे गेट दिस क्रस्टिंग ओवर द एंटीरियर 1/3 ऑफ द नोज. ओके, फाइनली कम्स वेजोमोटर राइनाइटिस. वेजोमोटर राइनाइटिस, वेजोमोटर का मतलब ही हो गया ब्लड वेसल से रिलेटेड. Whenever there is sympathetic nervous system which acts on the blood vessel shrinks. Whenever there is parasympathetic nervous system which acts on the blood vessel dilates. तो नॉर्मली हमारे क्या हो रहा है? नॉर्मली हमारे पूरे दिन में there is shrinking and dilation under the effect of sympathetic and parasympathetic nervous system. But in some cases, because of certain emotional responses, because of certain hormonal responses, our parasympathetic drive becomes over the sympathetic drive. मतलब parasympathetic nervous system is overstimulated. In those cases, what will happen? The blood vessels will keep dilated. And if the blood vessels keep dilated, then these turbinates will become bigger in size. So that is why this is called as vasomotor rhinitis, because it is happening because of the parasympathetic overdrive leading to turbinate hypertrophy. राइट? नाउ यू नीड टू गेट डाउन द पैरासिम्पैथेटिक ड्राइव. हमें आपको पैरासिम्पैथेटिक नर्वस सिस्टम की खत्म करना है. So what will you do? There is one nerve which supplies the parasympathetic supply to the nose, which is called as median nerve. So we need to cut the nerve. And what is the whole sole way in which we treat this particular disorder? Vasomotor, we say median neurectomy. So median neurectomy is the surgical modality of choice for vasomotor rhinitis. Okay, fine. V for V. चलो अब आते हैं allergic rhinitis. Allergic rhinitis simple है. Allergic rhinitis we already know. Allergy is type 1 hypersensitivity reaction. It is IgE mediated. Type 1 hypersensitivity reaction, right? Now allergy can happen either seasonal, एक सीजन में हो रही है, या फिर पूरे साल हो रही है. अगर सीजन में हो रही है, we call it seasonal allergy. अगर पूरे साल हो रही है, we call it perennial allergy. These are the two types. Now any person which comes with allergic rhinitis, they will have 4 important symptoms which you can remember as ribs. Rhinorrhea मतलब nasal discharge, itching, block and sneezing. तो ribs होता है rhinorrhea, itching, block, sneezing, right? अब ये बहुत इंपॉर्टेंट है कि एलर्जी में क्या साइंस मिलते हैं, ये क्वेश्चन आता है. तो एलर्जी में अगर हम किसी की भी नोज देखेंगे तो एलर्जी, कांस्टेंट एलर्जी से द टर्बिनेट्स बिकम बॉगी एंड मलबरी लाइक. तो मलबरी टर्बिनेट्स आर सीन इन विच कंडीशन, ये क्वेश्चन आता है. इट इज सीन इन एलर्जिक राइनाइटिस. फर्स्ट इज व्हाट इज मलबरी टर्बिनेट्स, राइट? अब सेकंड इंपॉर्टेंट, एलर्जी में आप क्या करते हैं? एलर्जी सिर्फ नाक में नहीं होती, एलर्जी आंखों में भी होती है. So what do? You keep rubbing your eyes again and again. So if you keep rubbing your eyes, your infraorbital crease becomes very prominent. या आंखों के नीचे का fold बहुत prominent हो जाता है. And that crease which forms infraorbital, that is called as a Denny-Morgan line. क्योंकि आप बार बार अपनी आंखों को ऐसे ऐसे squeeze करते हैं. This is called as a Denny-Morgan crease, also called as a Denny-Morgan line. Okay? Now, third thing, आप एलर्जी में क्या करते हैं? What is this? This is called as an allergic salute. This is called as allergic salute. अब allergic salute करते करते क्या होगा, ये जो ऊपर की नाक की लाइन है ये prominent हो जाएगी, क्योंकि बार बार you are pushing the nose up. So this line over the nose will become prominent. And if this line over the nose becomes prominent, this is called as Darrier line. It is called as Darrier line. अब जिनकी एलर्जी होती है वो रात भर तो सोते नहीं है. So if they don't sleep well, they will have big dark circles. And dark circles are called as allergic shiners. They are basically the venous congestion which happens over the face because facial veins are valveless. अगर आप सोएंगे नहीं, बार बार आप मुंह चलाते रहेंगे, these facial veins are getting congested and they will shine out. That is called as allergic shiner. Okay, ये सारे के सारे signs हैं for allergic rhinitis. For obvious reasons, किसी के भी एलर्जी होगी, we will give them antihistamines. We will give them leukotriene antagonist, right? Like montelukast, zafirlukast, right? We will give them mast cell stabilizers such as chromolim sodium or sodium chromoglycate, right? We will give them steroids or topical steroids, okay? And we will give them immunotherapy. Okay, immunotherapy matlab chota allergen, we will keep feeding them so that they get immune to the response what is given to them. Okay, right? So this thing finishes about what you require in allergic rhinitis. Okay, fine? चलो अब आते हैं एट्रोफिक राइनाइटिस पे. ये एक और फेवरेट क्वेश्चन है नीट पीजी का. बड़े क्वेश्चन आते हैं एट्रोफिक राइनाइटिस से, तो इसको फटाफट खत्म करते हैं. एट्रोफी का मतलब क्या हुआ? दिस इज अ क्रॉनिक राइनाइटिस which causes atrophy of the mucosa, atrophy of the bones, atrophy of the blood vessels. मतलब सब चीजों की एट्रोफी हो जाती है inside the nasal cavity. There is atrophy of nasal mucosa, glands, blood vessels and nerves. Everything becomes atrophied. There are 2 types of atrophic rhinitis. One which we don't know the reason, जिसे हम कहते हैं इडियोपैथिक, जिसे हम also कहते हैं प्राइमरी एट्रोफिक राइनाइटिस which is इडियोपैथिक. हमें नहीं पता उसका रीजन क्या है. दूसरी होती है सेकेंडरी. सेकेंडरी का मतलब क्या होता है? दैट इट इज स्पेसिफिक टू समथिंग एज अ सेकेंडरी डिसऑर्डर. इट इज हैपनिंग बिकॉज ऑफ सर्टेन डिसऑर्डर्स. दैट इज कॉल्ड एज सेकेंडरी एट्रोफिक राइनाइटिस which is happening secondary to a cause. अब प्राइमरी एट्रोफिक राइनाइटिस जो इडियोपैथिक होती है उसके सर्टेन कॉजेस को हाइपोथेसाइज किया गया है. देयर इज सम हाइपोथेसिस दैट हैज बीन गिवन फॉर दीज पर्टिकुलर कॉजेस. The mnemonic is hernia. Hernia means H, it could be because of hereditary cause. This is for primary. E, it could be because of endocrine cause. Endocrine, why? Because there could be estrogen deficiency. There could be because of estrogen deficiency. Estrogen is a very good vasodilator. Here, blood vessels are getting shrunk. There is vasoconstriction. So that is why estrogen is deficient. R is racial. It usually happens in the Caucasians or the yellow races. N is nutritional. It happens because of vitamin A, D and iron deficiency. What is the infective organism which causes atrophic rhinitis? So atrophic rhinitis, the causative organism is Klebsiella ozoeni. Very important question. Klebsiella ozoeni. Next is, it could be hernia ka A, that is autoimmune because of formation of autoantibodies. Okay. Then comes, if it is secondary, that means there are certain secondary causes which are destroying your mucosa. What are the secondary causes which can destroy the mucosa? सारी granulomatous diseases destroy करती हैं हमारे nasal mucosa को. कौन सी granulomatous diseases होती हैं? We could have tuberculosis, we could have syphilis, we could have vaginous granulomatosis, right? Or we could also do traumatize. We could traumatize by doing a surgery. So very commonly it is seen post septoplasty as well as post functional endoscopic sinus surgery. जिसमें हम normal mucosa अगर निकाल लेंगे, it can also lead to secondary atrophic rhinitis. Okay, so trauma also is very, very important, right? Okay. Rhinoscleroma is one other disease which we just saw. जिसमें atrophic stage होती है. It is also one of the common stages, right? चलो. अब, whenever you see three things in your question, three things. What are the three things? If the patient has come to you with green colored crusts, you see these green colored crusts, right? Now, if there is formation or if there is destruction of the nasal mucosa and destruction of the bones, what will happen? All the mucosa will become very, very shrunken. बहुत बड़ी cavity बन जाएगी. That means the nose will look very big because everything is destroyed inside the nose. So second is, you will see roomy nasal cavity. Roomy nasal cavity. Right? And the third will be foul smelling nasal discharge. The foul smelling nasal discharge that you see in these cases is called as ozena. Why? Because it is called as Klebsiella ozoeni, which is the organism. So, isko kehte hain ozena. If you see these three triads, this is called as Frenkel's triad. Frenkel's triad, because it was Bernard Frenkel who first got this disease. So Frenkel's triad, ये तीन चीजें होती है: crust, roomy nasal cavity, foul smelling nasal discharge, and these three form the characteristic diagnostic कि किसी के atrophic rhinitis है. Okay, fine. Now, one more important feature you see in atrophic rhinitis is, because their nerves get destroyed, they cannot smell their own discharge. So that, because they cannot smell their own discharge, they are okay, only the people around them can smell it. This is called as merciful anosmia. हमें mercy हो गई, we cannot smell our own discharge. This is a mercy to them and it's called as merciful anosmia. Okay, fine. चलो, अब आगे बढ़ते हैं. Now, how do you manage that? I've given you a simple mnemonic: dogs bark. Dogs do bark, right? So dogs bark. अब सबसे पहले जो पूछा गया था मुझसे, D for douching. What is douching? Douching का मतलब होता है कि we take 280 ml of water and we mix 3 types of salt inside it. What are the 3 types of salts? We mix 28.4 gram of sodium bicarbonate, 28.4 grams of sodium biborate and 56.7 grams of sodium chloride. अब ये सब मिलाते हैं, ये 3 salts हम मिलाएंगे 280 ml water में, and we will take it inside a syringe and we will rinse the nasal cavity. हम rinse करेंगे. So what will happen if we rinse the nasal cavity with these 3 salts? Sodium bicarbonate will dissolve the crust, sodium biborate will be an antiseptic, and sodium chloride will reduce the nasal edema and it will wash out all the discharge. These are the 3 things which we constitute as alkaline nasal douche. Okay? अब D हो गया. O से क्या होगा? O से मतलब हुआ estradiol nasal spray. Estradiol is a potent vasodilator. So when you add, the vasodilation will happen. There will be more regeneration of mucosa. Now comes the third, G. G मतलब we will tell the patient to instill glucose and glycerine drops. इसका क्या मतलब है? Glycerine is something which is a lubricant, क्योंकि आपको चाहिए अंदर lubrication. Everything is atrophied. And what is glucose? Glucose, whenever it goes under anaerobic conditions, क्योंकि अंदर growth है, there is anaerobic condition. So whenever glucose goes in anaerobic condition, it will form something called as lactic acid. और lactic acid क्या है? Lactic acid will inhibit bacterial growth. That is why we will tell the patient to keep adding glucose and glycerine drops. Dogs का S, submucosal placental extract injection. Placental extract is very good for regeneration. So we inject placental extract directly inside the mucosa. Then comes bark. B say, because it is because of nutritional deficiencies also. So it could be, we will give B12A, D supplementation, right? A is antibiotics. The drug of choice is streptomycin given 1 gram per day. Then comes R, that is rich protein diet because they occur in malnourishment. और K एक solution होता है जिसे कहते हैं chemicitin. Chemicitin is a solution which is formed with chloramphenicol, estradiol and vitamin D2. Okay, so estradiol, vitamin D2 and chloramphenicol साथ में बोलते हैं chemicitin solution. This we also instill directly. This will also reduce atrophic rhinitis symptoms. अगर इन सारे dogs bark में काम नहीं हुआ, then we choose to do a surgery. And what is this procedure? We need to close the nostril. We need to elevate the mucosal flaps and we need to medialize them and close it in the center. So हमने यहाँ पे incision दिया, we give lateral incision, we get both the skin flaps together in the midline and we suture them up. Because we don't want the air to go in. Air will go in, it will create more dryness. So we need more closed space so that it can regenerate. This is called as Young's operation. Now there is a modification to this Young's operation. What is that? That if we make a hole, a small hole in the center of this Young's, हमने छोटा सा एक hole बना दिया. This hole is only 3 millimeters and this is called as modified Young's. Called as modified Young's, which is a 3 millimeter hole which we make in the center when we do the Young's procedure. Right? Okay. That finishes about what you need to know from atrophic rhinitis. चलो, दो इंपॉर्टेंट सीटी स्कैन रिलेटेड क्वेश्चंस. ओके, व्हाट इज द सीटी स्कैन रिलेटेड क्वेश्चन? अब इसमें क्या दिख रहा है? व्हाट डू यू सी? दिस इज अ कोरोनल सेक्शन. दैट मींस आई हैव कट ओपन माय हेड लाइक दिस. यू आर सीइंग ओवर हियर, दिस इज योर कोरोनल सेक्शन, राइट? नाउ इन दिस व्हाट ऑल यू कैन स्पॉट ऑन, लेट्स सी. यू हैव गॉट दिस ऑर्बिट. ये देखो, ये ऑर्बिट है, राइट? एनीथिंग व्हाट यू सी ग्रे इन अ सीटी इज सॉफ्ट टिश्यू. जो भी ब्लैक दिख रहा है एयर है, एंड व्हाटएवर यू सी व्हाइट इज बोन. ओके, सो व्हाट यू सी हियर, दिस इज ऑर्बिट, इट इज ग्रे. Center में we can see this is our septum or nasal septum, right? Then we see these scroll-like projections. देखो scroll की तरह आ रहे हैं. This is our inferior turbinate. ऊपर से ये आ रहा है हमारा middle turbinate. This is also our middle turbinate, right? Now we have got these sinuses below the orbit. Orbit के नीचे कौन से sinus होते हैं यहाँ पे? This is our maxillary sinus, right? Maxillary sinus has got air. तो देखो इसके अंदर air दिख रही है maxillary sinus में. तो problem क्या है? What is the problem over here? You see that at the floor of the orbit, यहाँ पे नहीं है, but यहाँ पे कुछ है. At the floor of the orbit, there is a cell. There is an air cell present at the floor of the orbit. If ever you see an air cell present at the floor of the orbit, or just at the upper limit of the maxillary sinus, this cell is called as Haller cell. What is Haller cell? Haller cell is an anterior ethmoidal air cell. मतलब anterior ethmoidal cells होते हैं, right? You've got ethmoidal air cells. So if there is an anterior ethmoidal air cell and it has accidentally gone and pneumatized the floor of the orbit, then we call it as a Haller cell. This is a very, very important question. Okay. Ab second important question. Second question ये क्या है? Okay. So this is a posterior part of our nose. This is again our coronal section. Posterior part of the nose. जहाँ पे क्या दिख रहा है? We can see this is our nasopharynx starting, right? And what you see here, this is our sphenoid bone. This is our sphenoid bone. Inside the sphenoid bone, this is our sphenoid sinus. But generally sphenoid sinus should have only two. एक sinus ये, एक sinus ये. There should be two sinus. But you actually don't see two sinus. आप एक extra चीज देख रहे हो यहाँ पे. So what is this? This is called as an Ono-D cell. What is an Ono-D cell? Accidentally the posterior ethmoidal air cells can migrate inside the sphenoid sinus and pneumatize it. So posterior ethmoidal air cells gone into the sphenoid and pneumatized it, it called as Ono-D cell. Now, one important point regarding Ono-D cell is what? That Ono-D cells are very near. You can see the structure. This is your optic nerve. So, accidentally, when you are actually operating on a sphenoid sinus which has an Ono-D cell, you can accidentally injure which nerve? You've got the injury to the optic nerve. Because this bone here is very, very thin. It's only 0.25 millimeters thin. So, that is why this is something which will always be asked as a question. What is Ono-D? What is Haller? ठीक है? चलो, अब आगे बढ़ते हैं. अब ये पूरा चार्ट है अबाउट साइनस और जितने क्वेश्चन साइनस से आते हैं ये सारे इसके अंदर है, राइट? हाउ मेनी साइनस डू यू हैव? यू हैव गॉट टू टाइप्स ऑफ साइनसेस, एंटीरियर ग्रुप ऑफ साइनस, पोस्टीरियर ग्रुप ऑफ साइनस. एंटीरियर ग्रुप ऑफ साइनस का निमोनिक है फैम. फैम होती है ना, फैमिली. तो फ्रंटल, एंटीरियर एथमोइड एंड मैक्सिलरी, फैम आर एंटीरियर ग्रुप ऑफ साइनसेस. पोस्टीरियर ग्रुप ऑफ साइनस आर पोस्टीरियर एथमोइड एंड स्फेनोइड. These are the two posterior group of sinuses. Okay, fine. This is what we have understood. ठीक है. Anterior group of sinus में frontal, anterior ethmoid and maxillary, all three of them drain into middle meatus. Middle meatus. Posterior ethmoidal sinus drains into superior meatus. Superior meatus. Sphenoidal sinus drains into a recess called as sphenoethmoidal recess. तो ये सारे इंपॉर्टेंट क्वेश्चंस बन गए. फैम सारा खुलता है मिडिल मियाटस में. Sphenoid, posterior ethmoid drains into superior meatus. Sphenoid sinus drains into a recess present behind the posterior ethmoid, which is called as sphenoethmoidal recess. Okay? अब एक और इंपॉर्टेंट क्वेश्चन. Which is the first sinus to develop in a child? The first sinus which is developed or which is earliest at birth is the maxillary sinus. Maxillary sinus is the earliest sinus to develop at birth. That is why the earliest sinus that you will see on an X-ray of a child is also maxillary sinus in 4 to 5 months. Okay, fine. Chalo, now next. Which of the following sinus is the last to develop? The only sinus which is absent at birth and it is last to develop is called as frontal sinus. Okay, that is why frontal sinus is seen last on an X-ray and that is around at 6 years. Right? Okay. Next question. Which of the following sinus is most pneumatized at birth? Most pneumatized का मतलब सबसे ज़्यादा air cells किस sinus के दिखते हैं? The most pneumatized sinus at birth is ethmoidal sinus. That is why सबसे ज़्यादा इसी के air cells बने रहते हैं. Okay? So these are the 3 questions. Keep noting how they have asked. Okay? Now, one important question. All these sinuses, if you see, are supplied by ophthalmic division of the trigeminal nerve, except maxillary sinus, which is supplied by maxillary division of the trigeminal nerve. So trigeminal nerve have got 3 branches: ophthalmic, maxillary, mandibular. सारे के सारे sinus are supplied by ophthalmic except maxillary, जो supplied होता है by maxillary division या V2 division. बाकी सारे supply होते हैं by V1 division. This finishes everything about whatever they have asked from these sinuses. Right? अब 2 क्वेश्चन इसमें मैं ऐड कर देता हूं. Largest ethmoidal air cell is called as bulla ethmoidalis. Bulla ethmoidalis is the largest anterior ethmoidal air cell. Anterior most ethmoidal air cell, मतलब सबसे आगे कौन सा ethmoidal air cell होता है? It is called as agar nasal. सबसे आगे is agar nasal. सबसे बड़ा is bulla. Okay, fine. So this finishes about सारे potential questions जितने भी साइनस में पूछे गए. ठीक है, चलो, fine, खत्म. So we finished nose, right? So we finished ear, we finished nose. अब quickly हम जाते हैं और खत्म करते हैं oral cavity और pharynx की कहानी. ठीक है, तो oral cavity और pharynx को जल्दी होगा because this is something which is very very easy. इसमें ज़्यादा टाइम नहीं लगेगा. Complicated part खत्म हो गया है and larynx हम लोग सारी images में खींच देंगे. Right? Okay. So MP Vertus is asking, okay, thank you. So I think नहीं, PYQ का है, PYQ का video is already there, you can say, but इसमें सारी चीजें PYQ से ज़्यादा है, so you can get over everything today itself. ठीक है, चलो आगे बढ़ते हैं. अब देखो ये क्या है. Now this is an image which is of the nasopharynx and they have asked you topographic anatomy की किसमें क्या दिख रहा है. First important question, all the pharynx is lined by stratified squamous epithelium. सारा का सारा pharynx is lined by stratified squamous epithelium except nasopharynx. Nasopharynx nasal cavity की lining के साथ होता है. That is why it is lined by pseudostratified ciliated columnar epithelium. बाकी जितना भी pharynx है, oropharynx, hypopharynx, they are all lined by stratified squamous epithelium, non-keratinizing type. Okay, fine. So if we see this image, ये कौन सी image है? ये nasopharynx की image है, right? तो ऐसे सोचो, this I am lying down and you are seeing behind my nasal cavity, right? And when you are seeing behind my nasal cavity, this is my nasopharynx, right? This is the lateral side of the nasopharynx. This is the medial one. This is the medial side. मतलब इधर मेरा septum है. This is the lateral side. Now on the lateral wall of the nasopharynx, you see a slit-like opening. इसमें एक slit-like opening ये देखो ये दिख रही है. This slit-like opening that is seen on the lateral wall of the nasopharynx, This slit-like opening is called as eustachian tube opening. आंख बंद करके बोलना है eustachian tube opening. Seen on the lateral wall of nasopharynx. Okay. The elevation produced because of the cartilaginous end of the eustachian tube above the orifice. हमारा eustachian tube ऐसे होता है. So it has got a cartilaginous elevation above the eustachian tube orifice, and this cartilaginous elevation above the eustachian tube orifice, this is called as torus tubarius. This is called as torus tubarius, okay, which is an elevation present over the eustachian tube orifice. Okay. Next, there is a three-dimensional fossa which is present behind the torus tubarius. You can see that. Can you appreciate this kind of collapsed three-dimensional fossa just behind the torus tubarius? This is the fossa of Rosenmuller. Most common site, fossa of Rosenmuller is the most common site for NPC or nasopharyngeal carcinoma to develop. Okay, fine. Chalo, आगे चलते हैं. Now, these are all the things that you require from Waldeyer's ring. Waldeyer's ring एक lymphoid ring है, which is formed from many things, right? Now, what are the things that form the Waldeyer's ring? First are adenoids. Adenoids are present at the roof of the nasopharynx. The other name of adenoids is also called as Luschka's tonsil. ये important है. What is tubal tonsil? Tubal tonsil का मतलब हुआ that you know that this is your eustachian tube, right? So just above this there could be some amount of lymphoid tissue. This is called as tubal tonsil, which is just present in relation to the eustachian tube. Adenoids यहाँ पे होते हैं. So that was Luschka's tonsil. Other is next to the tube, which is called as tubal tonsil. The other name for tubal tonsil is also called as Gerlach tonsil. जो torus tubarius के ऊपर होता है, that's called as Gerlach tonsil. Third is oropharynx में, which we already know कि हमारे दो tonsil होते हैं. So palatine tonsil are the third type, which is important for Waldeyer's ring. Fourth important होता है, which is a tonsil or a lymphoid tissue present at the base of tongue. That is called as lingual tonsil, जो base of tongue पे होता है, right? And finally, there are certain things which are present in our pharyngeal wall, which are called as lateral pharyngeal bands. All of these constitute what we call as a Waldeyer's lymphatic ring. ठीक है? चलो, अब आगे बढ़ते हैं. Adenoid hypertrophy. Now, this is very simple. हम इसमें बहुत time waste नहीं करेंगे. Very easy to understand. This is our nasopharynx. This is our eustachian tube on both the sides, and above the eustachian tube is our torus tubarius. Right? This is our torus tubarius. Now, at the roof of the nasopharynx, there comes down an inverted pyramid-like lymphoid tissue, which we call as adenoid hypertrophy or adenoids. Roof से ये नीचे V की तरह आता है, ये लटकता है, and this is called as adenoid hypertrophy. That is why I have told you that this is nasopharyngeal tonsil भी कहते हैं, right? And this is present at the junction of the roof and the posterior wall of nasopharynx. Okay, ये roof से नीचे आ रहा है in the form of an inverted pyramid. Now, very importantly, ये याद रखना है कि whenever you get an adenoid question, adenoid usually starts to appear by 2 years of age. It increases in size at 6 to 7 years of age and gradually atrophies during puberty. क्योंकि हमारे बच्चों में सबसे ज़्यादा requirement होती है of local immunity. So that is why by puberty our immunity is well developed. We don't require adenoid. So कोई भी adenoid related question आपको 50, 40, 30 year old में नहीं होगा. This is only children which you will get as a question because they atrophy at puberty. Tonsil और adenoid में क्या फर्क होता है? Tonsils have a capsule, adenoid don't have a capsule. Tonsils have a crypt, adenoids do not have a crypt. Okay, fine. चलो आगे बढ़ते हैं. Now, if the patient has got adenoid hypertrophy, what do you think will be the clinical features of this child? Right? So let me just show it to you here. अब अगर ये पूरी तरीके से adenoid भर गया in your nasopharynx, what will be the first clinical feature of this child? Obviously, the child will develop nasal obstruction. The child will develop nasal discharge. And this adenoid will go and cause obstruction to the eustachian tube opening. That is why I told you that the most important cause for bilateral conductive hearing loss or otitis media with effusion in children is what? It is adenoid hypertrophy. So most common cause of otitis media with effusion in children due to the blockage of the eustachian tube orifice is basically because of adenoid hypertrophy. That's what I told you, right? अब ये पूरी तरीके से ये बंद हो गया है नाक, right? So close your nose and speak. What is that? This is a nasal voice that happens because of the obstruction inside the nose. अब अगर किसी की नेजल वॉइस आ गई तो उसे हम क्या बोलेंगे? उसे हम कहते हैं राइनोलेलिया क्लोजा। व्हाट डू यू अंडरस्टैंड बाय राइनोलेलिया क्लोजा? राइनोलेलिया मतलब आवाज जो नाक से निकल रही है, क्लोजा मतलब क्लोज। तो हिमेश रेशमिया, राइट, यू मस्ट हैव सीन नाक बंद करके, तो दिस काइंड ऑफ अ वॉइस कम्स आउट, राइनोलेलिया क्लोजा। You are now doctors, you should understand that word. So rhinolalia clausa is a feature of nasal and nasopharyngeal pathologies. Right? अगर किसी के बहुत ज्यादा हवा आ रही है नाक से, हाइपर नेजालिटी, मतलब जो भी बोल रहा है वो हवा निकल रही है नाक से, दैट मीन्स व्हाट? देयर इज अ कनेक्शन बिटवीन द ओरल कैविटी एंड द नोज, राइट? सो राइनोलेलिया क्लोजा याद रखो हिमेश रेशमिया से, नाक बंद कर दी, नोज में या नेसोफैरिंक्स में कुछ भी बंद होगा, इट विल क्लोज द नोज, क्लोज्ड वॉइस। एपर्टा का क्या मतलब है? राइनोलेलिया एपर्टा मींस हाइपर नेजालिटी ऑफ वॉइस। ये हाइपोनेजल थी ऊपर वाली, ये हाइपर नेजल है। हाइपर नेजल मतलब बहुत ज्यादा हवा निकल रही है नाक से। कब हवा निकलेगी? व्हेन देयर इज अ कनेक्शन बिटवीन द ओरल कैविटी एंड द नोज, एंड दैट हैपेंस इन क्लेफ्ट पैलेट। क्लेफ्ट पैलेट इज द रीजन, राइट? सो सपना इज सेइंग, oh thank you very much सपना, ओके ग्रेट, यू गाइज आर एंजॉइंग, ठीक है। सो राइनोलेलिया एपर्टा एंड राइनोलेलिया क्लोजा वी हैव अंडरस्टूड, इन दोनों की क्या इंपॉर्टेंस होती है ये भी हमने समझ ली, ठीक है। अब देखते हैं अगर हमारे पास कोई बच्चा आता है एडिनोइड हाइपरट्रॉफी का तो कैसा होता है। दिस इज हाउ द बेबी लुक्स लाइक, राइट? नाउ आई टोल्ड यू दैट द नोज ऑफ द चाइल्ड इज क्लोज्ड, तो वो किससे सांस लेगा? दे विल बी माउथ ब्रीदर्स, तो दे विल बी माउथ ब्रीदर्स, माउथ ब्रीदिंग, दे विल बी माउथ ब्रीदर्स, करेक्ट, ओके। अब एक इंपॉर्टेंट चीज, क्योंकि ये ब्रीद माउथ से करते हैं और इनका मुंह खुला रहता है, दैट इज वाई इनका मुंह लंबा हो जाता है, right? Their mandible grows more than the maxilla, so their maxilla remains small, there is a small maxilla, and their mandible grows longer, which is called as long face syndrome. इसे दूसरा नाम long face syndrome भी कहते हैं, because mandible has now increased in size. अब अगर mandible increase होती रहेगी तो ये chin छोटी हो जाएगी, so they will have a small chin, right? अब एक और इंपॉर्टेंट चीज है, that whenever these children are breathing with an open mouth, चिल्ड्रन में बहुत इंपॉर्टेंट चीज होती है, जब उनके दांत निकलते हैं ना, when their teeth come out, तो their gums need to be stimulated by the tongue. टंग बार बार छूती रहती है gums को, so that the teeth come out. These children have an open mouth, so they hardly get their tongue touching over the gingiva. कभी टंग टच ही नहीं करती. So if the tongue will not touch over the gingiva, इनके दांत will become very very उबड़ खाबड़. It will come out in a very haphazard manner. That is why it is called as crowded upper incisor. Crowded upper incisor. Okay, fine. Next, because of the crowded upper incisor, what will happen? Their lip will become pinched up. So they will have pinched upper lip. क्योंकि अब upper lip ऊपर उठ जाएगी, क्योंकि these incisor are coming out, right? They hardly use the nose for breathing. If they are not using the nose for breathing, their ala will atrophy. If there is alar atrophy, then what will happen? Their nose will become pinched in. There will be a pinched in nose, right? Now if you see this child is actually looking very dull, so this is called as a dull expression of the child, because the child is not sleeping well, the child is sleep deprived because of obstructive sleep apnea. अब ये children के नाक बंद है, they have got a blocked nasopharynx, they are breathing from the mouth, so that is the reason why they will have hypoxia in the night, and they will also have increased carbon dioxide retention. If these babies have got increased carbon dioxide retention, तो कभी भी किसी के carbon dioxide ज़्यादा हो जाएगा body में तो क्या होगा? There will be clouding of memory. There will be clouding of memory that they will have, and they will lead to a condition which is called as Guy's aproxia. What do you understand by Guy's aproxia? Guy's aproxia means inattentive behavior. ये बच्चे सोते ही नहीं है, and इनकी fogging है, and इनको सुनाई नहीं दे रहा है, so they will be inattentive. ये अपने में लगे रहेंगे. That's called as Guy's aproxia, and inattentive behavior of this child. This all forms the whole thing that you will see in cases of adenoid hypertrophy as a syndrome, right? Okay. अब अगर ये कोई बच्चा आया हमारे पास, तो उसमें हम क्या ट्रीटमेंट देंगे? What will be the treatment? So usually we start on a medical line of management. The best way to shrink the adenoid is give intranasal steroid, which is mometazone. Mometazone is a drug of choice for children. Fluticasone is a drug of choice for adults when we give steroids. Surgical is something which we do in cases if the adenoids are grade 3 or grade 4, if they are causing conductive hearing loss. अब एक चीज important है, ध्यान देना. If they ask you a question of adenoid and they tell you that there is nasal obstruction, only, then your answer will be we will do adenoidectomy. If they ask you if the child has got adenoid hypertrophy, nasal obstruction with conductive hearing loss, then your answer should be we will also do myringotomy. Myringotomy का मतलब putting an incision over the tympanic membrane, draining out the fluid. So see this, only if the child has got nasal obstruction as the symptom, we will do plain removal of the adenoids or adenoidectomy. If the child has got even nasal obstruction with conductive hearing loss, then you will say that we will also do grommet insertion. Grommet is the ventilation tube that needs to be inserted so that we can drain out all the fluid of the middle ear. That will be your answer. Okay, fine. चलो आगे बढ़ते हैं. अब next question आता है. Next question is, what do you understand by juvenile nasopharyngeal angiofibroma? बड़ा इंपॉर्टेंट क्वेश्चन, बड़ी चीजें पूछी जाती हैं इसमें, राइट? अगर आपके पास कोई भी क्वेश्चन आता है where they tell you an adolescent male, now notice this, not a female, an adolescent male, 18 से 19 साल का बच्चा who comes with progressive obstruction in the nasal cavity with spontaneous unprovoked bleeding from the nasal cavity. मतलब bleeding हो रही है, unprovoked bleeding है, spontaneous है, profuse है, with nasal obstruction. The answer is juvenile angiofibroma. Okay, that's why it is juvenile, right? That's why it's juvenile, because it happens in adolescent males. So this is something which you will see in young adolescent males. Now why in males? It's because of the fact that this is a testosterone or a hormonal dependent tumor. That is why it happens during the time of mostly adolescence or puberty. Okay, fine. Now this is the most common benign and locally aggressive tumor of the nasopharynx, but this is a benign tumor. It is completely benign, but it has got local aggressive potential. Okay, now why does that happen? The most important theory is जो हमारी first branchial arch होती है, the artery of the first branchial arch is maxillary artery. So in some people there is a remnant that forms over at the area, or it leaves behind an area of that first arch branchial artery. And that vascular remnant under the effect of hormones starts to grow. That is called as juvenile angiofibroma. So the most accepted theory is that there is a vascular remnant of the first branchial arch artery. That is the maxillary artery जो रह जाती है. और कहाँ पे रह जाती है? At the site of sphenopalatine foramen. So between the palatine bone and the sphenoid bone, there is a foramen which is called as sphenopalatine foramen. वहाँ पे there is some kind of a vascular remnant of the first pharyngeal arch which is left behind. If it starts to grow under the effect of certain hormones, we will call that as angiofibroma. अब इसके नाम में ही देखो क्या है, angio है, fibroma है. That means that it is containing blood vessels and it is containing a fibrous component. So if we see these blood vessels inside of angiofibroma, these blood vessels inside the angiofibroma lack a smooth muscle coat. They lack a smooth muscle coat. And because they lack a smooth muscle coat, that is why we never ever biopsy an angiofibroma. बिल्कुल सही आपने बोला. So this is one thing which has been asked. What is the one investigation you will not do in angiofibroma? पिछले INICET में question. You will not do a biopsy. Why? Because the vessels lack a smooth muscle coat. The moment you take them out, they will not be able to shrink back, and that will lead to torrential bleeding. ठीक है? चलो आगे बढ़ते हैं. अब what is the investigation is contraindicated? That I already told you, it is biopsy. That I already told you, it does not undergo vasoconstriction. What is the investigation of choice to see an angiofibroma? It is CECT. Remember, CT best for seeing bones, MRI best for seeing soft tissue involvement. So this is something which is invading a lot of bones around it. That is why we choose CECT. Contrast enhanced CT scan. ठीक है, अब आगे बढ़ते हैं. अब important signs आ जाते हैं जो बड़ा important ये picture है, right? Now angiofibroma is occurring where? In the nasopharynx, right? अब ये देखो, this is something which is an axial section. Axial मतलब हमने ऐसे काटा और हम ऊपर से देख रहे हैं. So if we are seeing from the top, right, we see the nasal cavity. ये देखो, ये nasal cavity हो गई. ये हमारे maxillary sinus हो गए साइड में. This is maxillary sinus, this is maxillary sinus, right? Remember one thing. The fossa present behind the maxillary sinus. मतलब देखो ये maxillary sinus है. इसके पीछे का जो ये एरिया है, behind the posterior wall of maxilla, this area is called as pterygopalatine fossa. Pterygopalatine fossa is a fossa present behind the posterior wall of maxilla. ये चीज हमें याद रखनी है. Okay, so what exactly does it do? Like what is the significance of this is कि nasal cavity के पीछे nasopharynx होना चाहिए और nasopharynx black दिखना चाहिए because nasopharynx contains air. But यहाँ पे हमें कुछ भी black नहीं दिख रहा है, यहाँ पे हमें सब कुछ ग्रे ग्रे दिख रहा है. That means यहाँ पे ट्यूमर है. Now, where has this tumor gone? This tumor directly comes out from the sphenopalatine foramen and it goes into this pterygopalatine fossa. which is a fossa present behind the posterior wall of maxilla. तो ये क्या करेगा? If it grows into the pterygopalatine fossa, then this particular tumor will push the posterior wall of maxilla anteriorly. ये देखो, इस side की posterior wall of maxilla anteriorly it is bowing. You can't see that here. But this side, the maxillary sinus is actually bowing anteriorly. The posterior wall of maxilla is bowing anteriorly. What is this called as? This is called as Holman-Miller sign. So, anterior bowing of the posterior maxillary wall, it's called as Holman-Miller sign, which is a classical sign where the pterygopalatine fossa has been involved. Right? अब क्या होगा? Now this tumor will go more laterally outside. Pterygopalatine fossa is connected to which fossa outside? Infratemporal fossa. Infratemporal fossa का मतलब ये temporal fossa है. If we go below the zygoma, ये zygoma है, zygoma के अंदर चले गए, that is our infratemporal fossa. And the lateral boundary of infratemporal fossa is our mandible. तो अगर ये ट्यूमर mandible के बीच में आ गया, that means if it comes into the infratemporal fossa, it will push the mandible laterally. So if you see here, this tumor has come into the infratemporal fossa and it is pushing the lateral ramus of the mandible laterally. So if it pushes the lateral ramus of the mandible laterally, this sign is called as Hondusa sign. So what is Hondusa sign? It is pushing of the lateral, pushing of the ramus of the mandible laterally when the tumor involves the infratemporal fossa. What is Holman-Miller sign? It is anterior bowing of the posterior maxillary wall, which is usually seen when the tumor is in pterygopalatine fossa. Hondusa दिखेगा ITF involvement में, pterygopalatine दिखेगा, pterygopalatine fossa में दिखेगा Holman-Miller sign. These are the two very very important signs जो ग्रंथ की तरह पूछे गए हैं, बहुत important sign पूछे गए, बहुत बार पूछे गए. ओके चलो, अब एक और साइन है which has been added recently. अब ये जो साइन है, अब ये देखो, ये हमारी टेरेगोइड प्लेट है, ये हमारी मीडियल टेरेगोइड प्लेट है, ये लैटरल टेरेगोइड प्लेट है. अब ये ट्यूमर क्या करता है, ये टेरेगोइड प्लेट्स का जो बेस है ना, उसको तोड़ देता है. दैट मीन्स अगर टेरेगोइड प्लेट हमारी ऐसी है, राइट, दे आर कमिंग डाउन, ये हमारी मीडियल टेरेगोइड प्लेट है, ये लैटरल टेरेगोइड प्लेट है. दिस ट्यूमर विल डिस्ट्रॉय द बेस वेयर दीज टेरेगोइड प्लेट्स अटैच. तो देखो इसने बेस पे इसको तोड़ दिया है. तो दे एक्चुअली लुक लाइक टू स्टिक्स विच आर हैंगिंग आउट. तो ये ऐसे लगता है दो चॉपस्टिक्स हैं. दैट इज व्हाई दिस इज कॉल्ड एज चॉपस्टिक साइन, which indicates pterygoid plate involvement, which appears as chopsticks. Okay, fine. चलो अब आगे बढ़ते हैं. आगे बढ़ने के लिए हमारे पास एक इंपॉर्टेंट स्टेजिंग आती है, which is called as Redkowski staging. Redkowski staging is the way in which we stage this tumor, right? अब ये बड़ी कंफ्यूजिंग लगती है, but I'll tell you a very simple way to remember Redkowski. ठीक है, अब हम लोग एक एक करके याद करते हैं. Redkowski, what is stage 1? 1 का मतलब हुआ पहले 1A and 1B. 1A का मतलब है कि अभी ट्यूमर जस्ट स्टार्ट हुआ है. तो जब स्टार्ट होगा तो सिर्फ नेजोफैरिंक्स या नोज में ही होगा. तो इफ इट इज स्टार्टिंग ओनली इन द नेजोफैरिंक्स और इन द नोज, वी कॉल इट 1A, और कहीं नहीं गया. 1B का मतलब हुआ किसी भी साइनस में चला गया. अगर वहां से कहीं भी साइनस में चला गया, 1B, बस खत्म. ठीक, अब हम याद करते हैं 2. 2 इज अगेन डिवाइडेड इनटू 2A, 2B, 2C. 2A का मतलब है टेरेगोपैलेटाइन फोसा में जस्ट घुसने लगा है. That means minimal extension into pterygopalatine fossa. 2B का मतलब है अब मैं pterygopalatine fossa में completely आ गया हूं. अगर आपसे ये बोलें कि minimal extension है pterygopalatine fossa में, तो आप बोलेंगे it is 2A. अगर आपसे ये बोलें कि completely pterygopalatine fossa में फैल गया है, तो आप बोलेंगे 2B. बट 2B में एक और चीज ऐड करनी है, वो है ऑर्बिट. तो pterygopalatine fossa का complete involvement together with the orbit, we call it 2B. 2C, remember one word, infratemporal fossa. अगर infratemporal fossa में आ गया यानी Hondusa sign पॉजिटिव हो गया, तो ऑटोमेटिकली द आंसर इज 2C. नाउ कम्स 3. 3 का मतलब हो गया अब ये ब्रेन में जाने लगा है. तो इफ देयर इज मिनिमल स्कल बेस इरोजन, 3A. स्कल बेस तोड़ के इंट्राक्रेनियल चला गया, 3B. फिनिश्ड. तो ये सारे के सारे रेडकाउस्की इसी तरीके से याद करते हैं. जस्ट टेक द कैच वर्ड एंड पुट इट इनटू. ठीक है, so this finishes about what is how we stage juvenile angiofibromas. How do we treat it? I told you it is a very vascular tumor. If it is a very vascular tumor, we need to embolize it first. So we use something called as preoperative embolization. ठीक है, शुभमन, I'll just repeat it. अच्छा ठीक है, फिर से रिपीट करना है, मैं फिर से कर देता हूं. अब देखो, स्टेज 1A मतलब सिर्फ नोज या नेजोफैरिंक्स में है. 1B मतलब याद रखना है साइनस में आ गया. अब 2A, 2B, 2C क्या है? 2A का मतलब है टेरेगोपैलेटाइन फोसा में जस्ट घुसने लगा है, मिनिमल एक्सटेंशन इनटू टेरेगोपैलेटाइन फोसा. If I completely come into the pterygopalatine fossa and involve it, it is 2B. Minimal extension 2A, complete involvement 2B. ठीक है, अगर मैं इंफ्राटेम्पोरल फोसा में चला गया 2C. Now comes 3. 3A मतलब minimal skull base erosion, 3B मतलब complete intracranial spread. ठीक है. How do we treat it? Preoperative embolization. We add a radiologically we add a substance, okay, or an embolizing agent to stop bleeding during surgery. Okay, and with that, the only way in which we can manage JNAs is by surgical management. So usually we do a transnasal endoscopic surgery, which is usually done with the help of 2 surgeons, and we tackle the tumor completely. Okay. Up only in those cases, if the tumor has gone into the brain, if it has invaded the skull base, and we cannot remove it in toto in one sitting, in those cases we can shrink the tumor. The drug of choice for shrinking the tumor is anti-androgen drug, because androgen dependent tumor hai, and the only anti-androgen drug which is available is called as flutamide. Okay. We can also give a short course of radiotherapy, which is reserved in only those cases which are unresectable angiofibromas. ठीक है, चलो खत्म. This finishes about angiofibroma. अब आते हैं next कार्सिनोमा पे. अब कार्सिनोमा में बहुत सिंपल क्वेश्चन है जो पूछे गए. आई ओनली पुट दैट. मोस्ट कॉमन कार्सिनोमा ऑफ नेसोफैरिंक्स इज ऑफ कोर्स नेसोफैरिंजियल कार्सिनोमा. मोस्ट कॉमन हिस्टोलॉजिकल टाइप ऑफ नेसोफैरिंजियल कार्सिनोमा जहां मिले स्क्वामस सेल ही होता है, तो इट इज स्क्वामस सेल कार्सिनोमा. Most common site from which this carcinoma arises, it is fossa of Rosenmuller. That is the most common site. ये हम ऑलरेडी पढ़ चुके हैं, right? Which is present behind the torus tubarius. ठीक, आगे बढ़ते हैं. One thing, where does it come from? Always remember when they tell you about any nasopharyngeal carcinoma question, they will tell you about a man or a woman residing from southern China or northeastern part of India. और उसका रीजन ये है बिकॉज दीज आर द मोस्ट एथनिक जोन्स इन द साउथ ईस्ट एशियन पॉपुलेशन वेर यू गेट दिस पर्टिकुलर कार्सिनोमा. ओके, सो अनदर इंपॉर्टेंट पॉइंट, दिस occurs wide in these areas. It's because they consume a lot of salted fish, and salted fish usually releases a very important carcinogen. This is called as nitrosamine. So that is something that is very common in these areas, और तभी uncooked salted fish के चक्कर में they get this carcinoma more. One virus which has been closely associated with nasopharyngeal carcinoma, it is Epstein-Barr virus. Close your eyes, tell this answer. बड़ा important question है. Now that is the reason when we screen patients of nasopharyngeal carcinoma, उनमें Epstein-Barr virus antibodies मिलती हैं. And there are two types of antibodies which we see in these patients with in nasopharyngeal carcinoma. One is one is immunoglobulins which are directed against the viral capsid antigen, and one immunoglobulin is directed against the nuclear core early antigen of EBV. So one is early antigen, one is viral capsid antigen. अब अगर इन दोनों में मैं बोलूं कौन सी मोर सेंसिटिव है, इट इज वायरल कैप्सिड एंटीजन. अगर मैं बोलूं कौन सी मोर स्पेसिफिक है, देन इट इज अर्ली एंटीजन. Okay, so this is something which is raised in cases of nasopharyngeal carcinomas. Okay, ये हमारा स्क्रीनिंग टूल है. ठीक है, चलो आगे बढ़ते हैं. अब एक इंपॉर्टेंट चीज जो पूछी जाती है, that if the nasopharyngeal carcinoma metastasizes out, it will cause what? The most common is skeletal mets. कौन सी चीज? It causes most common skeletal mets to thoracolumbar spine. Okay, it causes most common mets to the thoracolumbar spine. Then comes lung, then comes liver. अब एक चीज तो आपको सबसे पता होगी, हर जगह पूछी जाती है, that is what is trotus triad. Trotus triad का मतलब क्या है? Trotus triad का मतलब है NPC में दिखता है NPC. NPC में दिखता है NPC. That is what trotus triad is. Okay, so N का मतलब हो गया न्यूरैल्जिया, P का मतलब हो गया पैलेटल पैल्सी, एंड C का मतलब हो गया कंडक्टिव हियरिंग लॉस. न्यूरैल्जिया क्या है? न्यूरैल्जिया समथिंग which is because of temporoparietal neuralgia that occurs due to trigeminal involvement. Palatal palsy occurs due to the involvement of vagus nerve, and conductive hearing loss occurs due to the involvement of the eustachian tube. So this NPC में NPC. Okay, fine. चलो अब आगे आते हैं. What is the investigations of choice to rule out nasopharyngeal carcinoma? The investigation of choice to rule out nasopharyngeal carcinoma is CCT and MRI with gadolinium contrast, because you need to see the extent. Okay. What is the screening and follow-up tool? ये मैंने already बताया था that if you want to screen the patients, we can take these antibody levels, and these are the IgA antibodies which are directed against the viral capsid antigen and the early antigen of EBV. Okay, fine. Chalo, thank you Pranav. Chalo, आगे बढ़े. Ab, how will we treat it? Always remember, close your eyes. The first and foremost treatment of NPC is chemoradiation. We don't touch this surgically as much because of the reason of poor reconstruction. क्योंकि बहुत अंदर होता है ये. So we can't reconstruct it that much. Plus there is a lot of neurovascular structures. So the first treatment of choice is chemoradiation. That is the first thing that we do. Only in small tumors we can do something called as nasopharyngectomy. That is only in the earlier part of tumors. But again, not the first choice of management. Not the first choice of management because of poor reconstruction methods. Okay, this finishes about NPC. अब आ जाते हैं टॉन्सिल में. अब नेसोफैरिंक्स खत्म, नीचे आते हैं into the ओरोफैरिंक्स. ओरोफैरिंक्स में इंपॉर्टेंट क्या पढ़ना है? अक्यूट टॉन्सिलाइटिस, क्रॉनिक टॉन्सिलाइटिस, टॉन्सिलेक्टमी खत्म. और क्या क्वेश्चंस है ये जल्दी खत्म कर लेते हैं. Acute infection and inflammation of the tonsil is called as acute tonsillitis. If I ask you most common organism for tonsil कौन सा है? ग्रुप ए बीटा हीमोलाइटिक स्ट्रेप्टोकोकाई, जिसे हम लोग GABHS भी कहते हैं. ग्रुप ए बीटा हीमोलाइटिक स्ट्रेप्टोकोकस. This is the most common organism to cause tonsillitis. Okay. What are the types of acute tonsillitis? There are 4 types of acute tonsillitis. Okay. So let's say tonsil. Let's say ये tonsil है. Okay. Now you know that on the medial surface of the tonsil you have got something called as crypts. The largest crypt of the tonsil is called as crypta magna. The question that comes is, what is the derivative of crypta magna? It is the ventral portion of the second pharyngeal pouch. Because second pharyngeal arch or second pharyngeal pouch is the one which gives rise to tonsil. Tonsil second pharyngeal pouch से बनती है. So crypta magna is a ventral portion of the second pharyngeal pouch का remnant. That is why it is the largest crypt of the tonsil. Okay. PDF, you can download the PDF. There would be a Telegram group that we have. Okay. So you can join the Telegram group. We are posting up all the PDF regarding all of what we are teaching. There is a workbook which you can download from the PW Meded channel. Okay. So we have given that workbook link. Go there and you can download that workbook. पूरी workbook आपको मिल जाएगी. Okay, I'm teaching the workbook as it is, right? Now, what are the types of acute tonsillitis? First is called as acute catarrhal tonsillitis. मतलब ये जो पूरा surface है, बाहर का surface है tonsil का, ये red हो गया. Acute catarrhal का मतलब peripheral surface of the tonsil becomes inflamed. This is also called as peritonsillitis. इसे हम लोग superficial tonsillitis भी कहते हैं. देखो superficially inflame हो गया. If the whole tonsil parenchyma, मतलब अब टॉन्सिल का पूरी टॉन्सिल का पैरेन्काइमा इन्फ्लेम हो गया, अब पूरी टॉन्सिल इन्फ्लेम हो गई अंदर से, इसे हम क्या बोलेंगे? दैट होल टॉन्सिल गेट्स इन्फ्लेम्ड, इट इज कॉल्ड एज अक्यूट पैरेन्काइमाटिस टॉन्सिलाइटिस. ओके. नाउ इफ द टॉन्सिल स्टार्ट्स फॉर्मिंग पस, तो अगर पस बनने लगेगा इट विल स्टार्ट फॉर्मिंग विद इन दीज क्रिप्ट. ये क्रिप्ट के अंदर पस बनने लगेगा एंड दिस फॉर्म्स लाइक स्मॉल फॉलिकल्स. इसे हम कहते हैं फॉलिक्यूलर टॉन्सिलाइटिस. दीज आर कॉल्ड एज टाइनी फॉलिकल्स. मतलब पस फॉर्मेशन विद इन दीज क्रिप्ट्स. अगर ये सारी फॉलिकल्स जुड़ गई तो दे विल फॉर्म समथिंग कॉल्ड एज अ मेम्ब्रेन, और इसे हम कहते हैं मेम्ब्रेनस टॉन्सिलाइटिस. दीज आर द 4 टाइप्स ऑफ अक्यूट टॉन्सिलाइटिस. ओके फाइन. चलो अब आगे बढ़ते हैं. अब क्रॉनिक टॉन्सिलाइटिस के 4 फीचर कौन से होते हैं? दिस इज अ वेरी वेरी इंपॉर्टेंट क्वेश्चन एंड इसे एज इट इज हमें याद करना है. राइट नाउ इफ वी ओपन द माउथ एंड इफ वी सी अ पेशेंट, तो हमारे पास एक एंटीरियर पिलर होता है, एक पोस्टीरियर पिलर होता है. This is the uvula, right? This is anterior pillar and this is posterior pillar, right? And let's say this is our tonsil in between. This is our tonsil, right? This is our tonsil. Okay. Now, what are the features of chronic tonsillitis? 4 features. First feature. The first feature of chronic tonsillitis is that there will be flushing of anterior pillars. मतलब ये जो anterior pillar है, ये अब red color का दिखेगा. There will be flushing of anterior pillar. ये red color का दिखेगा. That is the first sign. Second sign of chronic tonsillitis is that if I press over the anterior pillar, एक tongue depressor लेके, suppose ये मेरा tongue depressor है, I press over the anterior pillar, what will happen? Cheesy white material will come out of the tonsil. गंदा material will come out of the tonsil. This cheesy material, once it comes out of the tonsil, this is called as Irwin-Moore sign. This is called as Irwin-Moore sign. ये बहुत important question है. Irwin-Moore sign is seen in. It is seen in cases of chronic tonsillitis. It is a dirty cheesy material which comes out of the tonsil on pressurizing the anterior pillar. Okay. Now comes the third important point. Third important point or third feature or sign of chronic tonsillitis is because of constant infection, this tonsil could be hypertrophied or it could become atrophic. या तो बहुत छोटी होगी या ये बहुत बड़ी होगी. This is what is the third sign of chronic tonsillitis. Fourth sign of chronic tonsillitis is that because of constant infections, the lymph node of the tonsil will be enlarged, but it will be non-tender because this is not acute. So what is the lymph node of the tonsil? The lymph node of the tonsil is jugulodigastric node. Jugulodigastric node is the lymph node of tonsil. It is also called as an upper jugular node. Upper jugular node, मतलब jugular vein के ऊपर के level पे, you will find a node here, and it will be palpable, it will be enlarged, but it will be non-tender. This is the classical 4 signs which will define whether the patient has chronic tonsillitis or not. Okay? चलो आगे बढ़ते हैं. Now tonsillectomy पे आते हैं. Tonsillectomy करने के लिए there are certain indications which are asked as questions कि इनमें से कौन सा नहीं होता. There are two sets of indications. One is called as absolute, one is called as relative. Absolute indications of tonsillectomy is given by number 1 recurrent tonsillitis. ये बार बार हो रही है. And recurrent tonsillitis का there is a criteria which is called as Paradise criteria. Now what is Paradise criteria? If there are episodes of tonsillitis which are happening at least more than 7 per year, or if they are happening more than 5 episodes in 2 consecutive years, or more than 3 episodes in 3 years. 3 पे 3, 5 episodes in 2 years, more than 7 episodes in 1 year. बार बार आपके पास वो patient आ रहा है. Then this criteria is called as Paradise criteria and it fulfills that the patient should undergo tonsillectomy. आगे आते हैं. The other absolute indications are if the patient is having febrile seizures, if the patient has got peritonsillar abscess, which we will come, and it is more than 2 times that the peritonsillar abscess has happened in adults and more than 1 episode at least has happened in children. We should do a tonsillectomy. If the patient has developed obstructive sleep apnea, the patient is snoring, the patient is becoming apneic, then in those cases. And finally, if you suspect a malignancy, तो उसके केस में हमें biopsy लेनी पड़ती है. For that we need to do an excision tonsillectomy. ठीक है? These are the absolute indications जब हमें करनी चाहिए. But there are certain indications which are also relative. यानी कि I told you it is a streptococcus which is the most common GABHS. So patient might be a diphtheria or a streptococcus carrier, or you might suspect, or you might do it as a part of any other surgery, right? Now tonsil के lateral क्या होता है? Tonsil के lateral एक bone होती है, and that bone is styloid process. Styloid process के around एक nerve होती है which is glossopharyngeal nerve. So let's say this is your tonsil, right? And इसके lateral अगर हम जाएंगे, यहाँ पे एक bone है which is called as styloid, और उसके around एक nerve है which is a 9th cranial nerve, which is a glossopharyngeal nerve. Sometimes this styloid process becomes elongated, and this becomes elongated more than 2.5 centimeters. If styloid process becomes elongated more than 2.5 centimeters, it will compress the glossopharyngeal nerve, and this will produce oropharyngeal pain. This is called as styalgia. We also call it as eagle syndrome. तो ये important question है, eagle syndrome क्या होता है? It is oropharyngeal pain caused due to an enlarged styloid process causing glossopharyngeal neuralgia. Okay, so in those cases also अगर हमें styloid exercise करनी है, we need to take out the tonsil first, then exercise the styloid. So that is also as a part of other surgery, right? Second मैंने आपको बता ही दिया, it is glossopharyngeal neuralgia which will get recovered जैसे ही हम इस bone को निकालेंगे. And third, it could be also be used in a surgery which is done usually for obstructive sleep apnea. It is called as UPPP या uvulopalatopharyngoplasty. Okay, fine. चलो आगे बढ़ते हैं. अब ये मैंने 2 चीजें आपके लिए लिख रखी हैं. अब ये याद रखना है. एक होती है रोज पोजीशन, एक होती है बॉयज पोजीशन. रोज पोजीशन का क्या मतलब है? व्हाट इज रोज? रोज मतलब होता है व्हेन अ बॉय गिव्स अ गर्ल अ रोज, सो ही सिट्स डाउन एंड ही लुक्स इन फ्रंट एंड ही गिव्स अ रोज लाइक दिस. बट ये एक्चुअली रोज का मतलब ये नहीं है. ऐसे रोज आप याद रख सकते हो कि रोज ये होती है. दैट मीन्स रोज पोजीशन इज एक्सटेंशन एट बोथ द जॉइंट्स. बोथ द जॉइंट्स का मतलब एक्सटेंशन एट द सर्वाइकोथोरैसिक प्लस द atlanto-occipital joint. So there are 2 joints, one between the thorax and the cervical spine and one between the atlas and axis. So if you have both the extensions, cervicothoracic plus atlanto-occipital, then we call it as rose position. When do you use rose position? Rose position में हम 3 सर्जरी करते हैं. Tonsillectomy, adenoidectomy, tracheostomy. बस. So these are the 3 surgeries which we utilize in rose position. अब आता है what is voice. Voice का मतलब होता है जैसे suppose कोई ऐसे खड़ा हुआ है and they put their neck ऐसे आगे. So this looks like a barking dog. Some dog is barking. This also looks like I'm sniffing the morning air. So this voice position is also called as sniffing the morning air position. It is also given the name as barking dog position. Okay, अब ये किस में यूज करते हैं? सारी स्कोपी में यूज करते हैं. बट द ओनली डिफरेंस बिटवीन वॉइस पोजिशन एंड रोज पोजिशन इज कि रोज में हम दोनों जॉइंट्स का एक्सटेंशन करते हैं. वॉइस में वी फ्लेक्स द सर्वाइकोथोरैसिक जॉइंट एंड एक्सटेंड द atlanto-occipital joint. There is flexion at cervicothoracic joint and there is extension only at atlanto-occipital joint. That is the only difference between the two. अब ये सारी स्कोपी में करते हैं. सारी स्कोपी का मतलब इसोफेगोस्कोपी, ब्रोंकोस्कोपी, लैरिंगोस्कोपी. All scopy is voice position. Remember that. ठीक है? Right? Simple and straightforward. चलो अब आगे आते हैं. अब आता है बड़ा इंपॉर्टेंट क्वेश्चन जो अभी हाल फिलहाल में FMGE में भी पूछा गया. Right? And they told about कि different type के hemorrhages क्या होते हैं. They had asked and I'll tell you कि क्या क्वेश्चन था. There are 3 types of hemorrhage which can happen during tonsillectomy. एक टाइप का hemorrhage हुआ और bleeding हुई that happens during the time of surgery. कि आप कर रहे हैं सर्जरी एंड सडनली इट स्टार्ट्स टू ब्लीड. द मोस्ट कॉमन फॉर्म टू ब्लीड ड्यूरिंग सर्जरी कौन सी आर्टरी होती है जो ब्लीड करती है? इट इज द टॉन्सिलर ब्रांच ऑफ फेशियल आर्टरी विच इज ऑल्सो कॉल्ड एज टॉन्सिलर आर्टरी, जो सबसे इंपॉर्टेंट होती है, विच इज द वन विच सप्लाइज द मैक्सिमम ऑफ द टॉन्सिल. देयर इज अ वेन ऑल्सो विच इज सप्लाइंग द टॉन्सिल एंड इट इज कॉल्ड एज पैराटॉन्सिलर वेन. So दो important structures, tonsillar artery and paratonsillar vein, can be the potential bleeders during tonsillectomy, which are the most common reasons during surgery. अगर during surgery है तो मतलब हम उसे कंट्रोल कर सकते हैं, right? अब let's say आपने सर्जरी कर दी, you shifted the patient to the post-operative ward, and within 24 hours you got a call that patient is bleeding from the mouth. So if the hemorrhage occurs within 24 hours post-surgical, then we call it as reactionary hemorrhage. What is the cause of reactionary hemorrhage? Maybe कोई clot रहा होगा and that clot has dislodged, or maybe you have put some ligature and that ligature has slipped या opened, or maybe the patient has become suddenly hypertensive and a blood vessel has opened up. These are the 3 potential reasons why reactionary hemorrhages can happen. So if there is a reactionary hemorrhage, आप तुरंत उस patient को OT ले जाओ, re-explore. This will be our option. You will mark that option. कि हम ले जाएंगे OT में, we will re-explore and we will heal the bleeder. But let's say now some secondary hemorrhage. Secondary hemorrhage का क्या मतलब है? They gave the question in FMGE कि आपने tonsillectomy करी, the patient went home, third day पे patient ने chips खा लिए and the patient came to you running with bleeding. That means what? Now the patient is gone home. This is occurring post 24 hours but occurs within 7 to 10 days. Most common cause of secondary hemorrhage is infection. तो जो चिप्स था उससे इन्फेक्शन हो गया. थैंक यू हर्षित, थैंक यू. So there is infection. So most common cause of secondary hemorrhage is infection. तो इसको हम ट्रीट कैसे करेंगे? First line of management should be high grade antibiotics. If it doesn't stop, then we need to re-explore. This is how we will approach all the questions regarding tonsillectomy hemorrhages. इसमें सब कुछ है, ठीक है, राइट? चलो आगे बढ़ते हैं. नेक्स्ट, अब खत्म हो गया फेरिंग्स, ठीक है. अब हम आगे ओरल कैविटी में, ठीक है. चलो अब आगे बढ़ते हैं. अब ये बहुत सिंपल है, इसमें आई एम नॉट गोइंग टू गिव अ लॉट ऑफ टाइम टू यू गाइस, बट दिस इज वेरी वेरी सिंपल. इफ आई एम गोइंग टू प्री मैलिग्नेंट लीजन्स ऑफ द ओरल कैविटी, ठीक है. प्री मैलिग्नेंट लीजन्स ऑफ द ओरल कैविटी का मतलब ये है कि देयर आर सर्टेन इंपॉर्टेंट प्री मैलिग्नेंट लीजन्स. वी नीड टू नो एटलीस्ट 3: ल्यूकोप्लेकिया, एरिथ्रोप्लेकिया एंड ओरल सबम्यूकस फाइब्रोसिस. वी शुड नो 3. ओके. What is leukoplakia? Leukoplakia means it is a white patch or a plaque which cannot be stripped off easily, and it is at least 5 millimeters. So you see, this is a white patch or a plaque. You can see that, and it cannot be stripped off or scraped off, and this is at least more than 5 millimeters. So wherever white you see, patch you see, white patch matlab leukoplakia. Okay. Now there are 2 variants of leukoplakia most commonly. अगर ये बिल्कुल smooth है तो इसे हम कहते हैं homogeneous type. अगर ये टूटा फूटा हुआ है then it is called as non-homogeneous leukoplakia. ओके, तो अगर टूटा फूटा है तो नॉन होमोजेनस, अगर एक स्मूथ सा है तो इट इज कॉल्ड एज होमोजेनस. हाउ विल यू ट्रीट इट? ऑल प्री मैलिग्नेंट लीजन्स रिक्वायर्ड 3 अप्रोचेस, ये याद रखना सब में. फर्स्ट इज सर्जिकल अप्रोच, जिसमें हम इसको निकाल देते हैं. दैट इज समथिंग विच इज ऑब्वियसली डन. सो वी आइदर यूज इट कोल्ड स्टील और वी डू लेजर एक्सिजन. तो हम इसको निकाल के बाहर कर देते हैं. ओके, दैट इज द फर्स्ट थिंग. Second is, because this is something which is pre-malignant, we require to give the patient antioxidants. और antioxidants में सबसे अच्छा antioxidant is lycopene and beta carotene. So in all patients we give high dose lycopene as well as beta carotene. Okay. Third is a chemotherapeutic agent which is called as bleomycin, and we give them to apply topically. So we give topical bleomycin also. So जब भी erythroplakia या leukoplakia आए, it is the same management: removal, topical bleomycin, beta carotene as well as lycopene, and tell the patient to stay away from habits या गुटखा chewing. ठीक है, अब ये हमने व्हाइट पैच या प्लाक देखी है. अब अगर इसी की जगह if we see something like a red velvety patch, same thing, but a red velvety patch at least more than 5 millimeters, cannot be stripped off, cannot be scraped off from the mucosa, right? So this is something which will be erythroplakia. Erythros means red, plakia means a patch. Okay, now one important question is that erythroplakia means that this has a highest predisposition becoming malignant. So they will give you options. Which among the following is the highest to get malignant? 30% of erythroplakia will become malignant. Okay, and among which type of erythroplakia is the most dangerous? The most dangerous erythroplakia is erythroleukoplakia. Matlab, if erythroplakia is mixed with leukoplakia, it is called as erythroleukoplakia, and that is the most dangerous form which can turn malignant. तभी हमेशा इसको भी what do we do? Surgically excise, topical bleomycin, high dose beta carotene, lycopene, and cessation of habits. Same thing what we read in leukoplakia. Right? Okay? Thank you, Souvik. Thank you. ठीक है, चलो आगे बढ़ते हैं. अब we come to oral submucous fibrosis. अब ये क्वेश्चन आ चुका है. Oral submucous fibrosis, right? मतलब म्यूकोजा के पीछे की बात हो रही है. That is submucosa, and that is getting fibrosed. The other name is sclerosing stomatitis. ठीक है, अब energy is getting drained. See, when you come to my side, when you become a surgeon, when you become a physician or surgeon, I am a surgeon. This is my daily work. Okay, so what we do is, then you will also get get energetic. You will also see. My main motive is to make you guys excel in what you do. If I get that, I can take 7 to 8 hours class, no problem. If it serves the purpose. So my whole idea is to make you guys into something which you guys dream of. That's all. Okay, that's all the motive is behind. So that requires some amount of energy. Good. It is, and I'm very happy that you guys are still watching, you guys are still active, because this is a brain drain today. But that is what is the fun part about it. That is what the best part about it is, that we keep hanging, we keep working together, we keep getting the positive results out as much as we can. ठीक है, चलो अब आते हैं oral submucous fibrosis क्या होता है. So I told you this is a progressive fibrosis that happens in the submucosal tissues, right? This is a submucosal tissue, right? Very good. So now most common cause क्या होता है? अब आधे से ज्यादा इंडिया में क्या चलता है? गुटखा चुइंग. और एक चीज होती है जैसे हम कहते हैं एरिका नट. एक एरिका नट होता है, राइट? So एरिका नट chewing is the most common cause of submucous fibrosis. एरिका नट is also called as betel nut. ये पान में बहुत डालते हैं, right? Okay. Now this, but the best part is that erythroplakia had 30% chance of becoming malignant. ये उतना malignant नहीं होता. It is 1 to 15% of people who end up into malignancy. अब अगर मैं आपको दिखाऊं ये कैसा दिखता है, so see this. This is how it looks like. There are two things what you will see in this case. There are two things what you will see in cases of oral submucous fibrosis, right? One is that they will have these kind of blisters. You can see these kind of ulcers. So in the earlier stages of submucous fibrosis, उनमें खूब सारे ulcers बनते हैं. They'll be like blisters. फिर ये blisters फूट जाते हैं. They will break. And when these blisters break, they heal with fibrous tissue. So when they form, so in the earlier stages, these blisters are present. The patient will have a lot of burning of mouth. But later on, these blisters will heal, and they heal with fibrous tissue formation, and that will lead to these fibrous band formation, which will lead to trismus. Trismus is difficulty in mouth opening. So अगर मैं बोलूं, there are only two symptoms which are related with oral submucous fibrosis: ulcer, और उसके बाद the blisters or the ulcers, and then trismus. These are the two things that you will see, right? Now the treatment of this is obviously the same. You will give avoidance of habits. You will give the same high dose beta carotene and lycopene. But here you need to break these bands. तो इसको बैंड को ब्रेक करने के लिए हम क्या करेंगे? We can't do just a surgery, क्योंकि अगर हमने सर्जरी कर दी तो the band will heal again, और वो फिर fibrous tissue बन जाएगा. So we need to do something about it in order to break them. How do we do that? We use something called as intralesional injections. और वो intralesional injection क्या होते हैं? We'll take, let's say my pen is an intralesional injection. I'll fill this pen with a steroid, which is triamcinolone. and I'll also fill it with a substance which is called as hyaluronidase. Hyaluronidase का मतलब है काटने वाला hyaluronic acid को. And triamcinolone is a steroid which is anti-fibroblastic. I don't want fibroblast. So I'll put this injection straight away inside the band and inject it. So when I inject it, it will lead to healing of this area. It will lead to dissolution of this band. And at the same time, when I'm doing this, I'll give the patient a jaw appliance. Jaw appliance मतलब उसको एक mouth stretching appliance दूंगा, which the patient will keep stretching the mouth. So jaw appliance is the next mode of treatment that we give. अब अगर इन सबसे ये बैंड भी अभी भी नहीं टूटे and the patient has got very severe mouth reduction opening, that is very high trismus present, in those cases we'll choose a surgical management. अब surgical management में हम क्या करेंगे? We will cut these bands. हम इसको काट देंगे. But अगर हमने काटा, this fibrous tissue will grow back again. तो अब उसको growth को रोकने के लिए what we'll do? We'll put an interposition graft. Interposition graft मतलब we'll take a thigh graft, and what we will do? We will just put or interpose a thigh graft between it, ताकि ये वापस से ना बन जाए. Or we'll put a flap in between. Right? So this is something that is very, very important. Okay? Fine. So this is what defines oral submucous fibrosis management. अगर अभी भी ठीक नहीं हुआ, then what we need to do? We need to cut the temporalis muscle fibers. Temporalis muscle is a mouth, it's a jaw closer. तो temporalis को अगर हम काट देंगे तो mouth open हो जाएगा. तो उल्टा of temporalis. That means we need to cut the temporalis fibers so that the mouth can open, because temporalis का function होता है mouth को close करना. So we will have to cut the temporalis fibers, and that is called as coronoidectomy, because coronoid process पे temporalis attaches. तो इसीलिए हम coronoid process को remove कर देंगे. That's called as coronoidectomy. ठीक है, चलो अब आगे बढ़ते हैं. अब एक चीज I want to teach you all, very very important, that is, अब हम थोड़ा नीचे जाते हैं, right? मीटोमाइसिन सी यहाँ नहीं काम करेगा, क्योंकि मीटोमाइसिन सी itself हम बार बार नहीं लगा सकते. It has got its own side effects. तो यहाँ पे this is something which is very very chronic. There's something which is not going to work off, क्योंकि पूरे मक्कल म्यूकोजा, पूरे pharynx में there are fibrous bands. So we need something more stronger, right? Okay, that's why we put a flap or a graft. What is pharyngeal pouch? Okay, so let me just go straight to the image of it. ये pharyngeal pouch है. Pharyngeal pouch होता क्या है? Pharyngeal pouch का दूसरा नाम is also called as Zenker's diverticulum. Zenker's diverticulum. It is also called as a pharyngeal or a hypopharyngeal pouch, right? Now, what is this? This is a type of Pulsion diverticulum, and it is a type of false diverticulum. It is not a true diverticulum. It is a Pulsion or a false diverticulum, right? Now, what you're seeing here, this is a cross section of your pharyngeal muscles, okay, from behind, okay. And what all the muscles do you see over here? So there is a muscle which is called as inferior constrictor muscle. Inferior constrictor के दो parts होते हैं. One is called as thyropharyngeus part. One is called as cricopharyngeus part. One is thyropharyngeus. One is cricopharyngeus. Okay. Thyropharyngeus part is present above. ये हमारा thyropharyngeus muscle है. This is thyropharyngeus, and this is our cricopharyngeus muscle. The potential anatomical space present between the cricopharyngeus below and the thyropharyngeus above, this space, this is called as Killian's dehiscence. Okay. Now there is another important area which is important for our exams, that is called as Lammer's dehiscence या Lammer's triangle. What is Lammer's dehiscence या Lammer's triangle? A potential area which is present between the cricopharyngeus above and the outer longitudinal fibers of the esophagus below. See, this is the outer longitudinal fibers of esophagus, and this is the cricopharyngeus, and can you see this deficiency or opening? This is called as Lammer's triangle, right? Now what will happen? Let's say when the patient is swallowing, right? When the patient is swallowing, the bolus gets pushed because thyropharyngeus contract करती है और cricopharyngeus relax करती है. That is how the bolus is pushed. But let's say in some patients what happened was that there is tonic spasm of the cricopharyngeus. ये cricopharyngeus relax नहीं करी, ये tonically spasmed है. यानी thyropharyngeus is also contracting, cricopharyngeus is also contracting. So now what will happen? The food bolus will not get pushed below. Rather, it will get pushed out through this. The pharyngeal mucosa will get pushed out through this opening, and it will form something called as a Pulsion diverticulum. And this Pulsion diverticulum or a false diverticulum, क्योंकि ये true diverticulum नहीं है. This is nothing but pharyngeal mucosa coming out of these dehiscence, and this is called as pharyngeal pouch या फिर Zenker's diverticulum. Right? So what will we see when we actually put a barium swallow? So the investigation of choice is a barium swallow. This is what is the investigation of choice, and I already told you what is Killian's dehiscence, what is Lammer's dehiscence. Now imagine, whenever the patient will eat, the food will not only go into the esophagus, but will also go inside into this pharyngeal pouch. And what will be the symptom of this patient जो आपके पास आएंगे, that they will always regurgitate food back. बार बार उनका regurgitation होगा, बार बार vomiting होगी, so they will be afraid of eating. So because they are afraid of eating, they will end up into emaciation and weight loss, right? And accidentally, this food can also spill over into the airway or trachea, and they can lead to aspiration pneumonia. So that is why they usually present with regurgitation of undigested food, and a very bad smell comes out of the mouth, which is called as halitosis. And that is the reason why these people don't eat much, which ends up into their weight loss. And if it goes inside into the larynx and the lungs, then there will be features of aspiration pneumonia and there will be features of laryngitis. So this is what is the exact feature of pharyngeal pouch. Investigation of choice कैसे देखते हैं? It is a barium swallow. How you see this pouch. अब एक इंपॉर्टेंट साइन इसमें आता है, विच इज कॉल्ड एज बॉयज साइन. अब याद रखना, देयर इज समथिंग ब्राइस साइन और एक होता है बॉयज साइन. ब्राइस लैरिंगो में आरवाई आता है, तो ब्राइस में भी आरवाई आता है. दैट इज अ साइन विच इज सीन इन लैरिंगोसील. बॉयज साइन इज अ फीचर ऑफ पाउच. ओके, एंड व्हाट इज बॉयज साइन? ये पाउच एक स्वेलिंग की तरह होगा, राइट? सो व्हाट वी विल डू व्हेन वी प्रेस ओवर, राइट, व्हेन वी प्रेस ओवर दिस pharyngeal pouch, then it will create a gurgling sound. So that gurgling is nothing because of the food that is present inside, and that is what is called as Boyce sign. How will you diagnose it? You do a barium swallow. Okay, fine. Now, what is the treatment of choice? Ya to we give an incision over the cervical area and we excise it. So that is called as transcervical excision of the pouch. And we also release the tonic spasm of the cricopharyngeus muscle. So we give an incision over the cricopharyngeal. So if we give an incision over the cricopharyngeus, it's called as cricopharyngeal myotomy. Myotomy मतलब muscle को open करना, right? At the same time, we can also do something called as endoscopic stapling. उसका क्या मतलब होता है? That let's say this is the esophagus and this is the false diverticulum that has formed. So what we will do? We will take a laser and we'll excise out the bridge between them. ये हम इसको हटा देंगे. We excise out the bridge between them. And now what we will do? We will endoscopically staple them. एंडोस्कोपिकली हम इसे स्टेपल कर देंगे ताकि ये एक लूमन बन जाए, सो दैट द फूड बोलर्स कैन पास इजीली. दिस इज कॉल्ड एज एंडोस्कोपिक स्टेपलिंग विद डॉल्मेंस प्रोसीजर. ओके, फाइन. दिस इज व्हाट यू शुड नो एटलीस्ट अबाउट व्हाट इज द फेरेंजियल पाउच. ठीक है, चलो आगे बढ़ते हैं. डीप नेक स्पेस इन्फेक्शंस, अब ये खत्म करते हैं. इसमें बहुत सारी कहानियां, इसमें बहुत सारी चीजें आती हैं, राइट? बट इसमें आई टेल यू समथिंग विच इज वेरी 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 इजी वे in which you can understand कि इनके क्या questions आते हैं. Parapharyngeal, retropharyngeal space, Ludwig's angina, peritonsillar space abscess, ये सब क्या होती है? How this forms? This is something we'll finish off quickly, right? इसमें बहुत time नहीं लगेगा, but this is very very important for you to take. ठीक है. First is peritonsillar abscess. अच्छा, Lemur's triangle you want to again? Lemur's triangle is a triangle which is formed by the cricopharyngeus fibers above and the outer longitudinal fibers of the esophagus below. Okay? चलो, अब what is peritonsillar abscess? अगर ये टॉन्सिल है, इफ दिस इज योर टॉन्सिल, ओके, लैटरल टू द टॉन्सिल इज योर टॉन्सिलर कैप्सूल. यहां पे होती है टॉन्सिल की कैप्सूल. लैटरल टू द टॉन्सिलर कैप्सूल इज अ लूज एरियोलर टिश्यू. मतलब जो नेक्स्ट लाइनिंग होती है, दिस इज अ लूज एरियोलर टिश्यू. आफ्टर द लूज एरियोलर टिश्यू देयर इज एन इंपॉर्टेंट फेशिया which is called as pharyngobasilar fascia. After the pharyngobasilar fascia, it is an important muscle जिसे हम कहते हैं superior constrictor muscle. And behind the superior constrictor muscle एक और fascia होता है which is called as buccopharyngeal fascia. तो bucco मतलब बाहर, pharyngobasilar मतलब अंदर. B for bucco, B for बाहर. ठीक है, उसके बीच में होती है superior constrictor muscle. So what is the lateral bed of the tonsil? First is capsule, then comes loose areolar tissue, then comes pharyngobasilar fascia, then comes superior constrictor muscle, then comes buccopharyngeal fascia. The space present between the superior constrictor laterally and the capsule medially, this little space over here, this is your peritonsillar space. अगर किसी भी वजह से इसमें पस बन गया, और if there is any infection or pus formation that happens within this area, then what will happen? The tonsil will get pushed medially. हमारी tonsil जो है वो medially push हो जाएगी. ये tonsil हमारी medially push हो जाएगी. and the uvula will become laterally deviated. Uvula lateral चला जाएगा, tonsil medially shift हो जाएगी, right? So what did I tell you? This is a space present between the capsule and the superior constrictor muscle. Most common, it is the one which is most commonly occurring in adults. Adults में क्यों होता है? Because adults में tonsillar atrophy हो जाती है, tonsil atrophy कर जाती है. So this superior constrictor and capsule come more together. They come more aspas, and that is the reason why adults have more peritonsillar abscess. Most common organism for peritonsillar abscess is Streptococcus pyogenes, then comes Staph aureus, and then comes anaerobic bacteria. But most common is Streptococcus pyogenes, right? Now, if you see this, this is how I told you that your tonsil has gotten medially enlarged, right? There is redness, there is erythema. The tonsil has gotten medially, right? And the uvula has deviated more laterally. Okay, this is what we have read. Now, what will be the symptoms of this patient agar aise aata hai to? So the symptoms of this patient will be that the patient will obviously have got a very high grade fever. The patient will have severe odynophagia. They will not be able to eat. The patient will have drooling of saliva. They cannot even swallow their saliva back, right? Patient will be dehydrated. And the classical picture of voice seen in oropharyngeal lesions is hot potato voice. Hot potato का मतलब किसी ने गरम गरम आलू रख दिया है in your throat, right? Now, if there is a garam garam aloo that is kept in your throat, you must have eaten a garam aloo, right? How does it feel, right? You say, so that is thick, muffled voice that comes out. That thick, muffled voice that comes out is a characteristic of oropharyngeal and supraglottic pathologies. So that produces hot potato voice, which is characteristically seen in peritonsillar abscess, right? So, हमें edema दिखेगा, soft palate का, right? And we will see tonsillar area, right? At the same time, it will also cause, because see, it is very near our pterygoid muscles, so it will cause trismus. Why? Because it will cause irritation of the pterygoid musculature. And if the pterygoid muscles get irritated, it will even lead to difficulty in mouth opening, which is called as trismus. Okay? There will be deviation of the uvula towards the opposite side, which we have already told. And if we see the tonsil, then there will be frank pus which will come out of the tonsil. Pus निकलेगा tonsil के ऊपर से. This is what is quinsy, or this is what is peritonsillar abscess, right? अब अगर इस abscess को हमें ठीक करना है, what will we do? The first line of treatment is obviously medical, where we try putting high-grade antibiotics in order to counter the infection. But the most important is to drain it, which is by incision and drainage. कभी भी tonsillectomy नहीं करते हैं. Never ever we do hot tonsillectomy. Hot tonsillectomy का मतलब we never do a tonsillectomy during active infection. Why? Because अभी infection spread हो जाएगा. It can lead to sepsis. So we never do it. Why do we never do it? Because पहले हम incision and drainage करेंगे. Incision and drainage कैसे करेंगे? हम लोग क्या करेंगे? We will draw an imaginary line along the base of uvula, one line, and one line along the anterior pillar. The point where this is intersecting, इस point पे we will take a blade and we will poke it. और बस वहीं से सारा का सारा जो जितना भी पस है, it will come out. It will start draining out. This is how we drain a peritonsillar abscess. एक line along the base of uvula, one line along the anterior pillar where it intersects. That is the highest point where the abscess is formed, and we will just poke it there, and so that we will drain out all the abscess or all the pus that has accumulated in this space. Okay, this is what finishes about what is peritonsillar abscess. Okay, after 6 weeks to 8 weeks, when the patient has got less acute infection चला गया है, then in order to prevent its recurrence, then we will do interval tonsillectomy. Interval tonsillectomy मतलब 6 से 8 हफ्ते बाद we will do that, right, when the infection has gone away. This finishes peritonsillar abscess or your first important deep neck space infection, what you require for quinsy. Second important question जो आता है, that is Ludwig's angina. Angina का मतलब ही होता है pain, and it is Wilhelm Ludwig who was the first one who actually saw this, and that is why it is called as Ludwig's angina. Now, two things that you need to remember in Ludwig's is, this is a superficial spreading cellulitis. That means this is not pus forming. This is a superficial spreading cellulitis of the submandibular and the submental space. मतलब ये पूरी की पूरी space will become big. इसकी cellulitis हो रही है. That means the subcutaneous tissue is becoming enlarged, but there is no pus formation. There is no pus in cases of Ludwig's. There is no pus in cases of Ludwig's. Okay, fine. Now let's say ये एक area है जो हम submandibular पढ़ रहे हैं, and submandibular area is divided by a muscle जिसे हम कहते हैं mylohyoid muscle. So you can see that this is our mylohyoid muscle, and it divides this whole of submandibular space into two smaller spaces. One space is present above the mylohyoid जिसे हम कहते हैं sublingual space. इसे हम कहते हैं sublingual space, and one space is below the mylohyoid, and we call this as submylohyoid space. Okay, so one is above, which is called as sublingual space, one is below, which is called as submylohyoid, यानी ये इसके नीचे है. Together this sublingual space and together with this submylohyoid space, together हम इन दोनों को बोलते हैं submandibular space. Now what you can see near it, आप क्या देख रहे हो? यहाँ पे देख रहे हो एक दांत है. There's a teeth over here. So that means the most common cause of Ludwig's angina has to be dental infections. तो कोई भी आपके पास क्वेश्चन में डेंटल इन्फेक्शन आया, think about Ludwig's as your possible answer. So patient has gone for a root canal treatment, patient has gone for a tooth caries treatment, something will happen. This dental infection will straight away enter in this and will start forming, again this will produce cellulitis, and this will lead to polymicrobial cellulitis of the submandibular and the submental spaces. Okay, so that is why I've written it over here that the most common cause is dental. Most common organism is mixed aerobic infections, right, and anaerobes. And finally, it is a superficial spreading cellulitis of the submandibular and sublingual spaces. It is never pus forming, it has got no pus into it. Okay, that is why when you see a child with any case of Ludwig's angina, so is child के there will be a huge swelling present in the submandibular and sublingual area together, क्योंकि ये पूरी cellulitis ऐसे फैलेगी. Right, now when I press this, अगर मैं इसको press करूंगा, so it will be woody hard because it is cellulitis, it is not pus. Pus जो होता है is boggy, so this is woody hard, right? So if it is woody hard, right, that is why it is also called as brawny neck edema या brawny neck induration. Induration का मतलब होता है whenever you palpate you feel firmness, that is called as induration. So this is called as brawny neck induration. It is woody hard tenderness. Right, now if there is so much of swelling over here, then obviously the floor of the mouth also will get swollen, and if the floor of the mouth gets swollen, then the tongue will get lifted up. If the tongue will get lifted up, then what will happen? The patient will end up into stridor. So these are the people which will end up into airway problems, because they will come in stridor and you don't have any place to intubate them. तभी हमें इसमें tracheostomy करनी पड़ती है, because we can't intubate these children if they come in such conditions. Right, so they will have pain, drooling and woody hard swelling, they will have bilateral submandibular space swellings, they will have tongue elevation and edema at the floor of mouth, and because of the irritation of the pterygoid muscles, they will also lead to trismus. Okay, so this is what is about Ludwig's angina. Okay, now how do you treat it? So treatment is also simple. We give an incision from mastoid to mastoid. So एक हमने blade लिया and we take from one mastoid to another mastoid, हमने एक incision मार दिया. So this looks like a little suicidal incision. तभी हमने थोड़ा सा इसको अब modify कर दिया है. And modify क्या किया है अब हम लोगों ने? That now instead of giving a whole incision from mastoid to mastoid, we give two incisions, one over on one submandibular space, one on another submandibular space, and we keep drains into it. इसके अंदर हम drain लगा देते हैं. So these are only to decompress. It is only to relieve the pressure of the compartment so that the child can get a little better, right? But there will be no pus that will come out. Remember that. Okay, चलो आगे बढ़ते हैं. Now we enter into retropharyngeal and parapharyngeal space abscess. ठीक है, अब ये वाला जो होता है ये सबसे tricky होता है. This is something which usually people falter out on. ठीक है, अब इसको ऐसे देखो. This is something which is given in your textbooks also, right? This is the same diagram. I'm going to teach everything on the same diagram. अगर हम अपनी neck को इस तरीके से काटते हैं, axial, and we look from the top, right? अगर हम axial काट के ऊपर से देखते हैं, so what will we see? What are the layers that we will be able to see? Right, so सबसे पीछे we will be able to see the vertebra. ये देखो ये सबसे पीछे है. You'll be able to see the vertebra, right? Vertebra के सामने क्या होती है? There is these prevertebral muscles, correct? In front of the prevertebral muscle there is this fascia which is called as prevertebral fascia, which is written over here. ठीक है? The space present between these prevertebral fascia and the vertebra, this space here is called as prevertebral space. That is the first space. Okay, now let's come to the second space. In front of the prevertebral fascia there is another fascia, and this fascia present in front of the prevertebral fascia, this fascia here, this is called as alar fascia. The space present between the alar fascia anteriorly and prevertebral fascia posteriorly, इस space को हम कहते हैं danger space. This is called as danger space. Okay, that is the second point. अब हम लोग आते हैं third space पे. अब देखो हमने ऐसे काटा था. So that means this was the tonsil that you're looking from above, right? एंड टॉन्सिल के पीछे मैंने बहुत सारी लेयर्स बताई थी, जिसमें सबसे पीछे मैंने बताई थी दैट देयर इज अ मसल विच इज योर सुपीरियर कॉन्स्ट्रिक्टर मसल, राइट। एंड सुपीरियर कॉन्स्ट्रिक्टर मसल के मैंने पीछे एक फेशिया बताया था, दैट मीन्स बक्को मतलब बाहर, सुपीरियर कॉन्स्ट्रिक्टर के बाहर एक बक्कोफेरेंजियल फेशिया होता है. So I told you that there is a fascia present behind the superior constrictor which is called as buccopharyngeal fascia. ये हो गया buccopharyngeal fascia, right? So now you can see a potential space present between this and this. So that means one space which is present between the alar fascia posteriorly and the buccopharyngeal fascia anteriorly, this space is called as retropharyngeal space. Retropharyngeal space is further divided by a median fibrous band into two smaller spaces, and these two smaller spaces which are present, they are called as spaces of Gillette. इन्हें हम क्या कहते हैं? इन्हें कहते हैं space of Gillette. Space of Gillette. अब देखो इसमें क्या क्वेश्चन बनता है. ये जो दो छोटी छोटी स्पेसेस हैं, they contain retropharyngeal nodes. इन्हीं के अंदर होते हैं retropharyngeal nodes. The other name for retropharyngeal node is also called as node of Rovier. This is the most common cause of infection during childhood retropharyngeal abscess. इन्हीं में lymphadenitis हो जाती है, ये abscess बन जाती है. So in children this is the most common cause of getting separated. Okay, fine. अब ऐसे सोचो, अगर कभी भी retropharyngeal abscess होगी, so these nodes will separate, right? The most common cause of retropharyngeal abscess, मतलब यहाँ पे पस बन गया. The most common cause of retropharyngeal abscess in children is trauma. That means let's say यहाँ से कोई आया, somebody has traumatized the posterior pharyngeal wall, right? Child was eating something, he traumatized, pencil खा रहा था, suddenly traumatized. So what happens? Organisms entered and they produced a bulge. But ये bulge बिल्कुल बीच में नहीं होगी. It will not be a posterior pharyngeal wall बीच में bulge. It will be a paramedian bulge. क्यों? क्योंकि बीच में तो there is this median fibrous tissue ना. So there will be a paramedian bulge which you will see in cases of retropharyngeal abscess. If you open the mouth, you will see a paramedian bulge. मतलब median से थोड़ा side में you will see a posterior pharyngeal wall bulge. If you open the mouth of the patient, posterior pharyngeal wall में bulge मिल जाएगी center में. So the most common cause is trauma. And what will they produce? They will produce a paramedian bulge. Paramedian bulge. Okay? In the posterior pharyngeal wall. In the posterior pharyngeal wall. That is what we have understood. Okay? Right? Why does that happen? It occurs due to the suppurative lymphadenitis of the nodes of Rovier. It occurs because of lymphadenitis, because of nodes of Rovier. This is also we have understood. Okay? What is the most common cause of retropharyngeal abscess in adults? This is for children, right? Adults में most common cause of retropharyngeal abscess is actually TB spine, या pot spine, या caries spine. So it will come out and it will produce pus over in this area. So caries spine adults में है, trauma children में है. Nodes of Rovier usually get separated in children. Usually this infection causes a cold abscess formation क्योंकि TB हमेशा cold होता है in cases of adults. Where is this retropharyngeal space? It is between the alar fascia as well as the buccopharyngeal fascia. Divided by median fibrous tissue, spaces of Gillette. Contain node of Rovier. This is what finishes what is retropharyngeal abscess. Okay. अब parapharyngeal abscess देखो. Para मतलब around, मतलब ये इसके थोड़ा सा साइड में, मतलब ये बीच में retropharyngeal है, इसके बाहर para. अगर हम साइड में आ जाते हैं, this is our parapharyngeal abscess which we are seeing, right? Now, the lateral boundary, मतलब parapharyngeal, अब ऐसे सोचो मैं ऐसे चला गया साइड में तो laterally क्या आ रहा है? ये mandible आ गई. So laterally, it is our mandible which is a lateral limit of parapharyngeal space. Mandible के बाहर और mandible के अंदर कौन सा attachment होता है? Mandible के बाहर there is an attachment of masseter muscle, right? So you clinch your mandible, you will feel that this is your masseter. और masseter के just अंदर, मतलब what is there underneath the mandible here? इस तरफ mandible के medial क्या attach हो रहा है? That is our medial pterygoid muscle. This is a medial pterygoid muscle. मतलब एक साइड में, इधर masseter साइड में, outer. ठीक है? This is our parapharyngeal space. मतलब अगर हम देखें parapharyngeal space है क्या? It is something which is present lateral to the buccopharyngeal fascia and between the mandible. This is our parapharyngeal space. This is divided by a bone which is called as styloid process. अब यहाँ पे एक bone होती है which is our styloid process, which divides the space into one compartment in front, one compartment behind. The compartment which is in front of styloid इसको हम लोग कहते हैं प्री स्टाइलॉइड कंपार्टमेंट. द कंपार्टमेंट विच इज बिहाइंड द स्टाइलॉइड, इसे हम लोग कहते हैं पोस्ट स्टाइलॉइड कंपार्टमेंट. ओके, सिंपल. तो अगर ऐसे सोचो, किसी को भी अगर पैराफेरेंजियल स्पेस में प्री स्टाइलॉइड कंपार्टमेंट में पस भर गया, यहां पे अगर पस भर गया, तो व्हाट विल बी द क्लिनिकल फीचर ऑफ दिस पेशेंट? 3 clinical features will be seen. 1, the tonsil will get shifted medially. Correct? 2, there will be trismus. Why? Because the medial pterygoid muscle will get irritated, क्योंकि वो उसके बगल में, so it will get irritated. Patient will have trismus. 3, this will produce a swelling present at the angle of jaw. So 3 things: trismus, tonsil will be pushed medially, and there will be a swelling at the angle of the jaw. अब आप मुझसे पूछोगे, tonsil was getting pushed medially even in peritonsillar abscess, tonsil is getting pushed even in parapharyngeal abscess, तो ये कैसे पता चलेगा कि कौन सा क्वेश्चन है? तो दोनों में tonsil medially push होती है, uvula laterally deviate होता है, but angle of the jaw पे swelling सिर्फ parapharyngeal का feature है, it is not a feature of peritonsillar abscess. So they will give you that there is also a swelling at the angle of jaw, the answer will become automatically parapharyngeal abscess. Okay, this is something for the pre-styloid. अब अगर पोस्ट स्टाइलॉइड में चली गई, पोस्ट स्टाइलॉइड इज अगेन न्यूरोवास्कुलर. इट कंटेन्स कैरोटिड शीथ, इट कंटेन्स 9th nerve, 10th nerve, 11th nerve, 12th nerve, sympathetic chain. So you will give 9th, 10th, 11th, 12th cranial nerve palsy. Sympathetic chain will be involved, which will produce Horner's syndrome. Carotid artery will get ruptured. Internal jugular vein can get thrombosed. सब चीजें इन्वॉल्व कर सकता है when it goes into the neural compartment, which is post styloid. ओके फाइन, दिस फिनिशेस ऑल इन ऑल. ये पैराफेरेंजियल क्या होती है, और ये भी खत्म होता है व्हाट इज रेट्रोफेरेंजियल. दिस इज व्हाट द होल क्राइटेरिया अबाउट पैराफेरेंजियल एंड रेट्रोफेरेंजियल एब्सेसेस, व्हिच आई हैव ऑलरेडी गिवन यू in total about what is this. I've already written everything. Tonsils push medially, trismus, bulge at the angle of jaw. ये सब हम लोग पढ़ चुके हैं. Post styloid में you will get torticollis due to the spasm of prevertebral muscles. You will get all these cranial nerve palsies, jugular venous thrombosis, carotid rupture. ये सब आपके नोट्स में ऑलरेडी है. So I'm not going into that. This is something I've already told you. खत्म. चलो, फाइनल आ गया आज का टॉपिक. फाइनल आ गए हम लोग फाइनल सेगमेंट पे, और अब खत्म करते हैं जल्दी जल्दी लैरिंक्स, राइट? बिकॉज आई नो यू गाइज मस्ट बी वेरी वेरी टायर्ड, राइट? एंड दिस इज माय फाइनल टेक फॉर टुडे. ओके, अब लैरिंक्स से जल्दी जल्दी आगे जाएंगे, राइट? लैरिंक्स बहुत आसान है, लैरिंक्स से कुछ ज्यादा नहीं है, स्ट्रेट फॉरवर्ड इमेजेस हैं, राइट? We'll straight away start from the infections and inflammation of larynx. ठीक है, ये क्या होते हैं? तो इसमें 2 इंपॉर्टेंट चीजें हमें पढ़नी है. वन इज acute epiglottitis, वन इज croup. दोनों के बीच में क्या डिफरेंस होती है? इन्फ्लेक्शंस और इन्फ्लेमेशन ऑफ larynx में सबसे इंपॉर्टेंट पहली चीज आती है acute epiglottitis. Now see this, everything I'll tell you here only. Whenever you had acute epiglottitis, that means it is an acute inflammation of the epiglottis and supraglottic structures. Most common organism that is seen in children is Haemophilus influenza, which causes epiglottitis. Most common cause in adults to cause epiglottitis is Streptococcus pneumoniae. Remember that. Okay, fine. आएगा. RLN, SLN, I'm coming. Vocal palsy will come. ठीक है, वो सब I'll teach you in this, right? So this is something about that, right? Now, one more important thing is this occurs in school-going children. So always remember this occurs in school-going children. Right, about 4 to 6 years of age. This is a bacterial inflammation. This is not viral. Okay, this occurs in 4 to 6 years of age. Now, whoever has got, what are the clinical features of this particular condition? Now, see, the epiglottis becomes such red and erythematous and enlarged. So, this red erythematous enlarged epiglottis is called as a cherry red epiglottis. It is also called as a cherry sign, or a cherry signed epiglottis. Okay, or a red sign epiglottis. Okay. So basically this is cherry red epiglottis. Obviously if there is such a big epiglottis, then how will the baby breathe? So this also causes one of the features of inspiratory stridor. The patient will come with difficulty in breathing. Inspiratory stridor. Expiration में कुछ नहीं, but इतनी बड़ी epiglottis हो गई है so patient cannot breathe in. Right? The patient will not be able to eat food, so they will have severe odynophagia. If they cannot eat food, they will have drooling of saliva. And very important condition is that after fever is that they will sit in tripod position. ये बड़ा important catch point है. अब epiglottis ताकि पीछे ना जाए, they will sit like this. And if they sit like this so that they can breathe, the epiglottis will fall forward and that will help them breathe. This is called as tripod sign. So tripod position is seen in what? It's seen in epiglottitis. Okay. Now, if we do an X-ray, right? If we do a lateral soft tissue neck X-ray, what will we see? We will see that the epiglottis has enlarged like a thumb. ये ऐसे thumb की तरह enlarged है. This is called as thumb sign. This is called as thumb sign. This is what you should remember about epiglottitis. Okay. How do you treat it? So this I'm going to tell you a mnemonic. Okay. So this is a 6H mnemonic. The same mnemonic will work for croup also. तो ये 6H mnemonic दोनों में होता है. Any patient of epiglottitis or croup, right, will come with a hospitalization. सबसे पहले hospitalization करेंगे और उनकी airway manage करेंगे by tracheostomy या फिर intubation. Arshid is saying all 19 subjects. I won't be able to stand so long for 19. Okay, ENT I can manage for you. That I can take. But 19 के लिए we have got mentors for you. Everyone will grill you in the same way. Okay, चलो. So now comes second is head end will be raised, right? So head end का raise का मतलब that the head end should be up. It should be propped up ताकि हमें breathing better हो. Okay, so this is called as head end raising. It will prevent the falling of epiglottis. तीसरा H, start the patient on humidified oxygen. ज़्यादा ऑक्सीजन दो. ठीक है. Fourth H is hydrocortisone. Hydrocortisone is a life-saving drug here. Why? क्योंकि hydrocortisone decreases significant edema of airway. एयरवे खुल जाएगा, ज्यादा ब्रीदिंग होगी, ज्यादा बेहतर ऑक्सीजनेशन होगा. Fourth, high dose antibiotics, penicillins or cephalosporins because it is an acute infection. Sixth, high dose of nebulized epinephrine. तो epinephrine को हम nebulize कराते हैं. Epinephrine is what? Epinephrine is a sympathomimetic drug. Whenever sympathomimetic I tell you, so where does epinephrine act? It is a non-selective alpha and beta agonist. So it will act on alpha 1, beta 1 and beta 2 receptors. When it goes to the alpha 1 receptors, what will it do? It will cause vasoconstriction. Agar vasoconstriction hoga, so obviously the tissue will also shrink. So that will lead to better airway. If it acts on beta 1 receptors, it will increase the heart rate. So the heart rate will get increased. There will be better, stroke volume. Okay. And second is beta 2 receptors are present over on the smooth muscles and they will cause bronchodilation. Okay. So these are the three things what epinephrine does, life-saving drug, not only for epiglottitis but also for croup. ठीक है, चलो अब आगे बढ़ते हैं. Now we come to the next one, laryngotracheobronchitis या फिर croup. अब अगर मैंने बताया epiglottitis is a bacterial infection, croup is a viral infection. ठीक है. If epiglottitis occurs in cases of school-going children, croup occurs in 6 months to 2 years of age. This is the difference. ये छोटे बच्चे हैं. Whenever laryngotracheobronchitis या croup comes, आप में 3 चीजें दिखती हैं. 3S you will see. And what are the 3S that you will see? The patient will have stridor, the patient will have severe chest retractions, and the patient will have seal-like barking cough. So seal-like barking cough, severe retractions, and stridor. If you see in a 6 to 8 month old child or 1 year old child, answer aankh band karke is croup. If that was epiglottitis was a bacterial infection which was happening because of Haemophilus influenza and Streptococcus pneumoniae, this has to be because of para-influenza virus. It's a viral infection, right? Now, if we do the investigation, if we do a AP view of an X-ray or an X-ray, then in the AP view, what will you see? कि इनका जो cervical trachea है and the subglottic region. Subglottis matlab the area within the cricoid cartilage is called as subglottis. So you will see that their trachea and their subglottis has gotten considerably narrowed. This looks like the top of a church, which is called as steeple sign. It is also given the name as pencil tip sign. It is also given the name as wine bottle sign. Right? This is what is the understanding about ये. Right? This is also called as wine bottle sign. ठीक है? चलो आगे बढ़ते हैं. इसका भी same treatment है. What I told you, this also has got the same treatment as it is of epiglottitis. ठीक है? अब chronic laryngitis में, chronic inflammation of the larynx में सबसे important is TB या tuberculosis of larynx. ठीक है? अब tuberculosis of larynx में क्या features होते हैं? ये important है. ये एक चीज है which has been asked as a bouncer once. तो इसमें क्या होता है? What you will see is, let me just draw it for you so that you can remember. Let's say this is your larynx, this is your tongue, this is your epiglottis, this is your arytenoids, and these are your vocal cords. So what are the features of TB? You will see single cord will become red. एक vocal cord red हो जाएगा. This is called as monocorditis. मतलब एक vocal cord will become inflamed. Second feature of TB is that the epiglottis will become edematous. ये बहुत बड़ी हो जाएगी. और अगर ये edema हो जाएगा epiglottis में, we call this particular sign as turban epiglottis. We call it as turban epiglottis. Turban की तरह बड़ी हो जाएगी. This is called as turban epiglottis. Monocorditis is the second feature. Right? Okay, now comes third, right? Third आती है that there will be interarytenoid mammillations. You can see that mammillation का मतलब होता है nodules. छोटे छोटे नोड्यूल निकल आते हैं interarytenoid एरिया में. देखो arytenoid के बीच में छोटे छोटे नोड्यूल निकल आए. This is called as interarytenoid mammillations. Okay, fine. अच्छा, अब और क्या दिखता है? नेक्स्ट चीज दिखेगी कि ऐसे लगेगा किसी ने वोकल कॉर्ड के ऊपर ना ऐसे ऐसे कोई एक चूहा आया एंड इट हैज बिटन. So this is called as mouse nibbled appearance. Mouse nibbled appearance. Somebody has come and ऐसे चबा के चला गया like a mouse. This is called as mouse nibbled appearance of vocal cords. ये सारे के सारे जितने फीचर हैं ये सारे के सारे टीबी में होते हैं. So you should remember about this area, like whatever I have told you about this diagram. Treatment ATT और कुछ नहीं, एंटी ट्यूबरकुलर ट्रीटमेंट. ठीक है, चलो आगे आते हैं. लैरेंजियल पैपिलोमास क्या होते हैं? तो लैरेंजियल पैपिलोमास अकर, पैपिलोमा का मतलब ही है ह्यूमन पैपिलोमा वायरस से होंगे, राइट? इट कैन अकर इन चिल्ड्रन, इट कैन अकर इन एडल्ट्स. अगर ये चिल्ड्रन में होते हैं देन वी कॉल इट एज जुवेनाइल ऑनसेट रिकरेंट रेस्पिरेटरी पैपिलोमाटोसिस. इसे हम लोग जॉर्प भी कहते हैं. अगर जुवेनाइल है मतलब बच्चों में हो रहा है, इट्स कॉल्ड एज जॉर्प. अगर अडल्ट्स में हो रहा है वी कॉल इट एज अडल्ट रेस्पिरेटरी पैपिलोमाटोसिस. एचपीवी के दो इंपॉर्टेंट स्ट्रेन्स होते हैं. एक होते हैं लो रिस्क, एक होते हैं हाई रिस्क. लो रिस्क का मतलब 6 and 11, मतलब जितने भी जेनाइटल वार्ड्स, ओरल वार्ड्स, पैपिलोमा, ये सारे बिनाइन लीजन्स होते हैं, ये 6 and 11 करते हैं. बट जितने हाई रिस्क स्ट्रेन्स हैं, राइट, हाई रिस्क मतलब मेलिग्नेंसी करने वाले, दे आर मोस्टली 16 and 18. 16 and 18 प्रोड्यूस हाई रिस्क. ठीक है, ये मेलिग्नेंसी कॉज करते हैं. ठीक है, अब What is the difference between an adult papilloma and a juvenile papilloma? Right? इसमें ज्यादा कुछ याद करने की जरूरत नहीं है. What I will suggest you, इसमें बस एक चीज याद करो कि जो जुवेनाइल होते हैं वो मल्टीपल होते हैं. अडल्ट जो होता है वो सिंगल होता है. मतलब अगर वोकल कॉर्ड्स हैं, राइट, और अगर आपने देखा कि किसी बच्चे के बहुत सारे छोटे छोटे पैपिलोमा बने हुए हैं, बहुत सारे बने हुए हैं, देन दैट इज जुवेनाइल रेस्पिरेटरी पैपिलोमाटोसिस. अगर कोई अडल्ट है तो उसके सिर्फ एक यहां पे ऐसा लीजन होगा, वेल डिफाइंड लीजन होगा, दैट इज एन अडल्ट पैपिलोमा. दैट इज व्हाई जुवेनाइल पैपिलोमास आर मोर अग्रेसिव, क्योंकि वो ज्यादा होते हैं, ज्यादा अजीब तरीके से फैलते हैं. बट अडल्ट पैपिलोमास आर लेस अग्रेसिव, राइट? अब जुवेनाइल है, सो व्हाट विल बी द कॉज ऑफ जुवेनाइल पैपिलोमा? दैट मींस मे बी द मदर हैड गॉट जेनाइटल वार्ड्स. And during the time of normal vaginal delivery, the baby caught that into the oral cavity, larynx and pharynx. उसके through वो transfer हो गया. So during vertical transmission and delivery, the patient actually caught this infection from the genital warts of the mother. But orogenital sexual contact is something which is most common in adults, which is causing adult papilloma to spread. Okay? I already told you that these are multiple, and that is why इनकी recurrence भी ज़्यादा होती है जब हम इनको excise कर देते हैं. Adults are single and they are less recurrent. The only problem is, अगर malignancy में बोले तो उल्टा है. Adult papillomas are more malignant. Juvenile papillomas are less malignant. That is the only difference between the two. ठीक है? चलो. So see this, how these papillomas look like. You can see that? This is how these papillomas will look like. So this is a single solitary papilloma. Okay, so this is something which you will see in mostly in adults. This is single which is consolidated. But अगर ये बच्चा होता है, it would have spread into this area, सब जगह फैला होता. Okay, how will you treat this? So again, mnemonic ABC. We can give an alpha interferon therapy. आजकल एक ड्रग आया है which is a monoclonal antibody which is called as bevacizumab, and cidofovir is an antiviral drug against HPV. So A, B, C. इसके अलावा वी हैव टू मेंटेन द एयरवे ऑफ द पेशेंट. या तो इंट्यूबेट करेंगे या ट्रेकियोस्टमी करेंगे, ट्रिक्योस्टमी वी अवॉइड इन केसेस ऑफ पैपिलोमास, क्योंकि अगर हमने गलती से ट्रिक्योस्टमी कर दी तो उस साइड से पैपिलोमा निकलने लगेंगे, वी माइट सीड द इन्फेक्शन टू सम अदर प्लेस, ठीक है। सो दैट इज समथिंग वी शुड अवॉइड, ओके। नेक्स्ट इज at the same time laser excision is very common. Laser excision is the one which we do in order to excise these lesions. कौन सी लेजर? CO2 लेजर। अब एक इंपॉर्टेंट चीज है, जब हम CO2 लेजर से इसको एक्सरसाइज करेंगे तो मेनी ऑफ द टाइम्स जो इनके फ्यूम्स निकलेंगे वो अगर सर्जन ने इनहेल कर लिए तो द सर्जन विल गेट द डिजीज। तो दैट इज वाई लेजर से जो निकलते हैं फ्यूम्स उनको हम बोलते हैं प्लूम्स, and we should be aware about it. तभी as surgeons we always wear a big mask against HPV, हम लोग goggles लगाते हैं, पूरी की पूरी sheets लगाते हैं अपने around so that we get we don't get the infection from the patient, ठीक है, क्योंकि ये fumes या plumes निकल के हमारे अंदर चले जाएंगे and that we will also be lying down at the non-surgical side. We will also get operated after some time. चलो आगे आते हैं. Now, congenital lesions of larynx. I'll quickly cover about what is laryngomalacia, what is subglottic stenosis. So, stridor हमें पता है क्या होता है? An abnormal sound that is created due to a turbulence in the upper airway या upper airway obstruction की वजह से कोई भी sound आता है which is turbulent is called as stridor. अब important चीजें आपको याद रखनी है, ठीक है? ऐसा सोचो कि किसी भी वजह से if there is a problem which has happened over in the supraglottic and glottic area, the patient will develop inspiratory stridor. Inspiratory का मतलब expiration normal, सिर्फ inspiration में। तो पहली zone of stridor क्या होती है? अगर supraglottis में कुछ है या अगर कोई vocal cord के level पे है, they will produce inspiratory stridor. If there is any problem which has happened in the subglottic area and cervical trachea, they will produce biphasic stridor. Biphasic का मतलब inspiration में भी sound, expiration में भी sound. मतलब क्यों? क्योंकि trachea भी closed है, subglottis is closed within the cricoid. That means every place is closed from all around. तो इसमें कोई जगह नहीं है. So that is why during expiration and inspiration both there will be sound, which is called as biphasic stridor. और अगर कोई भी चीजें इन द लोअर ट्रेकिया एंड ब्रोंकाई दे विल कॉज ओनली एक्सपिरेटरी नॉइज या एक्सपिरेटरी स्ट्राइडर, ठीक है। अब देखो, मोस्ट कॉमन कंजेनाइटल लीजन ऑफ द लैरिंग्स इज लैरिंगोमलेशिया. मोस्ट कॉमन रीजन फॉर कंजेनाइटल स्ट्राइडर इन चिल्ड्रन इज लैरिंगोमलेशिया. ये चीज दोनों याद रखनी है. तो मोस्ट कॉमन इंस्पिरेटरी स्ट्राइडर बच्चों में लैरिंगोमलेशिया की वजह से होता है. Most common congenital lesion of the larynx is also laryngomalacia. Okay? अब laryngomalacia समझने के लिए एक चीज ऐसे समझो. This is how laryngomalacia looks like. Laryngomalacia is just like that I am wearing an double XL shirt और मैं एक बहुत तूफान में खड़ा हुआ हूं. तो जब मैं तूफान में खड़ा हूंगा तो डबल एक्सएल की जो शर्ट है वो फटफट करेगी बिकॉज इट इज ओवर साइज. द सेम वे हैपेंस विद laryngomalacia. इन लैरिंगो मतलब लैरिंग्स, मलेशिया मतलब फ्लैसिडिटी, मतलब कार्टिलेज आर नॉट वेल फॉर्म्ड, दे आर फ्लैसिड. So it is just like an XL shirt. When the wind will go inside, they will collapse. So now all the cartilages will collapse inward. So this first thing is because of flaccidity of cartilages, and because everything will collapse inwards, the epiglottis will attain an omega shaped appearance, जिसे कहते हैं हम omega sign. That is the first feature. ठीक है. सेकेंड, अब इसमें दूसरी चीज क्या देख रहे हैं हम लोग? दूसरी चीज ये देख रहे हैं कि इसमें जो म्यूकोजा है कुछ ज्यादा ही है. जैसे मैंने शर्ट पहनी थी ना, उसमें शर्ट में बहुत बड़ी शर्ट थी, तो इसका जो म्यूकोजा है वो नॉर्मल से ज्यादा है. दैट मींस इफ देयर इज रिडंडेंट म्यूको, रिडंडेंट का मतलब एक्स्ट्रा म्यूकोजा, देन दैट म्यूकोजा आल्सो विल फॉल इनवर्ड्स. दैट इज आल्सो समथिंग व्हिच इज अ प्रॉब्लम. So two things we have learned: extra mucosa and flaccidity of cartilage that are causing this collapse of supraglottic structures inwards during inspiration. Third is that they have got neuromuscular incoordination. इनकी muscles weak हैं, तो तभी ये control नहीं कर पाते, and that is the reason why their airway falls inside. Okay? And fourth is short mucosal fold. Short मतलब ये देखो, ये arytenoid है, ये epiglottis है, they are attached by aryepiglottic folds, but they are very very short over here. They are extremely short. The short vocal folds, short aryepiglottic folds. So चार important चीजें why this happens: flaccidity of the cartilages, redundant extra mucosa because of neuromuscular incoordination, and short folds, and this produces an omega shaped appearance, right? अब अगर कोई भी लारिंगोमलेशिया का बच्चा आता है तो हम उसे ट्रीट कैसे करेंगे? कभी भी सर्जरी इसमें नहीं करनी होती। ओके, तो द फर्स्ट एंड फॉरमोस्ट फीचर इज कि इन बच्चों की हम कराते हैं प्रोनिंग। प्रोनिंग का मतलब क्या होता है कि बच्चे को उल्टा कर दो। अगर बच्चे को उल्टा कर दोगे तो उनकी एपिग्लॉटिस आगे आएगी, आगे आएगी तो अच्छे से सांस लेंगे। करेक्ट? ओके, तो दिस इज समथिंग, राइट? So that we do proning. Supine कभी नहीं लेटाना है. That's why breastfeeding also in the prone position. That is a maneuver what we do for laryngomalacia babies. And we wait and watch. अगर आपसे क्वेश्चन पूछा जाएगा आप क्या करेंगे? हम कुछ नहीं करेंगे. We wait and watch. Why? Because as the child grows till 2 to 4 years of age, the cartilage will become more and more dense. Right? सपना is saying all 19 subjects. Thank you सपना, thank you. ओके, बट अभी देखना, अभी बहुत मजा आएगा आप लोगों को मैराथन में. अभी तो इतने सारे टीचर्स की बची हुई है. एवरी टीचर हैज प्रिपेयर्ड वेरी वेल फॉर यू ऑल एंड यू नो वी हैव गॉट सो मच ऑफ डेटा दैट वी नीड टू गिव यू एज अ टीम. उन्होंने बहुत मेहनत करी इन बिहाइंड दैट एंड वी हैव गॉट लॉट ऑफ थिंग्स दैट हैव बीन पुट फॉरवर्ड फ्रॉम द टीचर्स साइड, फ्रॉम द कंटेंट क्रिएटर साइड, सो दैट वी कैन क्रिएट दिस काइंड ऑफ अमेलगमेशन फॉर यू, जिसमें आपका पूरा 19 सब्जेक्ट जल्दी जल्दी स्प्रिंट में खत्म हो जाए. ठीक है, दैट इज व्हाट द होल आइडिया इज ऑल अबाउट. ठीक है, चलो बस लगे रहना. आई वुड से डोंट गिव अप ऑन दिस टाइम. बस लगे रहना इस टाइम पे. खत्म करना, सुन सुन के खत्म कर दो, बस खत्म करो. दैट यू विल गेट सम काइंड ऑफ अ मेमोरी व्हेन यू सिट ऑन द पेपर. लाइक स्लमडॉग मिलियनेयर में हुआ था ना, कुछ सुना था मैंने, अब मैं कहीं कहीं कुछ कुछ याद कर लेता हूं. सो दैट इज व्हाट विल हैपन. ठीक है, चलो. सो प्रोनिंग, वेट एंड वॉच, ये हम करेंगे. बट इन केस लेट्स से द चाइल्ड हैज गॉट फेलियर टू थ्राइव. अब चाइल्ड अच्छा नहीं कर रहा है, राइट? और इफ द चाइल्ड इज हैविंग सैचुरेशन और SpO2 below 90%, then what will you do? The operation that you do for laryngomalacia is called as epiglottopexy and supraglottoplasty. अब ये बहुत सिंपल ऑपरेशन है, इसको ऐसे ही सोच लो. एपीग्लोटोपेक्सी एंड सुप्राग्लोटोप्लास्टी. एपीग्लोटोपेक्सी का मतलब है बार बार ये कर्ल हो रही है ना एपीग्लोटिस, तो व्हाट वी डू, वी सूचर दिस एपीग्लोटिस टू द बेस ऑफ टंग. यहाँ पे टंग है तो वी विल सूचर इट, हम उसमें एक सूचर लगा देंगे ताकि ये बार बार कर्ल ना हो और बार बार गिरे नहीं. दैट इज कॉल्ड एज एपीग्लोटोपेक्सी. पेक्सी मतलब जोड़ना. ठीक है. सुप्राग्लोटोप्लास्टी का मतलब क्या है? सुप्राग्लोटोप्लास्टी मींस दैट वी रिलीज दिस एरी एपिग्लोटिक फोल्ड. हम इसको काट देंगे थोड़ा सा. वी रिलीज दीज फोल्ड्स सो दैट द एपिग्लोटिस कैन गेट अ लिटिल अनकर्ल्ड एंड द पेशेंट कैन ब्रीथ बेटर. ठीक है, दिस इज व्हाट इज सुप्राग्लोटोप्लास्टी एंड एपिग्लोटोपेक्सी. चलो आगे चलते हैं. नाउ वी कम टू सबग्लॉटिक स्टेनोसिस. ठीक है, सबग्लॉटिस का मतलब क्या हुआ कि लेट्स से दिस इज योर क्रिकॉइड कार्टिलेज. क्रिकॉइड कार्टिलेज के नीचे दिस इज योर ट्रेकिया. द स्पेस प्रेजेंट विद इन द क्रिकॉइड इज कॉल्ड एज सबग्लॉटिस. इसके अंदर के स्पेस को हम लोग बोलते हैं सबग्लॉटिस. ठीक है, अब अगर इस सबग्लॉटिक एरिया का डायमीटर लेस देन 4 mm हो गया इन फुल टर्म न्यूनेट, बिकॉज आई एम टॉकिंग अबाउट चिल्ड्रन हियर, और इफ इट इज लेस देन 3 mm इन प्री टर्म न्यूनेट, यानी कि ये बहुत छोटा हो गया, दिस इज बिकम वेरी वेरी स्मॉल, लेस देन 4 in a full term, less than 3 in a preterm, then we will call this particular thing as subglottic stenosis or narrowing. Okay, right? Now, अब ऐसे सोचो, I told you, कोई भी पैथोलॉजी अगर होगी सबग्लॉटिस पे या सर्वाइकल ट्रेकिया पे, मतलब यहां पे या यहां पे, they will produce what? They will produce biphasic stridor. मतलब दोनों साइड, अंदर भी बाहर भी, they will be stridor. So the most common cause of biphasic stridor in children is subglottic stenosis. Very important. ठीक है, अब दो टाइप की सबग्लॉटिक स्टेनोसिस के क्वेश्चंस आते हैं. एक टाइप की स्टेनोसिस होती है बचपन से है, कंजेनाइटल. कंजेनाइटल का मतलब क्या है कि क्रिकॉइड जो है अब छोटी बन गई. लेट्स से क्रिकॉइड इज वेरी वेरी स्मॉल. इफ द क्रिकॉइड इज स्मॉल, इवन द सबग्लॉटिक एरिया विल बी स्मॉल. So this is usually seen in syndromic children. जितने सिंड्रोम नॉर्मली आते हैं वो सब बता दो. डाउन सिंड्रोम, ट्रीचर कॉलम सिंड्रोम, पियर रॉबिन सिंड्रोम, पैलेस्टर हॉल सिंड्रोम, चार्ट सिंड्रोम, सारे बड़े बड़े सिंड्रोम्स में ये चीज दिखेगी, स्मॉल क्रिकॉइड दिखेगी, राइट? बट व्हाट इज अक्वायर्ड? अक्वायर्ड में आपको एक क्वेश्चन अक्वायर्ड से आएगा. अक्वायर्ड में क्या पूछेंगे? दैट द पेशेंट हैज गॉट रिपीटेड हिस्ट्री ऑफ इंट्यूबेशन, और अब पेशेंट के बाइफेजिक स्ट्राइडर है. तो अगर किसी के इंट्यूबेट हम लोग करते हैं तो उसके ट्रेकिया में भी सेंड द ट्यूब, राइट? We send the endotracheal tube into the trachea. अगर हम बार बार उसके intubation कर रहे हैं, they will cause friction, they will cause injury in the subglottic mucosa, and that will heal with the formation of fibrous tissue. So if it heals with the formation of fibrous tissue, this area will start getting smaller and smaller, and that is what is called as subglottic stenosis. तो मोस्ट कॉमन कॉज ऑफ सबग्लॉटिक स्टेनोसिस इज inacquired is repeated intubations. ठीक है, right? So all ENT questions in recent GT came from marathon class. Very good. सारे आ गए ना, सारे कवर हो गए, बस ये तभी मैंने बोला सब कुछ आ जाएगा. GT नहीं, पूरा नीट फंसेगा. You will get everything. Okay? चलो अब आते हैं नेक्स्ट पे. इसको ग्रेड कैसे करेंगे? ग्रेडिंग करेंगे हम लोग कॉटन मायर ग्रेडिंग से. कॉटन मायर इज द ग्रेडिंग सिस्टम. ठीक है, तो अब ये देखो, ये वोकल कॉर्ड है. वोकल कॉर्ड के नीचे ये देखो छोटी सी एरिया बन गई. वाई? बिकॉज एवरीथिंग इज स्टेनोस्ड. ठीक है, कॉटन मायर की ग्रेडिंग क्या है? इफ दिस स्टेनोसिस सेगमेंट, अगर ये सेगमेंट ऑफ स्टेनोसिस is 0 to 50%, then we call it grade 1. If it is 51 to 70, we call it grade 2. If it is 71 to 99, we call it grade 3. और अगर कंप्लीटली कुछ नहीं दिख रहा है, then it is grade 4, मतलब कंप्लीट ऑब्स्ट्रक्शन. दिस इज कॉल्ड एज कॉटन मायर ग्रेडिंग. ठीक है, अब यहीं पे हम इसका ट्रीटमेंट भी देख लेते हैं. इन केस अगर ग्रेड 1 या ग्रेड 2 स्टेनोसिस है तो हम क्या करते हैं? ग्रेड 1 या ग्रेड 2 स्टेनोसिस में वी टेक अ लेजर एंड वी कट ओपन इन 4 डायरेक्शंस लाइक दिस, जिसे हम कहते हैं क्रूशिएट इंसिजन. लाइक अ क्रूशिएट मतलब 4 डायरेक्शन में लेजर से हम इंसाइज कर देंगे. नाउ व्हाट विल हैपन, अगर हमने इसे एक्साइज किया then obviously this is released, but we need to do something to expand it. So now what we'll do, we will put a balloon and we will dilate it. हम इसमें balloon dilation करेंगे after giving an incision. So what will be the choice of treatment in stage 1 and stage 2 stenosis? It will be laser excision plus serial balloon dilation. Serial balloon dilation. This will be the thing that we will do in grade 1 or grade 2 stenosis. Okay? Right? Now at the same time यहां पे एक और ड्रग हम यूज कर सकते हैं, which I've already told you in corneal atresia, that is application of mitomycin C. यहां पे हम लोग mitomycin C लगा के रखेंगे. Why? Because it does not refibrose. That has got a role here. Okay? If it is stage 3 or 4, मतलब अब आगे आ गया, अब इससे काम नहीं बनेगा. अब हम क्या करेंगे? Let's say ये क्रिकॉइड है, इसके अंदर ये स्टेनोसिस हो रखी है. This is your cervical trachea, right? And इसके ऊपर होती है हमारी thyroid cartilage, right? So what we will do, we will excise out the complete cricoid और बचे कुचे ट्रेकिया को we will anastomose with our thyroid cartilage. This is called as cricotracheal resection and anastomosis. मतलब मैंने cricoid cartilage हटा दी, ट्रेकिया का थोड़ा पार्ट हटा दिया, और बचे कुचे ट्रेकिया को I sutured it with the remaining thyroid cartilage. That's called as cricotracheal resection and anastomosis. This is the treatment what we give in cases of subglottic stenosis. ठीक है, चलो आगे बढ़ते हैं. Okay, this I have already told you. Okay, so I am going forward now. अब आते हैं laryngocele पे. ठीक है, laryngocele क्या होता है? So what is a laryngocele? Okay, so let's just quickly recap कि laryngocele होता क्या है. So if I cut open my larynx in this direction, अगर मैं coronal section में अपने larynx को काटूं, तो my larynx will somewhat look like this. अगर मैं अपने larynx को काटता हूं, so it will somewhat look like this. Okay, so what have I made if I cut the larynx? We have got, this is a coronal section of larynx. There is false vocal cord above, true vocal cord below. अब एक important चीज होती है, the space present between the false vocal cord above and true vocal cord below is called as, it is called as laryngeal ventricle. Ventricle क्या होती है? Ventricle is the space present between false vocal cord above and true vocal cord below. This is called as laryngeal ventricle. Ventricle gets dilated laterally into a small pouch or a small page. And this small pouch or space, which is a dilation of the ventricle laterally, इसे हम कहते हैं laryngeal saccule. Saccule के अंदर होते हैं बहुत सारे serous mucinous glands. अंदर बहुत सारे glands होते हैं. अब ये क्या काम करता है? These mucus glands will create mucus and they will keep lubricating the true and false vocal cords. That is why saccule is also called as oil can of larynx. ये बड़ा important question है. That's called as oil can of larynx, right? तो ventricle का ही extension saccule होता है, right? Now, very important. If in case कोई एक ऐसा आदमी आया जो trumpet player है, या एक ऐसा आदमी जो ग्लास ब्लोअर है, जो ग्लास में ब्लो करते हैं, राइट? और देयर द ट्रम्पेट प्लेयर्स, तो वो क्या करते हैं? वो अपने ग्लॉटिस में बहुत प्रेशर लगाते हैं. दे क्रिएट अ लॉट ऑफ प्रेशर ओवर द ग्लॉटिस, राइट? सो अगर आपने बहुत ट्रेन किया, बहुत ज्यादा ट्रम्पेट बजाया, So there's a lot of increase in the transglottic pressure. If there is a high amount of transglottic pressure, आपने बहुत यहाँ पे pressure लगा दिया, increase transglottic pressure, तो होगा क्या? Accidentally the air will now go and trap into the saccule, and this saccule might get abnormally dilated with a air-filled swelling. तो अब ये saccule air से भर गया and it has abnormally become enlarged. और ये saccule अगर abnormally enlarge होके बाहर आ गया, it is called as laryngocele. तभी this is something which is seen in cases with trumpet players, glass blowers या weight lifters जो strain करते हैं, right? So I think doctor is already telling that 2024 में question आया था in laryngeal, इसमें strain use करना था, so basically this is what is all about, right? Now I told you इसमें आपको एक option क्या देंगे? तो it is abnormal dilation of saccule, ये हमें समझ में आ गया जिसमें air भरी है. एक ऑप्शन ये देंगे कि when the patient does Valsalva maneuver, मतलब नाक बंद करता है, मुंह बंद करता है, दम लगाता है, this swelling enlarges. Why? Because it has got straight connection with the larynx. So this swelling will increase on Valsalva maneuver. Always remember, this will increase on Valsalva maneuver. अब मैंने आपको बताया था Boy's sign was positive in cases of pharyngeal pouch. Bryce sign भी वैसे ही होता है. Bryce sign मतलब अगर मैं बाहर वाली swelling पे प्रेस करूं, so it will produce a hissing sound. तो RY आता है ना, तो Bryce और laryngo में दोनों में RY आता है. So Bryce is in laryngocele, Boyce is seen in pharyngeal pouch, which is a sound which is produced when the swelling is compressed. How do we manage? In small laryngoceles we don't do anything, we just marsupialize. इसको हम खोल के रख देते हैं ऐसे कॉपी की तरह. This is called as marsupialization. In large laryngoceles we excise out by a transcervical approach. Cervical incision देके excise out the complete thing. That's called as transcervical approach. ठीक है, fine. चलो, so this finishes laryngocele. तो हाँ, now let's come to benign vocal cord disorders. ये आपका बड़ा इंपॉर्टेंट क्वेश्चन आता है. तो दो इंपॉर्टेंट आपको मैंने यहाँ पे डिसऑर्डर्स दे रखे हैं, राइट? On one side is what? On one side you can see this is your vocal cord. These are your true vocal cords, right? And at the junction of the anterior 1/3 and mid 1/3 of the cord. So that means at the junction of anterior 1/3 and mid 1/3 of the cord, you see in both the cases, दोनों के cases में anterior 1/3 and mid 1/3 पे कोई ना कोई problem है, right? Now what is wrong here? This is about a chronic voice abuser. That means this, let's say this particular patient is a singer or a teacher. So they will tell you this is a singer or a teacher, chronic voice abuser. When the vocal cords adduct, the maximum friction that happens during adduction happens at the junction of anterior 1/3 and mid 1/3 of the cord. तो अगर कोई टीचर है, जैसे मैं हूँ, पढ़ाई जा रहा हूँ, अभी 5 घंटे होने वाले हैं, आई थिंक इट्स 5 hours plus, okay, almost 5 hours. So this is something which is very common in me. It could happen, okay, because if you have voice abuse, this is the junction which is keeping on hitting. और क्या होगा? There will be bilateral sessile swelling. Sessile का मतलब होता है flat based. This flat based, okay. So bilateral, they will be always bilateral. They will be flat and they will be sessile. They will be anterior and mid 1/3 junction. Okay, and they will be less than 3 millimeters and symmetrical. 3 millimeters and symmetrical. This is a classical case of vocal nodule. Chronic voice abuse, bilateral, symmetrical, flat, sessile. These will be the candidates for vocal nodule. Supravital stain इसमें नहीं हम लोगों को काम आता है. That generally works in pre-malignant versus malignant lesions. This is something which is benign, which is very well seen as it is. ठीक है? अब आते हैं नेक्स्ट थिंग इधर. अब ये एक ऐसा आदमी आया, लेट्स से ये गया स्टेडियम में और इसने सडनली चिल्ला दिया, आरसीबी जीत गई, सडनली चिल्लाने लगा. तो अब चिल्लाने लगा तो सडनली इसके एक वॉइस चेंज आया. तो इफ देयर इज सडन वॉइस अब्यूज, then it will cause hemorrhage in the vocal cord, and that hemorrhage in the vocal cord will produce a pedunculated lesion. ये flat नहीं है, this is pedunculated, occurring at the junction of anterior and mid 1/3 of the cord. But this is sudden, pedunculated, it is reddish, it is unilateral most commonly. This was bilateral, and this is more than 3 millimeters. This was less than 3 millimeters. Here the answer will become vocal polyp. Here answer is vocal polyp. Vocal nodule, what is the management that you do? It is always medical. All medical line of management is done in vocal nodule, which is proton pump inhibitor, give mucolytics, give antihistamines, and tell the patient absolute voice rest. This is the treatment that we give in medical line of management in vocal nodule, क्योंकि the moment we use any surgical, हमने surgery करी, it will lead to more scarring, more voice changes. But in the other case, यहाँ पे polyp के case में medical line of management doesn't work, क्योंकि polyp अगर हमने नहीं निकाला तो ये बड़ा होते होते खुद टूट जाएगा. This is called as auto amputation. If it accidentally breaks, it can get aspirated. So that is why the first line of management here is a microlaryngoscopy plus excision. That is the first thing that we do in a polyp, not in a nodule. Remember that. Nodule, medical, this is surgical. Right? Chronic versus sudden voice abuse. Okay? These are the two questions that are related to your exams. अब आते हैं third vocal pathology या third vocal disorder पे, which is Rinke's edema. Rinke's edema, they will always give you a history of a smoker, because this is something which occurs due to smoking. So it is a chronic irreversible swelling of the vocal cords. So you can see this is a full length of the vocal cord is swollen. This is a chronic irreversible swelling of the vocal cords. पानी भर जाता है, right? Now when I take out the vocal cord and show you, so the vocal cords have an epithelium. इनकी बाहर एक epithelium होती है. Epithelium के नीचे vocal cords में एक layer होती है जिसका नाम होता है superficial lamina propria. Superficial lamina propria के नीचे एक layer होती है जिसे कहते हैं intermediate lamina propria. Intermediate lamina propria के फिर एक नीचे layer होती है which is called as deep lamina propria. And deep lamina propria के नीचे होती है एक muscle which is called as vocalis muscle. This is what are the layers of vocal cord. अगर मैं छोटा सा piece निकाल के यहाँ पे दिखाऊं, these are the 5 layers which are present in our vocal cords. Okay, fine. तो ये 5 layer हैं. The intermediate lamina propria and deep lamina propria together are called as vocal ligament. This is called as vocal ligament. The other name of superficial lamina propria is called as Rinke's space. Very important. Okay. Now this Rinke's space contains a lot of blood vessels. यहाँ पे बहुत सारी blood vessels होती हैं. अब अगर कोई smoke कर रहा है, तो chronically ये blood vessels inflame हो रही हैं. And because they keep getting inflamed, ये क्या करती हैं? They become fragile. ये टूटने लगती हैं. और अगर ये टूटने लगती हैं, तो there will be production of a lot of transudate या fluid, जो इकट्ठा हो जाएगा between the epithelium and the superficial lamina propria. The other name for superficial lamina propria is also called as Rinke's space. तभी इस पूरे एडिमा का नाम होता है Rinke's edema. अब क्योंकि ये फ्रेडरिक बर्थोल्ड रिंकी ने ढूंढा था, इसलिए इसका नाम Rinke's edema पड़ गया. Okay, so this is what is all about in Rinke's edema. That is why they'll always be in smokers. That is why it is also called as smoker's larynx or a pseudomyxomatous laryngitis, because there is a kind of a jelly-like substance which tries to accumulate in the superficial lamina propria. Okay, now this is very common in females. This happens more in females than in males. That is why classically आपको question आएगा कि female की voice male जैसी है in cases of females on the telephone. So on the telephone, the female actually talks like a man, right? That is what is a classical thing that you will get, right? So this is something which will lead to deepening of voice, क्योंकि vocal cord भारी हो चुके हैं. If it becomes very big, then they will also lead to chronic cough and stridor, क्योंकि ये बहुत बड़े हो गए. So it will lead to chronic cough, होने लगेगा, कुछ निकाले बार बार, and they will also lead to stridor. The appearance of this swelling that is present over the vocal cord, इसे हम कहते हैं bag of water appearance. It is also called as bag of water appearance. Okay. Now how to treat it? The first treatment of Rinke's edema is avoid smoking. Smoking बंद कर दो, right? And we give the same line of medical management जो हमने वहाँ पे दिया था in vocal nodule, right? But surgery इसके केस में जरूरी है. So what do? We give incisions over the length of the vocal cord and we suck out all the fluid that is present in the Rinke's space. तो हम क्या कर रहे हैं? We are doing a procedure called as reduction glottoplasty. Reduction मतलब हम glotto मतलब vocal cords, plasty मतलब repair, reduction मतलब we are taking out all the edema. We are putting incisions, we are sucking out all the edema, and so that we can get a uniform cord. Okay, that's called as reduction glottoplasty. That is the surgery that we could do for Rinke's edema. This finishes about 3 important vocal disorders, right? अब in case गलती से आपके पास एक क्वेश्चन आ जाता है, right, regarding intubation. तो इंट्यूबेशन में सिर्फ 2 ही क्वेश्चंस आते हैं, या तो सबग्लॉटिक स्टेनोसिस है. अगर वो बोले बाइफेजिक स्ट्राइडर है इंट्यूबेशन से रिलेटेड, द आंसर इज सबग्लॉटिक स्टेनोसिस. बट अगर उन्होंने बोला कि होर्सनेस ऑफ वॉइस है रिलेटेड टू इंट्यूबेशन, तो आंसर है इंट्यूबेशन ग्रैन्युलोमा. अब ये क्या होता है? लेट्स से दीज आर योर वोकल कॉर्ड्स, राइट? दीज आर योर वोकल कॉर्ड्स. द पोस्टीरियर पार्ट ऑफ द वोकल कॉर्ड is made up of vocal process of the arytenoid. and this is also called as cartilaginous glottis. Cartilaginous glottis क्यों? क्योंकि this constitutes the vocal process of arytenoid cartilage. Anterior 2/3 of the vocal cord is membranous, posterior 1/3 is cartilaginous. ठीक है. अब अगर कोई इंट्यूबेशन करता है तो ये इंट्यूबेशन का ट्यूब जब अंदर जाता है तो accidentally causes an injury over the arytenoid vocal process, and that can lead to granulation tissue formation. So if you see any kind of a lesion present over on the posterior 1/3 of a single vocal cord, एक vocal cord पे posterior 1/3 में अगर आपने कोई lesion देखा और अगर उसमें intubation की history है, the answer would be arytenoid granuloma या intubation granuloma. Okay, because happens because of constant trauma, because of endotracheal intubation, right? Now, how do we treat it? The treatment here is microlaryngoscopy and excision, obviously, क्योंकि हमें निकालना पड़ेगा if there is hoarseness, and we can also give a short course of steroid for the granulation tissue to shrink. That's all. ठीक है, that's all related to intubation granuloma. आगे बढ़ते हैं. चलो, अब मुझे क्वेश्चन पूछा गया था अबाउट vocal cord palsy, right? अब यहाँ पे मैं आपके सारे vocal cord palsy के डर हटाता हूँ. And I'll try to make you understand, make you figure out ये सारे क्वेश्चन के आंसर कैसे करने हैं और क्या करने हैं. तो अभी के लिए हम सब भूल जाते हैं कि क्या है. Let me just put up a new slide and just teach you over one diagram कि हमें करना क्या है. Vocal cord के आंसर्स कैसे करने हैं. Okay. So let's say vocal cord में अब क्या पढ़ना है. This is what I'm going to teach you right now. ठीक है. So let's say this is my larynx. Okay, let's make up the larynx. Okay, this is my tongue, this is my epiglottis, these are the arytenoids. Okay, these are the arytenoids. Okay, and these are my vocal cords. Vocal cord के दो movement है, one is adduction, one is abduction. Okay, these are the two movements. During speech we adduct, during breathing we abduct. Okay, now there are two nerves which are supplying our vocal cords that we need to remember. One is our recurrent laryngeal nerve, which is a branch of vagus nerve. Recurrent laryngeal nerve supplies all intrinsic muscles of larynx. सारी की सारी muscles, abductor, adductor, सारी की सारी, they are all by this particular RLN or recurrent laryngeal nerve, except for one muscle. कौन सी होती है वो? Cricothyroid. Cricothyroid is the only muscle which is supplied by superior laryngeal nerve. The external branch of superior laryngeal nerve. नहीं, posterior cricoarytenoid नहीं, cricothyroid muscle. External branch of superior laryngeal nerve supplies only cricothyroid muscle, nothing else. बाकी सारी की सारी are supplied by RLN, all intrinsic muscles. ठीक है, right? Okay. हाँ, तभी मेरी लास्ट में क्लास हमेशा लगती है, because I am a slow teacher, I am a slow explainer, plus बहुत सारी चीजें बताने को होती हैं. So that is why Arshit, correct. Okay. तो RLN हो गया, SLN हो गया, and that is what cricothyroid is all about. ठीक है. अब cricothyroid का फंक्शन क्या होता है? It is tension and keeping the vocal cord adducted. Adduction and tension are two important things. Tension का मतलब इसीलिए इसको सिंगर्स मसल भी कहते हैं. इसको हम लोग सिंगर्स मसल भी कहते हैं, क्योंकि जब हम रबर बैंड की तरह अपने रबर बैंड को खींच देते हैं, वोकल कॉर्ड भी रबर बैंड की तरह है, उसको खींचेंगे, राइट? तो अगर हम उसको खींचेंगे, सो इट विल इंक्रीज इन पिच. That is why it is also called as singer's muscle, right? Tension and adduction. Janil is saying, please drink some water. Thank you, Janil. Okay, I will have some water. I will have some water after vocal palsy. Okay, ठीक है. तो इसे हम लोग singer's muscle भी कहते हैं. एक abductor होता है. The only abductor of vocal cord is posterior cricoarytenoid muscle. तभी इसे हम safety muscle of larynx भी कहते हैं. यानी एक ही मसल है जो हमारे वोकल कॉर्ड्स को दूर लेके जा रही है, एबडक्ट कर रही है. एक ही एबडक्टर है, दैट इज पोस्टीरियर क्रिकोएरिटेनॉइड. एंड वी आल्सो नो कि ये इसको कौन सप्लाई करेगा? इट विल बी रिकरेंट लैरिंजियल, क्योंकि रिकरेंट लैरिंजियल सारे इंट्रिंसिक मसल्स को सप्लाई करती है. दिस इज आल्सो एन इंट्रिंसिक मसल. तो एबडक्शन इज कंप्लीटली डिपेंडेंट ऑन आरएलएन ओनली. दैट आल्सो वी अंडरस्टूड, राइट? ओके. और एडक्शन करने के लिए ऑल भी मसल्स हैं, बट वन ऑफ द मसल्स इज क्रिकोथायरॉइड. ठीक है. दिस इज व्हाट वी हैव अंडरस्टूड अबाउट नर्व सप्लाई ऑफ लैरिंक्स. जो इंपॉर्टेंट क्वेश्चंस आते हैं. अब हम लोग आते हैं वोकल पैल्सी में. वोकल पैल्सी में वी नीड टू रिमेंबर वन इंपॉर्टेंट लॉ विच इज कॉल्ड एज वेगनर्स ग्रॉसमैन हाइपोथेसिस. एक ही हाइपोथेसिस है जो हमें याद रखनी है. ये सबसे इंपॉर्टेंट रूल है. वेगनर ग्रॉसमैन हाइपोथेसिस ये कहती है दैट इफ सपोज अ पेशेंट हैज गॉट आरएलएन इंजरी, अगर किसी के यूनिलैटरल आरएलएन इंजरी हो गई, तो द वोकल कॉर्ड विल अटेन अ पैरामीडियन पोजिशन बिकॉज ऑफ द अनअपोज्ड पुल ऑफ द क्रिकोथायरॉइड मसल। इसका क्या मतलब है? इसका मतलब यह है कि अगर किसी की आरएलएन इंजर हो गई तो कोई भी एडक्टर कोई भी एबडक्टर काम नहीं करेगा एक्सेप्ट फॉर क्रिकोथायरॉइड, बिकॉज क्रिकोथायरॉइड इज सप्लाइड बाय सुपीरियर लैरिंजियल नर्व दैट इज नॉट इंजर्ड. So now the vocal cord, if there is recurrent laryngeal nerve palsy, then that paralyzed cord, because of the unopposed action of cricothyroid muscle, क्योंकि वो अभी भी काम कर रही है, the paralyzed cord will now attain a position which is called as paramedian position. Paramedian का मतलब now the paralyzed vocal cord will attain a position 1.5 millimeters away from the midline. अब मेरा vocal cord ये जो है बस ऐसे ही खड़ा रहेगा. This is going to be just like this. 1.5 millimeters away from the midline. ना ये एबडक्ट करेगा ना ये एडक्ट करेगा, बस ये टेंशन में रहेगा. Why? Because cricothyroid is still functional. This is what Wegener-Grossman hypothesis states. If there is recurrent laryngeal nerve palsy, there is still action going on in the cricothyroid muscle which attains this vocal cord into a paramedian position. And the opposite cord is still functioning. मतलब opposite cord abduct करेगा, opposite cord adduct भी करेगा. तो अब हम लोग दो इंपॉर्टेंट चीजें सिनारियो यहीं पे देख लेते हैं. दो इंपॉर्टेंट सिनारियो है. लेट्स टेक व्हाट इज गोइंग टू हैपन इन यूनिलैटरल एंड बायलैटरल आरएलएन पैल्सी. एंड व्हेनेवर वी रीड पैल्सी, राइट, हम तीन सिम्टम्स के हिसाब से पैल्सी पढ़ते हैं. SAR, स्पीच, एस्पिरेशन, रेस्पिरेशन. इन्हीं के तीन के बेसिस पे वी विल अंडरस्टैंड कि पूरी पैल्सी में क्या हो रहा है. नाउ अंडरस्टैंड दिस. अगर किसी के रिकरेंट लैरेंजियल एक साइड की इंजर हो गई तो वन कॉर्ड विल बी इन पैरामीडियन पोजिशन, ये मूव नहीं करेगा. दूसरा कॉर्ड abduction करेगा ड्यूरिंग ब्रीदिंग, एडक्शन करेगा ड्यूरिंग स्पीकिंग, ये मूव करता रहेगा. तो व्हाट विल बी द प्रॉब्लम इन स्पीच? स्पीच में ज्यादा प्रॉब्लम तो होगी नहीं, बिकॉज ऑपोजिट कॉर्ड इज गोइंग टू कॉम्पनसेट. वो वापस भी तो आ रहा है और दूर भी जा रहा है. विल द पेशेंट एस्पिरेट? नहीं करेगा क्योंकि वोकल कॉर्ड इज क्लोजिंग. विल द पेशेंट हैव एनी प्रॉब्लम इन रेस्पिरेशन? नहीं, बिकॉज द ऑपोजिट साइड वोकल कॉर्ड इज स्टिल फंक्शनल. So in cases of unilateral RLN palsy, there will be nothing. You might find mild hoarseness, but actually everything is normal, and that is why in unilateral RLN palsy we usually give conservative management. That is voice rest. तो अपने आप ठीक हो जाएगी. अब this is the first thing. अब देखो second scenario क्या है. किसी के bilateral RLN injury हो गई. What is the most common cause for bilateral RLN injury? Thyroidectomy. Thyroidectomy is the leading cause for bilateral RLN injury. तो अब क्या हुआ? नाउ बायलैटरल आरएलएन हैज इंजर्ड. तो ऑब्वियसली आई टोल्ड यू बोथ स्टिल द क्रिकोथायरॉइड मसल इज फंक्शनल. नाउ माय बोथ वोकल कॉर्ड्स विल कम इन द मिड लाइन एंड दे विल स्टे इन दिस वे ओनली. दे विल नॉट एबडक्ट, नाइदर दे विल एडक्ट. वो ऐसे ही रहेंगे. नाउ दिस इज समथिंग बैड. इसमें स्पीच में कोई प्रॉब्लम आएगी? नहीं, बिकॉज बोथ ऑफ देम आर क्लोज टू ईच अदर, राइट? दे आर बोथ क्लोज टू ईच अदर, सो स्पीच विल बी नॉर्मल. एस्पिरेट भी नहीं करेगा बिकॉज फॉर एस्पिरेशन द वोकल कॉर्ड शुड बी अवे. एस्पिरेशन भी नहीं करेगा. बट व्हाट विल बी द प्रॉब्लम? द रेस्पिरेशन विल बी एन इशू. दीज पीपल विल एंड अप इनटू स्ट्राइडर. इसमें स्ट्राइडर विल बी प्रेजेंट. व्हाई? बिकॉज बोथ द थिंग्स हैव कम टुगेदर. तो नाउ अब इसके केस में आप क्या ठीक करोगे, क्या करोगे? सो व्हाट वी डू, वी कैन डू लैटरलाइजेशन ऑफ द कॉर्ड. हम इसको लैटरलाइज करेंगे. अब लैटरलाइजेशन थायरोप्लास्टी कौन से टाइप की होती है? तो याद रखो, टाइप 4 तरीके की थायरोप्लास्टी होती है. 1 2 3 4. हम what do we do in larynx? Microlaryngal surgery, right? MLS. So medialization thyroplasty is type 1, lateralization thyroplasty is type 2, shortening of the vocal cord is type 3, lengthening of the vocal cord is type 4. This is what, right? So this is type 2 thyroplasty, which is lateralization of the cords. ठीक है? Okay. Second हम क्या करेंगे? Second what we do, हमें स्पेस बनाने के लिए वी विल एक्साइज आउट द पोस्टीरियर 1/3 ऑफ द कॉर्ड. हम इतना एक्साइज कर लेंगे. पोस्टीरियर 1/3 ऑफ द कॉर्ड इफ इट इज एक्साइज्ड, देन वी विल कॉल दैट प्रोसीजर एज काशिमा प्रोसीजर. दैट इज द सेकेंड वे इन विच वी क्रिएट स्पेस. दैट इज कॉल्ड एज काशिमा प्रोसीजर. ओके, फाइन, राइट. अब ये हो गए हमारे दो सिनारियो खत्म. अब देखो तीसरा सिनारियो क्या है. तीसरा सिनारियो ये है कि अब एसएलएन प्लस आरएलएन इंजरी हो गई. मतलब आरएलएन एसएलएन दोनों इंजर हो गए. मतलब या तो अब ना तो एबडक्टर काम कर रही है ना एडक्टर काम कर रही है. कुछ नहीं काम कर रहा है, राइट? कुछ भी काम नहीं कर रहा. नाउ रिमेंबर वन थिंग, देयर आर 3 कंडीशंस इन विच योर वोकल कॉर्ड्स विल अटेन अ इंटरमीडिएट पोजीशन. इंटरमीडिएट का मतलब होता है देयर इज कैडेवरिक पोजीशन, राइट? So there is cadaveric position that will attain. Now what do you understand by cadaveric position? Cadaveric position is a position where the vocal cords are 3.5 millimeters away from the midline. That means now the vocal cords will be just lying 3.5 millimeters away from the midline. Neither they will adduct nor they will abduct. Kuch nahi hoga. Now they will be just 3.5 millimeters away from the midline. Like this. They will not move in, they will not move out. Right? Okay? Fine. So if they will not move in, they will not move out, they will be in cadaveric position. This is called as intermediate position or cadaveric position. Okay? They are 3.5 millimeters away from the midline. There are only 3 conditions where a cadaveric position is obtained. 1. SLN plus RLN both are injured. 2nd, the patient is under general anesthesia. 3rd, the patient is dead. Either you get complete vagal nerve injury, if the patient is dead, post-mortem, or if there is any kind of, patient is under general anesthesia. These are the only 2 things in which you see this cadaveric position. Now you think of, if there is bilateral RLN plus SLN injury, these vocal cords will be just like this. One will be like this, one will be like this. What will you do in such cases? The patient will have no sound at all. There will be aphonia. The patient will aspirate, but there will be no problem with respiration. So now what will you do? Is this larynx any more functional? If there is bilateral RLN and SLN injury, can you do anything? If you get these cords closer, then there will be stridor. If you take them away, then the patient will aspirate. Now you can't do anything. So in cases of bilateral SLN plus RLN injury, where both the vocal cords have attained a cadaveric position, the larynx is not functional at all. In such cases, what do? We do a procedure called as tracheoesophageal diversion. Tracheoesophageal diversion means kya hai? That let's say this is your trachea, right? This is your trachea, and this is the esophagus behind, okay? And this on top is your larynx. Okay? This outside is the skin. So what do? Your larynx is not functional, so you cut open the upper part of trachea, okay? And what do is that you suture the larynx and the trachea to the esophagus, and the lower part is sutured to the skin. So what have you done? The upper part of the trachea is sutured directly to the esophagus, and the lower trachea has been opened through the skin. This is called tracheoesophageal diversion, so that the patient can breathe through the stoma, and the upper part has been sutured to the esophagus, and that is nothing, that is just for all the food to go inside into the esophagus. This is done, that is the thing what we do in cases of bilateral RLN plus SLN injury. Okay? So partial RLN palsy is not there, that's called as paresis. Partial matlab paresis hoti hai. Complete palsy hoti hai, that partial is paresis of the cord. Paresis usually comes out on its own, like it improves with time. Okay, we give high dose methylcobalamin, which is a nerve toner, but usually it comes with time. Okay, Kashima is posterior 1/3 of the vocal cord is excised. Posterior 1/3 of the vocal cord is excised to create space, that is called as Kashima's procedure. Okay, so in your workbooks, I have actually given you this table, which actually tells up everything. The position, aspiration, respiration, speech. I'm not going into everything right now, because that is again going to take a lot of time. I've just given you that kind of concept how to approach these questions, right? So this is something that you can just recap once. Don't worry about the SLN here. SLN chhod do. That don't remember. Don't worry about them. But just remember bilateral and unilateral RLN, what you will do, and what will you do in cases of bilateral complete and unilateral complete. Okay, fine. Only PCA cannot be damaged. RLN supplies not only PCA but a lot of things, right? So RLN is something supplying everything. So sirf PCA nahi injure ho sakti alone. Okay. This is the same mnemonic I told you. So this I've already told you. What are the types of thyroplasty? MLS, the important mnemonic. Okay. Chalo. Ab jaate hain into laryngeal malignancy, which is the last part of today's lecture. Okay. So this is something that is my last feature for today. Laryngeal malignancy. Ab iski staging important hai. I'll tell you how to stage that and how to get all the answers right in laryngeal malignancy. Okay. So most common carcinoma of the larynx is what? It is squamous cell carcinoma, which is also very common for every place, right? Most common histologically. Okay, mostly you will see patients in the age group of 50 to 70 years of age. This is the age where they will come to you. Okay, Now, what are the risk factors for laryngeal malignancy? The risk factors for laryngeal malignancy are they will have high amount of smoking, alcohol, HPV infections, if there is any radiation to the neck, if they are asbestos factory workers, cement factory workers, wood dust workers, ye sare ke sare become, but the most important is smoking and alcohol, which predominantly predominate in cases of laryngeal malignancy. Most common site for malignancy in larynx is again vocal cords or glottis. Most important point. Best prognosis. Among which of the following is the best prognosis? The best prognosis of laryngeal malignancy is for glottic carcinomas. Why? Because glottis does not have lymphatics. If the glottis does not have lymphatics, it will not spread to the the lymph nodes. And that is the reason why these are very good in prognosis. The worst prognosis is of subglottis. Why? Because it has got the highest spread to lymph nodes. And lymph nodes usually that get involved is level 4, level 5 and level 6, which are the lower nodes. And this is why this is the worst. Okay, fine. Okay, now we move front. How do we stage? How do we stage laryngeal malignancy? Not to remember anything in this, okay? I'll tell you a very, very easy way to stage. Okay? So how to stage? I'll tell you a very, very easy way. What is this? This is your vocal cord, okay? If in your questions you are told that there is a glottic malignancy only on one vocal cord, but both the vocal cords are mobile. So that is T1A. A means ache. So if there is one vocal cord has the lesion, if there is lesion on one vocal cord and both vocal cords are mobile, we call it as T1A lesion. If there is lesion on both the vocal cords, T1B, B matlab both vocal cords, but still both vocal cords are mobile, we will call it T1B. Both are mobile, both have lesion. Now let's come to T2. T2 means two subsides. Two subsides means now this vocal cord carcinoma either has gone up towards supraglottis or it has gone below into subglottis. So if there is carcinoma which has spread beyond the glottis into either extent into either supraglottis or subglottis, and now the vocal cords have become impaired in mobility. Now see the word impaired. Impaired means they are working, but they are sluggish. They are not fully working. They are working, but they are not completely closing. That is why this is called as impaired mobility. Now see the word there, impaired. And they will tell you that this place, that there is some other supraglottic or subglottic structure which has been involved here. Okay. Now let's come to T3. 3 means that now the laryngeal carcinoma has involved 4 P's. 4 P's have been involved. 4 P's means now there is involvement of pre-epiglottic space, or there is involvement of paraglottic space, or there is involvement of perichondrium of thyroid cartilage, or there is involvement of post-cricoid area. So post-cricoid means cricoid ke piche, post-cricoid, perichondrium of the thyroid cartilage, inner perichondrium has been involved, paraglottic, pre-epiglottic, two spaces of larynx, pre-epiglottic, paraglottic space. 4P. And with this, the vocal cords have become fixed. As soon as you see fixed word, your brain should run towards T3 automatically. Fixed ho gaya hai. And any of these spaces will get involved, 4 P's. Now comes T4A. T4A means extra laryngeal tissue. So that means if your question says that if there is any involvement of cancer beyond the larynx, that means now trachea is involved. What is around the larynx? Trachea is there. The cartilages of larynx have gotten invaded completely, right? There is esophagus which has gotten invaded. Trap muscles are there. Skin is there. So any of these extra laryngeal structures, if they get involved, we will call it automatically T4A. T4B means there is involvement of 3 things: PCM, prevertebral space, carotid sheath, and mediastinum. So PCM, prevertebral space, carotid sheath, mediastinum. 3 things, if they get involved, automatically T4B. Okay, fine. Now, What is the treatment according to the stages? What you will do? Okay, this is what something that I have explained you over here. If the patient has come to you in stage 1 and stage 2, stage 1 and stage 2 means still there is impaired mobility of the cord. See, now we don't operate larynx so common. Why? Because we have got very good effects from radiation and chemotherapy, where we can save the organ, right? So now if there is any stage 1 and stage 2 tumor, then we will give something called as single modality treatment. Single modality means one modality treatment. That is stage 1 and stage 2. Single modality, one modality. So either we send the patient for completely radiotherapy, that is usually done for 35 cycles. That means 5 times in a week for 7 weeks. So we have to give radiation to the patient, right? That is radiation alone. Okay. Now let's come to the second one. Second is transoral laser microsurgery. We can put a scope and we can do a laser excision of that lesion also. But again, this is reserved for cases. Mostly we give radiotherapy. Okay. Now let's come to 3. 3 means gray zone. Neither it is T4, neither it is T2. It is in between. Cords are fixed. This is the point where we do something called as organ preservation protocol. That means we will check if the larynx is functional or not. We will check if the larynx has got okay speech aspiration and respiration. If there is no problem in speech aspiration and respiration, SAR, then the treatment of choice will become chemoradiation. That means organ is still functional, we can save the organ. Otherwise, we will take out the organ, that is laryngectomy. So then speech, aspiration, respiration, everything will be an issue. But now, in this case, what we will do, in this case, if there is a kind of a good function remaining in T3, then we will give chemoradiation, first line of action. If the larynx is not functional, that means now patient is aspirating, patient is then having increased hoarseness of voice, right? Patient is having problems in a patient has stridor. In those cases, we can't give radiation to that patient as a primary choice. So what we will do something called as partial laryngectomy or transoral laser excision with neck dissection, and followed by again post-operative radiotherapy. हमें उसके बाद देना पड़ेगा so that the tumor does not recur. So either we will do partial laryngectomy or we will do again a laser excision, but we will also do a neck dissection with it because lymph nodes are common in those cases in T3 because it is advanced stage, and post-operative we have to give radiation in all stage 3 and stage 4 tumors of any head and neck place. That is called as PORT, post-operative radiotherapy. किसी भी stage 3, stage 4 चाहे जो भी place में हो, we have to give radiation in those cases. Okay, so these are the things that we do in cases of organ preservation protocol. Okay, now next आता है stage 4A. 4A means completely extra laryngeal tissues are involved. Larynx is no more functional. So here the choice is obviously a total laryngectomy, complete removal of the larynx, and we do bilateral neck dissection. Followed by that, we also give post-operative radiotherapy. That is in stage 4A. Now, what is the incision given for laryngectomy? This is what is shown here. The incision is called as Gluck-Sorensen incision. Gluck-Sorensen's incision. Okay, that's called as Gluck-Sorensen incision. Okay, fine, right? Chalo, now. Somebody is asking me about nodal staging, so I'll do the nodal staging after this. Iske baad bhi I'll just quickly finish the nodal staging also. Stage 4B. 4B ka matlab it is end stage. If the prevertebral fascia, carotid, mediastinum is involved, nothing, we can just increase the life of the patient for 5-6 months, and that is called as palliation treatment. We'll just take away the symptoms of the patient by giving painkillers, by giving good nutrition, but this is something that is we reserved it for stage 4B. Right? Okay? I'll tell you the nodal staging, very, very easy. Okay, I'll just quickly finish off the nodal staging also. Okay? Nodal staging again divided into N1, N2A, N2B, N2C, N3A, N3B. Now this is almost same for every tumor in head and neck except for nasopharynx and thyroid. They are two different, but you don't need to go into them. Usse questions nahi aayenge, but mostly isi se question aayenge, which is common for all of them, right? That is your nodal staging. Now what is N1? N1 means single ipsilateral lymph node less than 3 centimeters in greatest dimension. Let's say the tumor is on the right side, so you will have a lymph node on the right side. It is single, it is ipsilateral, less than 3 centimeter in greatest dimension. So if there is a single ipsilateral node and it is less than 3 centimeters in greatest dimension, and there is no extranodal extension. Extranodal extension means that if this is a lymph node, the tumor is within the lymph node, it has not crossed the capsule. If there is any tumor which crosses the capsule of the lymph node, then automatically this is called as extracapsular extension, yeah, extranodal extension. So that means this is a node which is single, it is ipsilateral, it is less than 3 centimeters, and it has got no extranodal extension. That is N1. Okay, one node. Now comes N2A. N2A means what? Now this node is again single, it is ipsilateral, but now it is more than 3 centimeters and less than 6 centimeters with no extranodal extension. Yani ki it has become a little larger. So let's say on the same side I got a 4 centimeter node. So 4 centimeter hai, so that means it's bigger than 3, lesser than 6, and it becomes N2A. Single ipsilateral node, more than 3, less than 6. N2A. N2B. N2B means multiple ipsilateral nodes, none more than 6 centimeters without extranodal extension. That means what? You have got multiple nodes on the same side and all of them are less than 6 centimeters. But now they are multiple and none of them are above 6 centimeters. They are all on the same side, they are lesser than 6 centimeters and they don't have any extranodal extension. They become N2B. Okay? They could be any size, more than 3, 4, 5, kuch bhi. But they are none more than 6. Could be multiple. Multiple ipsilateral yaad rakhna hai, N2B. N2C, C for contralateral. So if there is any contralateral or bilateral node, none more than 6 centimeters with no extranodal extension, it is N2C. Matlab, if suppose the tumor is on the right, node is on the left. Or if nodes are on both the sides, they are bilateral or contralateral. And no node is above 6 centimeter. We call it N2C, C for contralateral. Okay. Now comes N3A, N3B. Any lymph node, irrespective of the site, if it is more than 6 centimeters with no extranodal extension, we call it N3A. That means any node, be it bilateral, be it contralateral, be it ipsilateral, any node, be it more than 6 centimeters, automatically it upstages to N3A. And any node, irrespective of the size, if the node has got extranodal extension, yani ki even if there is a 1 centimeter node and the capsule has been broken, it will automatically upstage to N3B. So the only place where you get extranodal extension is N3B. Here the nodes, the tumor comes out of the nodes and it sticks to the underlying tissues. That is something, it is an upstage thing, we need to upstage the surgery also. So this is N3B. This finishes about nodal staging. So did you guys understand about what is the nodal staging? Right? Easy. So this is something that can come. It came in your GT. So that's why I just quickly covered it. Chalo. Finally, हम कैसे इसको rehabilitate करेंगे? How will we rehabilitate the patients of laryngeal cancers? Right? The way we can rehabilitate the patients of laryngeal cancers is by number 1, tracheoesophageal prosthesis. What is tracheoesophageal prosthesis? Is something. This is the tracheoesophageal prosthesis. It has got 2 phalanges. One phalange goes in the esophagus called as esophageal phalange. One phalange goes in the trachea called as tracheal phalange. Okay, fine. So how do you do that? So let's say this is your skin, okay, and this is your trachea. This is your trachea. Now remember, the trachea has been sutured to the skin. Remember that the trachea has been sutured to the skin, right? Because your larynx is not anymore, right? And behind is your esophagus. Behind this is your esophagus. Now your larynx is not there. But can you speak? Can you speak without the larynx is the question. Yes, you can speak, but it is because of tracheoesophageal processes. अब ये क्या होता है? Tracheoesophageal processes में क्या होता है? You can see this processes. So we will give an incision in the posterior wall of the trachea and we will insert this processes in the posterior wall of trachea between the anterior wall of esophagus and the posterior wall of trachea. यहाँ पे हम इसको लगा देंगे. Okay, this processes is placed directly inside, between the anterior wall of trachea and the posterior wall of esophagus. ठीक है? Now, what will we do? In tracheoesophageal processes, हम लोग क्या करते हैं? Burp करते हैं ना? Burp. So when we burp, we create a sound from our esophagus. Same principle हम यहाँ पे लगा रहे हैं. We are utilizing the esophageal wall to vibrate, which will create sound, and then it will be again we can articulate it with our mouth to create some speech. हमें साउंड चाहिए, साउंड हम वॉल्स ऑफ ईसोफेगस से लाएंगे. So how will we able to do that, right? We will be able to do that by one procedure. अगर ये सांस बाहर छोड़ रहा है during the time of expiration, he will close the stoma. Stoma बंद कर देगा. तो अब क्या होगा? All the air instead of going out will now get diverted through this processes into the esophagus. And when it goes into the upper segment of the esophagus, because of the pressure of this air gets vibrations. And that vibrations will come up and they will be articulated by mouth. और इससे हम speech बनाएंगे. This is called as tracheoesophageal process or tracheoesophageal speech. ये पूरा का पूरा flowchart is the same thing whatever I have told you, right? But this is how tracheoesophageal speech is there. So whenever you close the stoma, this is a one-way valve. All the air will go into the esophagus upper segment, and the upper esophageal segment will vibrate. It will create a burp-like sound, and that sound will be articulated by mouth, and that is called as tracheoesophageal speech. Okay, so this is what you should know. The other name for this processes has been asked once. It is called as Blom-Singer processes. Blom-Singer processes. Okay, fine. एक और तरीका है, and you must have seen this device. Okay, I was fortunate enough to have or to take an interview of one of those people who is the longest laryngeal cancer survivor for 25 years, and I interviewed him, and he's the one who's been mastering this speech. Ab he's a TEDx speaker. Can you imagine a person who doesn't have a larynx is a TEDx speaker, and he actually speaks with this electrolarynx. I interviewed him some time back, and he gave the whole interview with this, and he just puts this electrolarynx and he creates speech. It is a little robotic speech, but what happens is when you keep this over on this area, on the submandibular area, you push the button. So it creates a lot of vibrations in your mouth, and that vibrations create a robotic kind of speech. So person is speaking without a larynx. That is how magical head and neck surgery has become in today's time, right? So if you get any kind of a handheld device which is kept over here, the answer is this is called as electrolarynx. Okay, this is another way. चलो, last part of today, और ये एक चीज है जिसमें बस मैं एक ही चीज बताऊंगा, because rest of the things I hope you guys don't require as of now. एक चीज मैं बताऊंगा कि what is the levels of tracheostomy और high और mid और low tracheostomy क्या होती है, right? So let's say this is your cricoid, this is your trachea, right? So on the basis of level of tracheostomy, we have got something called as high tracheostomy, mid tracheostomy, and low tracheostomy. Okay. If we do the tracheostomy at the level of first tracheal ring, यहाँ पे करा, then we call it as high tracheostomy. Very important question that has been asked to you all throughout is that only indication of high tracheostomy is total laryngectomy. Why? Because I told you that in cases of total laryngectomy, we need to save as much trachea so that we can suture it to the skin for a permanent stoma. So for that, we do a high tracheostomy so that we can save as much trachea possible. So high tracheostomy, the indication is total laryngectomy. In normal cases, we do mid tracheostomy between 2 to 4th tracheal ring. If we do it more than 5 tracheal rings down, it is called as low tracheostomy. If we do a high tracheostomy, what is the complication? If you put the tube over here, it can rub the cricoid cartilage and it can lead to cricoid chondritis. Cricoid chondritis. If we do a low tracheostomy, what is the most common complication? There is apex of the lung over here, right? There is apex of the lung over here, so we can injure it, and that will lead to pneumothorax. So most common injury in cases of low tracheostomy, pneumothorax. Most common injury in cases of high tracheostomy, it is cricoid chondritis. That is why we do it in between 2nd to 4th tracheal ring. That finishes our huge marathon for today. I hope you guys have enjoyed it, and I hope you guys have taken something from whatever aspects of ENT. We went on from otology, we went to rhinology, oral cavity, then pharynx, सारे parts of pharynx, and finally larynx. This was a huge one run through, and I am very happy to see all of you still watching this. I think it's been almost 6 hours to us being together, right? And I thank you all. I wish you all the very best. Keep sprinting like this, right? Keep sprinting, and this is something which we have created this only for you. So just keep going, right? Just keep going, and don't worry about the results. Okay, don't worry about what will happen. बस करते रहो. Give your best. Don't worry about what will happen in the next stage. आप अपनी तरफ से best दो, and just have a good time, great time after your exams finish. Okay, fine. Thank you so much, guys. Thank you for so much of love that you have given. And if you have any problems, you can message me over the Telegram group. You can message me over on Instagram, over on my WhatsApp. So any place I'll be available, right? So you have got anything, whatever you have, don't keep any doubts. Ask before you go for your exams. Okay, fine. So you will all come out with flying colors. I'm very sure. So that you don't worry. You will definitely do well. But results के बारे में मत सोचना, टेंशन मत लेना. That is something which spoils out a lot of results. तो टेंशन लेने की जरूरत नहीं है. Do your best. सब बढ़िया है, सब आता है. जितना आता है सब निकाल के देखो and try to exclude options. नहीं भी आता कोई क्वेश्चन, try to exclude it out. ABCD में कहीं ना कहीं कुछ ना कुछ you will know. So you will try to exclude it out कि क्या होगा. Right? Okay. चलो. So thank you guys and good night. Good night to all of you.